गणनाथ सिन्धूरवण करुणसागर करिवदना लम्बोदर लकुमिकरा अम्बासुत अमरविनुत लम्बोदर लकुमिकरा सिद्धचारण गणसेवित सिद्धिविनायक ते नमो नमो लम्बोदर लकुमिकरा अम्बासुत अमरविनुत लम्बोदर लकुमिकरा सकल विद्या आदिपूजित सर्वोत्तमते नमो नमो लम्बोदर लकुमिकरा अम्बासुत अमरविनुत लम्बोदर लकुमिकरा.
That was my daughter Anisha Arvind singing the Ganesha Stuti. So good morning everybody. At the outset, I welcome all of you for our ADC International Virtual Diabetes Summit 2022. We are starting the second day with the much awaited postgraduate program. Every year we do this postgraduate program, and it has become widely popular, and many postgraduates are willing to attend this particular program. And our quiz master is Dr. Vishwanath from Ramaya Medical College. He is always kind enough to coordinate the PGs and organize the things in a very well manner. He is the professor, Department of Medicine, MS Ramaya Medical College. He is the honorary secretary of API India Karnataka chapter. He is actively involved in PG and UG teaching. He worked as a principal investigator for many clinical trials and research projects. His field of interest is diabetes, medical legal law, and infectious disease. To judge this particular session, we have two eminent personalities. One is Dr. Shrikant Hegde. He is a consultant physician, Shimoga, since last 28 years, and former vice chairman, APA Karnataka chapter, a avid photographer, and a very passionate academician. And Dr. Murali Mohan is MBBS MD MRCP. He is a senior consultant pulmonologist and academic director of Department Internal Medicine and Pulmonology at Narayan Hrudayalaya, Bangalore. Sir is a very active academician, and both Dr. Shrikant Hegde and Dr. Murali Mohan are being a part of our conference PG program symposium, and they are the judges for us since 3 years. And to our honor, Dr. Meena Chabrai from Delhi. Madam is the chairperson for the quiz program. She is a senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi. Since last 2 years, she is being a part of our program, and she is chairing this particular postgraduate symposium. Thank you, judges, and thank you, chairperson, for being a part of it. And thank you, most important, thank you, Dr. Vishwanath. Over to you for further proceeding. We'll be strict at time. We'll finish by 9:55. Over to you, Dr. Vishwanath.
Yeah. Can I just add, Dr. Arvind?
Yes, sir.
Most appropriate to this program, Dr. Shrikant is the new chief editor for the Journal of the Association of Physicians, Karnataka.
Congratulations, sir. Congratulations.
Yeah, good morning, sir. Thank you for that kind introduction. And always I look forward when we conduct this PG program. Maybe since last 2-3 years, especially with Dr. Meena and Dr. Murli Mohan, Dr. Shrikant, it's more learning for us. I always look forward to it, especially their comments at the end, the way they, advise the postgraduates on how to go about, whether it was pedagogy last year, before that case presentations, a lot of, we learn a lot. It's postgraduate presentation is there, but at the same time, I think it's a learning curve for us. So we can start the program, Dr. Arvind. I think,
yeah.
As Dr.
It's live.
Shrikant has
It is
already
live.
told,
It's live in YouTube and Facebook also. So you can start.
Okay, yeah. So marking will be for 20 marks to it. I think 5, 10, and 5. That's what Dr. Shrikant has told. So the presentation, critical analysis, discussion. So that will be totally for 20 marks. Initially, I request Dr. Pragya, the JSS team, to start the first. And all of you have got very good articles. That doesn't mean that we have to critically analyze, just exercise. So that's what I was discussing with Dr. Murli Mohan and Dr. Shrikant Hegde, that these are all very reputed journals with standard articles. Going through them itself is a learning curve. So I request Dr. team from JSS to start the proceeding.
Yes.
Yeah, can you upload?
Yes, one.
Yeah. So they are going to analyze on this primary statin as a primary prevention. So no, of course, we always know that secondary prevention, there is not much doubt, and people this one. But when it comes to primary prevention and statins, so that's what they're going to take us through. Okay, this is the article that we had given to them. Over to you, Dr. Pragya and Dr. Ashika. Both of you can answer. One of you can present.
Okay. Good morning to all the dignitaries. Thank you for giving us this opportunity. Now, this is Dr. Ashika and Dr. Pragya, postgraduates from JSS Medical College, Mysore. Now, we will be critically reviewing an article which was published in JAMA Cardiology. The article is the statin used in primary prevention of atherosclerotic cardiovascular diseases, according to 5 major guidelines for sensitivity, specificity, and number needed to treat. Abstract. This study was published in 2019 in JAMA Cardiology. The study aims to bring a light to the commonly encountered conundrum among the clinicians. Statins are the wonder drugs with pleiotropic effects, not only for the patients, but also for the pharmacological industry, and studies based on these drugs are replete for funding. Among a spree of guidelines available today by affluent medical bodies across the globe, a study of this kind may aid in decision-making for the clinicians. The abstract explains the crux of the article adequately. The clinicians will be greatly benefited by a head-to-head trial of these guidelines. The aim of the study claims to be a first of its kind, head-to-head comparison between the 5 major guidelines for statin use recommendation. The main aim of this study is to compare which of the 5 guidelines was best able to identify at-risk population for initiation of statin therapy to prevent a maximum number of atherosclerotic cardiovascular events. The main statistical marker used in this study is number needed to treat. The study population was Danish population cohort, which was studied over a period of 10.9 years. The age group which was included in this study was 40 to 75 years, and a total patient load of 45,750 patients were included. The people were recruited randomly through Danish civilization registration system. Exclusion criteria which was used in this study was appropriate. Because the population database of Denmark is inclusive and each citizen is uniquely given an identification number, the study claims to have followed up with all these people who were enrolled in the study till the end of the study. The study was done on an adequate number of patients. The data collection appears to be impeccable with 0 loss to follow-up, as the Denmark population is assigned a particular number and uploaded to a system database such that any event would be recorded and none would be go missing. However, the author do point out that certain factors such as chronic inflammatory conditions, premature menopause, or preeclampsia, which would affect the atherosclerotic cardiovascular disease events, were missing from the data system and so from the study as well. The guidelines used in this article were UK NICE guidelines, which use a scoring system of Q risk criteria, and US Preventive Services Task Force guidelines, which use pool cohort criteria, and AHA guidelines also use pool cohort criteria. The Canadian Cardiovascular Society guidelines use Framingham risk score, and European Society of Cardiology use score criteria for assessing the risk of statins. The baseline characters used in all these groups of population were almost equal, and they were comparable with respect to diabetes, population size, and plasma glucose concentrations, diabetic people, and LDL cholesterol levels, except that in European Society of Cardiology, the number of male patients was 2,547 when compared to rest populations, which was around 9,000 to 11,000. And smokers were all equal in all the studies, except that in European Society of Cardiology, smokers were very less. It was 1,942, which would have altered the results of the study when compared to the other population groups. However, the study is restricted to single ethnic group, that is Danish population, and which cannot be extrapolated to the other ethnicities. Although the study population was matched based on diabetics, non-diabetic smokers, and non-smokers, they did not take into account the HbA1c levels and the number of years a person has smoked, which would affect the atherosclerotic cardiovascular disease risk. The authors have also pointed out that ability of the guideline itself to assess the risk and correctly assign the statin therapy was not compared properly. Therefore, it may be beneficial in the future studies to assess the accuracy of this risk scores, that is, a Framingham risk score or pool cohort with on head-to-head comparison before assessing the guidelines. Interventions and variable response. The intervention used in this study was assigning moderate to high dose statin therapy for primary prevention of atherosclerotic cardiovascular diseases. The study applies 5 major guideline criteria on the population randomly to decide when to start statin therapy for the patient in each of the 5 groups. The ultimate aim being to decipher the number needed to treat to prevent one ASCVD event among the chosen population. They also said that a reduction of cholesterol by 38 milligrams per deciliter would reduce the relative risk of ASCVD by 25%. The outcome was calculated at the end of 10.9 years. Methods used were the study followed up the individuals from time of participation in the population study until one of the following event has occurred, either atherosclerotic cardiovascular event, death, emigration, or end of follow, which was done till December 7, 2018. The statistical analysis used in this study was adequate. They have calculated 10-year atherosclerotic cardiovascular risk using the above mentioned risk scores for each and every guidelines. They also compared the clinical performance of the 5 guidelines. They have calculated the sensitivity and specificity overall and as well as 5-year age groups for atherosclerotic cardiovascular disease events occurring during the follow-up in those respectively with and without statin eligibility criteria. The third was to estimate the number needed to treat in 10 years to prevent one ASCVD event to statin assignment according to the each and every guideline that they have given. Results will be discussed by Dr. Pragya.
So I'll be discussing about the results obtained from the study. The study observed a total of 4,156 ASCVD events across all groups. The statin eligibility was highest. In the study, it was found out that according to the risk stratification criteria of various guidelines, they found that the maximum sensitivity or the likelihood of a guideline to pick up a person who needs statin therapy was seen maximum with the AHA guidelines, which was followed by the CCS and NICE guidelines. Whereas specificity, which was to rule out a person who may not require the statin therapy at all, was highest for ESC guidelines. That means overprescription would be likely better avoided by the ESC guidelines according to the study results. So this is just a tabulated form to explain again that the sensitivity was found to be highest among the AHA guidelines, which was almost 70%, which came at a cost of specificity because they were using liberal guidelines to administer statin therapy to the patients. However, when compared with the ESC guidelines, ESC guidelines had a much lower sensitivity because they use more stringent guidelines to prescribe statins, and therefore allocating a better specificity to the ESC guidelines. However, there is a confusion here in the sense that the number needed to treat does not differ in spite of sensitivity and specificity being different for various guidelines. That although ESC may miss a lot of people who may require low-risk people or medium-risk people who may require statin therapy, the number needed to treat in the ESC guidelines remains same across the moderate and high-risk group when compared to the other guidelines. So this result has to be evaluated further and the discrepancy needs to be further analyzed. So the term of the follow-up is adequate as most risk assessment scores give the risk over a period of 10 years. Although in a study where we're evaluating atherosclerotic cardiovascular risk disease, we would like to evaluate the patients for a longer period of time, but the study could not do so, and rightly so, because they were only evaluating the risk assessment scores, which naturally provided only for 10 years. The assumption of reduction of cholesterol and its corresponding ASCVD risk, which was used in the study, such in that they assume that if they were able to reduce 38 milligram per deciliter cholesterol in a patient, they assumed that 25% ASCVD risk would be reduced with the patient. This extrapolation was made from a well-established meta-analysis published in the Lancet journal, and it appears to be adequate. The authors do not mention, however, the method of LDL cholesterol assessment, how frequently the follow-up was done, and whether there were any interlaboratory variations in the measurements of cholesterol. They also do not clearly mention which statin was used in the study. The authors seem to be aware of the potential drawback of using number needed to treat as a method to compare among these groups. This is because at the outset only, when comparing these guidelines, the AHA guidelines are more liberal. So they would prescribe statins to a lot more number of people, which may not develop an ASCVD at all. This means that at the onset, it was likely that the AHA guidelines would have a higher number needed to treat than the other guidelines, the more stringent guidelines. But this result was not achieved in the study. And this was also an apprehension in the beginning of the study, where the authors were discussing among themselves that what if the AHA guidelines number needed to treat is a lot higher, and that therefore the specificity and the utility of these guidelines may be diminished because of this result. However, this result was not achieved by the article. This is why the authors have also tested for sensitivity and specificity of these guidelines. As the guidelines for age are different in the ESC guidelines, which includes 40 to 65 years of age, whereas the others go for 40 to 75 years of age, it is a plus point that the article has evaluated amongst two different age groups for various guidelines. And the number needed to treat to prevent one ASCVD was found to be similar across all guidelines, which was a surprising outcome as explained earlier. The study concluded that while the AHA and the NICE and the guidelines would end up treating more people, they would also target statin therapy to many more of the individuals who developed ASCVD, not only to the low risk people, they would end up prescribing more statins. This was also applied to the people who needed statin. More number of people who needed statin would end up getting the statin treatment. As a result, more ASCVD events are prevented by the CCS, the AHA, and the NICE guidelines. But we have to take this with a pinch of salt in the sense that the authors assume that the overprescription of statins come with no harm and no cost burden to the society. As we know that overprescribing drugs may not only increase the pill burden for the patient, it may also increase the drug-to-drug interaction, and the larger number of population treated may even unfold higher number of side effects with the drug. Another commendable analysis done by the authors is the evaluation of not only class 1 strong recommendations which were given by various guidelines, but also subclasses such as class 2A and C guidelines, recommendations for statin therapy. And these were separately evaluated, which is a plus point in the study. However, the authors do mention that in itself, the Denmark population, the Danish people, have been categorized as low-risk population when compared to the rest of the world. And Asia being a high risk for ASCVD, how similarly these results can be replicated in this side of the world.
Summarize the well.
Yes, sir.
Yes.
So coming to the pros and cons of the study, sir. The study pro is that it's a first of its kind. The sample size is adequate. The source of data is impeccable with no loss to follow-up. It is adequately matched for age, cholesterol, BP matching, and diabetes. However, the cons were that the study is restricted to one single ethnic group. The drugs used were not really mentioned. The number of males and females were not matched properly among all groups. Other drugs such as antihypertensive, which were used, were not accounted for in the setting of the results. And it promotes overprescription of statins, assuming that there is no side effect. The results were not comparable with RCTs for statins done previously. So the statins, RCTs that were done, they gave a number needed to treat which was much higher, around 60. Whereas this study gives a number needed to treat which is much lower, which in by itself, the study is saying that statins may even have given better results with this study itself. So this needs to be, RCTs being superior to cohort studies, we need to evaluate this further. And data needs to be replicated in future studies, and this study is not a global study.
Thank you.
Thank you,
Sir.
Yeah. And congratulations to both the participants. It was an excellent analysis of the study. I think I'll give you full marks for the analysis.
Thank
Because, but one thing I would like to ask you is, what you mentioned that the authors did not mention about the drug statin used and the antihypertensive. Remember, the authors did not put the patients on any medication. They just analyzed whether who are the eligible population, whether by comparing different guidelines, the 4 or 5 guidelines they analyzed, and if you apply this guideline, how many patients will be eligible for statin use. The second guideline, so many, they're given the chart 15,000 with one guideline, 12,000 with one guideline. The main thing they conclude is that even though some of the rigid statin guidelines like European guidelines have the same number needed to treat as that of the liberal guidelines like the AHA guidelines. So the authors mean to say that when you have, even though you give more statins, more population, the number needed to treat would be still same, and you would be saving more number of lives. They also accounted for the adverse events. They also commented at some point, they also comment about the new diabetes developing in statin population. So they say it is similar or it is much less than the benefit. So excellent analysis. Dr. Murali Mohan, sir.
Sir, you are muted, sir.
Dr. Murali Mohan.
Dr. Murali, you are muted.
So sorry. Yeah, I think that's an excellent analysis by both the participants. The initial part where the study design was spoken about, and later the there is an analysis of the results was excellent. So outstanding. I think you all have understood the study well. As Dr. Srikanth was saying, this is very different from most other studies where we usually analyze drugs, whereas here these people have looked at the guidelines and compared them rather than the drugs themselves. But I had a couple of questions for you. You know, whenever you analyze a study, you want to know how it's relevant to you, to your population. So unless you're going to Denmark, do you think this is useful or not? In the Indian context, is there something you'd particularly like to comment about this? You did mention something briefly. I want to hear a little more about, are any of these guidelines adapted, or, do they have criteria which bring in the race factor into it?
So the QRIS criteria, which was used by the AHA guidelines, does account for the race. Framingham criteria also does account for race, but how replicable these data will be in our Indian scenario cannot be extrapolated just by the Denmark population, how beneficial it will be, the percentage of benefit offered by these drugs. So this needs to be replicated in the Indian data, and then only we can start applying this to our population confidently. So
is there a difference in risk between the Danish population and an Indian population, for example?
Yes, sir. The authors themselves have actually mentioned that according to the WHO, the Denmark population has actually been categorized as low risk for atherosclerotic vascular disease, whereas the Indian population is actually at high risk because we have higher number of diabetes, metabolic syndrome, which leaves us more at risk for these things.
And is the race assumption different for example, the Framingham and the QRIS 2, which we now use the QRIS 3, but the study came out before the QRIS 3 scores came out. So is there a difference?
Sir, I am not aware of the race difference.
Okay, so the Framingham test is white and non-white populations, whereas the QRIS specifically includes an Indian population, or Indian and Pakistani, a South Asian population. So it's even more specific for us. Yes, we recently completed a study where we showed the QRIS 3 is probably the best for us in predicting outcomes. Other question I had, do I have time to ask one more question, Dr. Krishna?
Yes.
Madam?
Yeah. Ashika, you on the video, please?
Yes, sir.
Yeah. So, we spoke about the harm that any drug does, and we always like to do a risk-benefit analysis. You spoke about the number needed to treat. Is there any assessment of how many people will get harmed by drugs?
So the actually number needed to treat can also be correspondingly evaluated with number needed to harm as well. That analysis was not done in this study. That should have been done, sir.
Excellent. Okay. I think that's only questions I had. Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.
I think we can go to the next presentation.
I request Dr. Megha from BMC, BMCRI to start her presentations.
On your videos and present, please.
Please.
Yes, sir. So am I audible?
Yeah. Sure.
Video.
Video. Good morning, respected judges and my dear colleagues. Today, I'm Dr. Megha and this is Monica, and we're from BMC. We'll be presenting a critical appraisal on the article Percutaneous Coronary Intervention versus Coronary Artery Bypass Grafting for Severe Coronary Artery Disease. This is an article published in the New England Journal of Medicine in March 5th in 2009. The study design being that was a prospective, multi-center, multinational randomized clinical trial. It was conducted in the US and in England. The authors were Patrick W. Series et al. It was conducted over a period of 12 months, and the patients were studied over a period of 12 months. Just going through a pre-checklist before we go to the actual clinical appraisal of the article. Background here being that PCI is a minimally invasive non-surgical procedure performed to improve blood flow in coronary circulation. CABG at that point was historically the treatment of choice for complex coronary artery disease, that is, coronary artery disease with triple vessel or just left main coronary occlusion. However, newer drug-eluting stents were increasing in popularity for the management of this condition. CABG remains the treatment of choice for patients with severe coronary artery disease, including those with triple vessel disease and those with left MCA. There was lack of data from randomized trials of PCI in such patients, and that's why this study was done. So coming to the PICO statement, the research question they proposed was, in patients with de novo complex coronary artery disease, is PCI with drug-eluting stent, in this study the drug used was paclitaxel, superior to CABG in preventing major adverse cardiac and cerebrovascular disease? So they included patients who had previously untreated lesions more than equal to 50% target vessel stenosis with stable or unstable angina or atypical chest pain. If they were asymptomatic, ECG considerations were taken. ECG changes were taken into consideration along with CKMB laboratory investigations. They excluded patients who were previously had interventions, who had an acute myocardial infarction, or who had other concomitant surgeries. So the primary outcome they studied was a composite endpoint of major adverse cardiac or cardiovascular events during the 12-month period, which included death from any cause, death from stroke or death from MI, or chances of repeat revascularization at 12 months. So some of the secondary outcomes that they did study was overall major adverse cardiac and CVA cerebrovascular outcomes at 1 month, post-procedure, 6 months, 3 years, and 5 years post-allocation. And they even studied each individual component, that is cause of death being stroke, documented MI, or repeat revascularization. They also took into consideration quality of life at these endpoints, though they haven't mentioned these in the main article, cost and cost effectiveness, and their other outcome that they were studying was the SYNTAX score, which is a score which takes into consideration the anatomical coronary variations in different patients and how these procedures will impact those patients. So they concluded that CABG remains the standard of care for patients with 3-vessel or left main coronary artery disease, since the use of CABG as compared with PCI resulted in lower rates of the combined endpoint of MACCE. So coming to our appraisal itself, first we looked at the internal validity. So how well was this study designed was our first question. So it was a double-blinded randomized control trial with a measurable outcome. So the measurable outcome was the major endpoint, that is deaths, as well as the rates of revascularization. So this, according to us, is a solid outcome that they looked for. It was, the randomization was in a 1:1 ratio, and even though there was a rate of attrition of 6.7%, they did preserve randomization with by doing an intention to treat analysis. So this is how the baseline characteristics looked after they randomized. So 1,800 patients were randomized into two groups, that is PCI or CABG. 903 patients were in the PCI group, and CABG had 897 patients. All the characteristics, age, sex, BMI, their previous comorbidities, there is diabetes, metabolic syndrome, their smoking history, they all were equal between both the PCI and the CABG groups. However, we would like to point out that there were few differences. First, with respect to the procedure itself. Obviously, with coronary artery with CABG, the procedure duration, the time to procedure, post-procedure, hospital stay, and complete revascularization were different due to the procedure itself. And some of the other differences were that the PCI cohort had a larger proportion of patients with blood pressure of more than 130/80, whereas the CABG group had a higher proportion of patients who were current smokers or who were dyslipidemic, so both triglycerides and low HDL. With respect to treatment, as I already explained, CABG group had a longer time to procedure duration, and a post-procedure hospital stay. Also, higher proportion of patients had complete revascularization after CABG. One other difference that we observed in the 12-month period was that the CABG group received less pharmacological treatment compared to the PCI group. So aspirin and the thienopyridines, both of these drugs were prescribed lesser to the CABG group compared to the PCI group. So summarizing the internal validity, we think it was a well-conducted trial. However, randomization has not been adequate in terms of few baseline characteristics, which might have had a small impact on the ultimate results. So coming to the results itself, just a reminder that this is the syntax trial, which was designed to compare the current surgical and percutaneous techniques in patients with complex coronary artery disease. So our primary endpoint was the major MACCE after 12 months after randomization. So here we see that the relative risk with PCI with a confidence of 95%, with a 95% confidence interval was 1.44. So the range was 1.15 to 1.81. So with this, we can conclude that CABG was definitely superior with respect to the major adverse cardiac or cerebrovascular events. PCI caused more of these events, so more harm than benefit with when it came to the PCI group. So the secondary outcomes, some of them that they've mentioned here. Death from cardiac causes. Again, the relative risk here is 1.75, and the the MI rates were 1.46. So that is also significant. That is, the PCI group had higher death from cardiac and a higher rate of MI. However, one difference with the CABG group was that they had a higher rate of stroke. That is, the relative risk here was 0.25. This could be because of the differences in pharmacological treatment. That is, the PCI group got more dual antiplatelet therapy compared to the CABG group. So this is what we were talking about. The PCI group got around 95% of them were on aspirin at the end of 12 months, and 71% of them were on any one of the thienopyridines at the end of 12 months. However, CABG, we can see at the end of 12 months, only 84% were on aspirin, and just 15% of them were on thienopyridines. So these are the Kaplan-Meier curves which show the outcome. The first image here shows us the primary endpoint that the trial looked for. So we can see that the PCI group definitely caused more of these events compared to the CABG group. Another significant difference between the two groups was repeat revascularization. So PCI definitely had higher rates. I mean, they needed more more of them, a higher percentage of them needed revascularization at the end of 12 months. However, this revascularization didn't seem to have an effect on death. So death from any cause and the composite death from any cause, stroke or MI, they had similar rates in both CABG and PCI groups. So one more secondary outcome that we pointed out was the syntax score. So they also took into account syntax score.
And 1 minute left.
Sorry. Okay, I'll hurry it up. So higher syntax scores had it means that they had a higher complex coronary artery disease. So they concluded that PCI should be avoided in patients with high syntax scores. So results of this study can be applied to the general population. However, we wanted to point out that in the Indian population, further studies are needed to solidify these results. As Divya Arket et al. Pointed out that the dimensions of the coronary artery segments of Indians were smaller. So cost effectiveness, CABG is significantly more expensive than PCI with drug-eluting stents. So invasiveness of CABG is also a significant factor. We feel that all relevant clinical outcomes were studied in this study. And since they did a multi-center trial, the chance of beta error, we feel, may have been low, even though this decreased the external validity. So we couldn't extend that into our Indian population as well. So just as an addition, syntax trial actually went on till 5 years after and 10 years after as well. So at 10 years, they still found no significant difference that existed in all-cause death between PCI with stent and PCI with drug-eluting stent and CABG, and that CABG provided a significant survival benefit in patients with triple vessel disease, but not in patients with LMCA. So that is still an area of deficit where more. So from this study, we conclude that CABG is the choice of treatment for complex coronary disease. Thank you.
Thank you. That was an excellent analysis. You have presented the data well. When was the study conducted?
So this was in 2008, sir.
2009. 2008-9. It was published in 2009.
Yes,
2 points I would like to differ is, one, you mentioned that it is they tried to test the superiority of PCI over CABG. It's not the case. They tried to assess the non-inferiority of PCI over CABG. That is one. The second thing is, this is not a double-blind control trial, because both were known. The investigators and the patients were aware of the procedures. Only at the time of allocation, they were blinded. Which patient will receive which treatment, they were blinded. So once the treatment started, it was not a blinded study.
Okay, sir. Okay.
That is all.
Yes, sir.
And why can this be applied to Indian population or our population? So this study, and if so, or if not, why?
So we feel
what are the ethnic groups studied in the?
So it was the Caucasian population. So the Asian population was not included.
Not in. Yes.
I think by and large, looking at just the baseline characteristics, we can extend this. But how it differs with respect to race is something that is still up for study. But we did point out that there's an anatomical difference. So
yes.
We
the
can.
Second thing is, the mean age for the participants in this study is around 65 years. Whereas in India, the mean age of onset of IHD or CAD is much lower, at least a decade lower than the Western Caucasian population. So at that age group, whether ABG or PCI, it needs to be studied by an independent study conducted in this population. That is one.
Yes.
Sir.
Thank you. I actually had exactly the same questions as Dr. Srikanth. So I'll just ask one more in addition to that. I'm going to quote from my personal experience. I've had a PTCA done and a stent put in. What I want you to tell us is, what is the quality of life after CABG as compared to after PTCA? One, the major difference was in the stroke outcome, which, the authors and you attributed to the greater pharmacological use. So I want you to tell me, which would be preferable, having a revascularization event or having a stroke? Which do you think patients would prefer? That's not been addressed in the study.
Sir, if the patient opts for PCI, the chances of repeat revascularization is more. So patient has to undergo multiple procedures. So, but the stent, in CABG, the occlusion chances are less. So it can be a one-time procedure. However, but the invasiveness of CABG is again adds to a negative point to the patient.
Peri-procedural adverse events, mortality, all will be higher with CABG. Quality of life with CABG will be decreased in the first year after the procedure. However, it will be almost normal compared to PCI post-procedure. Post that recovery period.
Sir had a very interesting question. Will the patient choose a stroke? He's the patient here. Will he choose a stroke or will he choose a revascularization procedure? So stroke was higher in which group, and where was revascularization higher is what sir is asking.
Stroke was higher in CABG group, ma'am. However, revascularization was higher in PCI group.
So nobody wants a hemorrhagic stroke. You will be. So that is
that surprised me actually. One of the risks of having dual antiplatelet therapy is a higher risk of bleeds.
So, hemorrhagic stroke.
Yes, exactly. And that's worrying. So
revascularization.
Yes. So that is what sir is asking. Will you choose a stroke over a revascularization procedure? So anybody would choose a revascularization procedure.
Yes, ma'am.
Also, when you say that,
Another limitation is the follow-up was only for 1 year.
1 year.
Most of the events happen beyond 1 year.
Yes,
so the study did not address what happens later. You mentioned about the 10-year follow-up later, but the original paper as such didn't mention that. It's a different paper. Even at 2022, the recent trial published proves that CABG is better than PCI in the similar situations.
Yes.
So the fact remains the same. But the question is, who are the patients who are likely to be more benefited by PCI versus CABG?
The ones with higher syntax score, that is more complex coronary artery disease, were more beneficial with CABG than PCI.
Okay. Thank you. That was a good presentation.
Excellent analysis. Thank you. And good handling of the questions also.
Thank you. So we move on to the next team, that is from Sri Devaraja's Medical College, Dr. Sujita and team. Can you please start your presentation? Prabhakar sir has also logged in. Welcome, sir.
Prabhakar sir is a very caring, head of department, professor. Yeah. He's logged in.
Okay, you can start, Dr. Sujita. You can start. It's visible.
Am I audible, sir?
Yes.
Yeah.
Yes.
Today my topic is critical appraisal for comparative effectiveness of aspirin dosing in cardiovascular disease. I'm Dr. Kavya BK and Dr. Sujita from Sri Devaraja's Medical College, Kolar. So this article was taken from the journal New England Journal of Medicine, published on May 27th, 2021. The study design was an open label study. It was a multi-centric study and a randomized control trial. The authors were W.S. Jones, H. Mulder, and L.M. Rupp and et al. Study period was from April 2016 to June 2019. It was conducted for a period of 24 months. So coming to the introduction, atherosclerotic cardiovascular diseases contribute to the world's largest disease burden and are leading cause of morbidity and mortality. Aspirin is recommended in patients with established atherosclerotic cardiovascular disease to lower the risk of adverse health outcomes. The appropriate dose of aspirin has always been a subject of controversy in these patients. So the objective of my article was to determine the optimal dosage of aspirin to be used for secondary prevention of atherosclerotic cardiovascular disease. So inclusion criteria, they considered patients with prior myocardial infarction, prior coronary revascularization procedure like percutaneous coronary intervention or coronary artery bypass grafting surgery. Also, the patients who had prior coronary angiography demonstrating around more than 75% of stenosis of at least one epicardial coronary artery, and who had an history of chronic ischemic heart disease or coronary artery disease or an atherosclerotic cardiovascular disease event. So the exclusion criteria they considered in the study was history of any significant allergy to aspirin, history of GI bleeding within the 12 months, bleeding disorder that precluded the aspirin use, or current or planned use of an oral anticoagulant or ticagrelor, and female patients who were pregnant or nursing were excluded from the study. So coming to the methodology, the study was done in 40 centers in the United States using an electronic health recorded data. So these data, they collected the information of patients who had already been diagnosed as atherosclerotic cardiovascular disease, baseline demographic and clinical characteristics like age, sex, race, ethnic group, smoking, previous antiplatelet usage were considered. So based on the article, this was the consideration based on the demographic details. So the median age group taken in this study was around 60 to 70 years of age, and it was seen more in female population. A median weight was around 90 kgs, and it was seen more in whites rather than black population were considered. And medical history of previous myocardial infarction, previous coronary revascularization were taken, and comorbidities like hypertension, dyslipidemia, diabetes mellitus, atrial fibrillation, congestive heart failure, previous chronic kidney disease and peripheral artery disease, previous clinically significant GI bleeding, previous intracranial hemorrhage were considered in this trial, and smoking was taken as a risk factor in this trial. And an aspirin use before the trial was also considered in these patients, because they didn't exclude these patients from the study. So this is a limitation in this study. So a patient who had an aspirin use of 81 mg, 162 mg or 325 mg before the onset of the trial were also considered in this study. The patients were randomly assigned in 1:1 ratio to receive a once daily dose of 80 mg, 81 mg or 325 mg of aspirin by a web portal, which was an internet-based portal. Patients were also randomly assigned in 1:1 ratio to follow-up visits every 3 or 6 months to better understand the effect of the frequency of clinical trial assessment on patient engagement and follow-up, adherence to the drug, recent hospitalizations and outcomes like primary and secondary were assessed based on the follow-up visits. So coming to the study outcome, there was primary outcome. The primary effectiveness outcome was the time to the first occurrence of any event, which included death from any cause or hospitalization secondary to myocardial infarction or hospitalization secondary to a stroke or a transient ischemic attack. The secondary outcome from the article included coronary revascularization procedures like percutaneous coronary intervention or CABG. And primary safety outcome, which they assessed in the article, was to assess for any major bleeding event which required major blood transfusion. So this was the graph which shows the dosages based on the aspirin dose of 81 mg and 325 mg. And the months of follow-up, they considered around 24 to 42 months. This did not show any significant difference, meaning the dosage of both 81 mg and 325 mg of aspirin had the same risk of death or hospitalization for MI or hospitalization of stroke in this study. So coming to the safety outcome, even the safety outcome was the same. The hospitalization for major bleeding event or major blood product transfusion occurred in 53 patients, and the risk was the same in both the groups of patients. That is, with 85 mg or 325 mg, it was the same. So the death from any cause occurred in 315 patients in the 81 mg group or 325 mg group of aspirin. Hospitalizations for myocardial infarction and stroke and the key secondary outcomes were similar in the two groups. Mean scores for the patients' reported outcomes measured were similar in both the groups at the baseline and at the time of follow-up at around 3 to 6 months. In this trial, there was no any significant difference noticed in the effectiveness or the safety outcomes between the strategy of 81 mg of aspirin daily or the strategy of 325 mg of aspirin daily. So that coming to the limitations of the study, it was an open label design, which did include blinding. Inclusion of patients who primarily took aspirin was considered before the trial. Patients commonly switched their randomized dose between 81 mg and 325 mg based on clinician biases and perceptions about the relative risks and benefits of aspirin dosing may have led to the dosage changes over time. This could be a part of bias in this article. So coming to the internal validity, patients to the treatment were randomized at the beginning of the study. Groups were different at the start of the trial. Like they considered a group of aspirin of 81 mg and group of 375 mg were considered differently. And the groups were treated equally apart from the intervention. The other tests and the risk factors which were considered were treated equally in both the groups. All the patients who entered the trial had a loss of follow-up, which was less than 10%, which was only 7 to 11%. Plus, it was an open label study. So this was the validity from our article. So the conclusion from the above study, in this trial, there was no any significant difference noticed in the primary effectiveness or safety outcomes between the two aspirin dosage strategies among patients with established atherosclerotic cardiovascular disease. A strategy of 81 mg per day aspirin had similar effectiveness as 325 mg of aspirin in patients with established atherosclerotic cardiovascular disease. And long-term adherence was better with 81 mg of aspirin compared to 325 mg dosing strategy. Thank you, sir.
Thank you.
Well presented. A good study. What do you think is the striking difference of this study from the other study in terms of the nature of study and the study design? If you carefully read the study design, you will notice that this is different from the other studies which were discussed.
Multi-centric study and open label study.
Did you see what is mentioned as a pragmatic clinical trial? They mentioned this as a pragmatic clinical trial. Generally, the study which mimics the real world scenario, not many inclusion criteria, exclusion criteria. So in the real world, how the clinical, it mimics the real world scenario of practice. And the second thing is, what are the study follow-up period?
Yes,
2.2 years. Do you think this is adequate for, it's modest?
It is modest.
And do you think this is applicable to the Indian population, our population?
It was inadequate period of follow-up because to assess the period of to assess health.
Yeah, the ethnic group studied ethnic groups. The participants, ethnic group of the participants. Did the study participants included Asians or Indians?
Sir, it was mainly the
white
Asians.
Population. Only 1% of the population was Asian population in the study. So that is one thing which we need to consider while extrapolating the results to our situation. And see, another thing is nearly 40% of the patients in 325 milligram group switched to 80 milligram during the course of trial. The switchover is huge when you compare between those who switched from 81 to 325 So large number of patients, nearly 40% switched over. So when you do an intention to treat analysis, initially you treat as per the allocation to the different groups. So huge number switching over to the other group makes some bias, brings some bias in the study itself. That is one limitation which you should consider while you analyze this study. Anyway, good presentation. Thank you, sir.
Yeah, again, I think excellent presentation and a good analysis. I mean, my questions are again fairly similar to what Dr. Shrikant has already asked. He brought up the important point of this being a pragmatic trial. The other thing is it's a multicentric trial. Can you tell me, are there any disadvantages and advantages of a multicentric trial?
The multicentric trial, the advantages include a large sample size is one, and multiple populations from different areas are considered, which might have a different risk factors for their own. And the age group of the population and the follow-up which they in a particular hospital would be different. So based on all these criteria, I think the advantage would be a broader assessment of the risk factors and the age group which can be considered, and the ethnicity can be considered. So that's would be the advantage.
Are there any disadvantages?
There could be bias or like patient.
Yeah, what you all said is right. There is bias. There's always a risk of bias, and bias is the enemy of good science. Okay, so that's one of the problems when you have different investigators who, no matter how well you design your study, have some differences in the way they approach a patient, they allocate the patient despite a central, internet-based randomization. There are always going to be these differences, and finally in the approach. One of the other big problems I would have liked you to mention is the amount of missing data. There was a lot of missing data in the question of the aspirin use. You did bring it up briefly, but almost, I don't remember the exact number, but something like 5 to 7% of previous aspirin use data was missing. And that's very important because, you want to know the effects of long-term aspirin. People who were on aspirin earlier would obviously have perhaps better outcomes than we don't know the answer to that, but it's likely that they had better outcomes than people who were not on aspirin earlier. So you have a lot of these biases that may have crept in, but this is the disadvantage of a multicentric trial and of a real world study, where the conditions are not as tightly controlled as with an RCT. Okay, but good analysis. Thank you very much.
Thank you.
Thank you. Thank you. All the three participants did well. Now I have one question to all the participants. Please mention who are the sponsors of the study in your paper, and did the sponsor or the study being sponsored affect the outcome or the final result of the study? The first paper. Who were the sponsors?
This is Dr. Pragya.
Whether
Yes,
it is,
Yeah. Let's switch on the video at least, because we don't know who will be talking.
the sponsors, they have just told that it was from a registry that they have taken, and the government of Canadian
no,
Danish
Denmark.
Society. Sir.
Who
Danish.
sponsored the study is
No
not,
one is sponsored. Yes.
not mentioned.
Yes.
Okay. So the question of sponsor biasing doesn't arise in your study. Okay. The second paper from BMC
Dr.
about
Megha.
PCI versus CABG. Sorry.
You're not audible.
Switch off your video, you'll be audible.
Yeah.
Okay, yes. Hello.
And it's a bonus question. It doesn't
No,
start on
sponsor.
the- just this is one area which we should look
Sponsored
into when you
were Boston Scientific.
Boston Scientific, the manufacturers of the stent. But however, did it affect the outcome of the study?
No, sir.
No. The sponsors had no role to
Were
play in
involved.
analysis. Okay. The third one.
So this sponsored. Hello. Hello, am I audible, sir?
Yes, yes,
Yeah,
go
yeah.
ahead.
Sir, this was funded by Patient-Centered Outcomes Research Institute. It was a non-profit organization which was contributed by multiple institutes, sir, and funded by the same.
Yeah, it looks like a publicly funded study. So generally, it's when you have a publicly funded study, the impression would be that it will be less biased. So, okay, thank you. Sir, any single question to all the three teams?
No, I think that's adequate, sir. I think we are, running short of time. Let's get on.
So final words from Madam, Dr. Meena, Madam. Meantime, I think I will call up Dr. Srikanth.
Yeah, so thank you so much, all the participants, and it's very heartening to see women empowerment and multiple studies, and very, very good. So we are encouraging research. But one question to our esteemed judges, sir, why don't we have original research in our country, and how do we promote that? So that's a question to my judges. Can all of us help? Because we have very few research papers from our own country. Original research papers.
Madam, that was exactly my thought when I was, the questions we were asking. Are these relevant to our population? That's a very important question that needs to be answered, and will only be answered if we do original research. So I hope young researchers
we need more
presenting papers take this up as a challenge. Sorry, ma'am, please go ahead.
Sir, I'm so sorry because I'm saying we need more electronic medical data. We don't have EMR, so we all are responsible. See, the Danish study, everybody was captured. Now here, since most of us physicians don't keep our EMRs, we don't have data coming in. So I think we also are responsible for the data from the real world missing. But it's heartening to see our young investigators and talking about these studies, and a very big thank you to all the participants. And I think we need more studies from India because, it's like what we just brought out, that ethnic differences, and we get cardiovascular disease a decade earlier than the Western counterparts. So a lot of factors which nutrition was not, in the ASCVD risk scores, nutrition may play an important role. So we have not discussed good fat versus bad fat, carbs, good carbs. So I think nutrition has to be studied in a big way. So a lot of, things that are India specific. The Indian phenotype particularly, that we have more visceral adiposity as compared to our Western counterparts. So all those things, I think this opens up our minds. It's very, very empowering that we need more India-specific data, which both of you highlighted. So thank you so much. Thank you, judges. We're really, really happy that you pointed out that we need more research papers from our own country, and we need more and more young investigators and the elder or senior doctors to maintain electronic medical records. Thank you.
Thank you, Pam. Can I just add one more point? When I was a postgraduate, I don't think I could have made presentations like this.
We couldn't have.
Absolutely no way.
Present generation are
brilliant presentations, all of them.
And a special credit to the faculty who trained them, because I think they deserve equal credit. They've done an outstanding job in training postgraduates. So kudos to all of you.
Critical analysis of a journal article is very important for various issues. One, in the practice, whether it is applicable to our practice or not. And the second thing is, as a reviewer, as a part of editorial, during the editorial process or during the pre-publication stage, critical analysis of the journal article is very important. So it's good that many students are taking up this and doing it in a very interesting way. All the best to all of you. Thank you.
So the results of the
Dr. Vishwanath will be.
Yeah, good morning, everybody. Yes, Dr. Srikanth.
Giving first place or second place is only just a customary thing, but I would give prizes to all the three of them. They have done a wonderful job. So there is nothing like winning and losing.
As Dr. Murali Mohan sir was telling, nowadays the students are so sharp and so confident enough to present comfortably. So that is why we should appreciate. Actually, I should say all are winners, because participating in a symposium, quiz program, journal analysis is an important aspect. You volunteered and you came forward and you presented in such a good way, and other persons were so impressed. All are the winners only. But as a customer, we need to announce the results. That is what I am going to. So the first prize goes to JSS Medical College, Mysore. So with good marks. The second prize goes to Bangalore Medical College. And the third prize goes to Kolar Medical College. Congratulations to all the winners. Winning or losing is a part of any.
Nothing, no losing, sir, here.
Can I also say a special word of appreciation and thanks to Professor Arvind, who comes up every year with something innovative and different, and an excellent selection of papers by Dr. Vishwanath. Thank you so much.
Thank you. Thank you.
Thank you, sir. On behalf of, I thank you.
That is the most important thing.
Every time to be the judge in this session. I thank Dr. Vishwanath, Dr. Murli Mohan, and Dr. Arvind for this excellent program. Thank you.
Thank you. Thank you so much.
Thank you.
I think Dr. Arvind, we lost. He has still a lot of thing to do, Dr. Arvind.
I think it's lost connection.
Okay, sir. I think I will wrap it up. Yeah. Thank you very much. Thank you, Dr. Srikanth Hegde, sir, Dr. Murli Mohan, and Dr. Meena Madam. And all the postgraduates, thank you for participating. And the respective HODs, because I had called them up and they allotted the cases students. Thank you.
Thank you. Thank you, Dr. Srikanth.
Thank you, sir.
Always a pleasure to be on any panel with you.
Thank you, sir. It's same. Admiration is mutual, sir.
Thank you.
Good morning, everybody. So moving ahead, sorry, there was some internet network glitches. So moving ahead, we'll start the program for today. That is 25th September, Hall A, Sri Kempegowda Hall. So we'll have the session starting today. The first session is on GDM Symposium, that is Gestational Diabetes Symposium. To chair this session, we have Dr. KG Suresh, my good friend from Bangalore. He is a consultant physician and diabetologist from Manipal Hospital, Bangalore. And Dr. Mridul Das, he is the Director, Diabetes Clinic and Diagnostic Laboratory, Agartala, Tripura, author of 6 articles published in national and international journals. We have 3 interesting sessions by Dr. Deena Shrestha from Nepal. Thanks for being a part of our conference. Greetings to you from India, from Bangalore. And then we have Dr. Om Lakhani from Ahmedabad and Dr. Shalini Jaggi from New Delhi, all the 3 eminent speakers. So over to chairpersons for further proceeding, please.
Thank you, Dr. Arvinda. At the outset, I thank you for inviting me for this wonderful symposium. So without wasting much time, so I'll introduce Dr. Deena Shrestha. She has done MBBS, MD, endocrinology from Nepal. Presently a senior consultant endocrinologist. She has won a president SAFES, South Asian Federation of Endocrine Societies. She is immediate past president, Dean Diabetes and Endocrine Association of Nepal. She is also founder of DRR Diabetes Rehabilitation and Research Center. And also she is in editorial board of JCEM, that is Journal of Clinical Endocrinology and Metabolism. And also chief editor for National Consensus Statement of Type 2 Diabetes and Hypothyroidism. Present affiliations, Norvik International Hospital, Kathmandu, Nepal. and publication. She has various publications in both national and international journals, and research interest mainly in thyroid and diabetes in pregnancy. So she'll be today talking on the topic pre-existing diabetes versus gestational diabetes, difference in management. Over to you, Dr. Dina.
Thank you so much. It's a great pleasure and really to be speaking on one of my favorite topics. I'm just going to share my screen. Good morning, everybody. So today the topic is like, what is the difference in the management when we are talking about pre-existing diabetes versus gestational diabetes? Without wasting much time, I'm just going to go ahead. So now we know that the classification of has become like hypoglycemia and pregnancy. So we are defining it as hypoglycemia and pregnancy. And that has been divided into diabetes in pregnancy, which affects about 15% of the pregnancies, and gestational diabetes, which is 85%. How do we define diabetes in pregnancy? What does it mean? Is that it can be pregnancy, which is diabetes actually in patients who are pregnant, but they can be both type 1 or type 2, but this was diagnosed before they got pregnant. Or the glitch is that they were actually diagnosed first time, but they meet the WHO criteria for diabetes, which is like postprandial of 200 or like a fasting of more than 126. What affects the hypoglycemia in pregnancy? Mostly the bulk of our patients are usually gestational diabetes, which is 85%. And in this, it's like more like a pre-diabetic range, only that the fasting is not, we don't have to wait for 100. It's more than 95, but it's a milder kind. And it is usually diagnosed first time during pregnancy, does not reach the WHO criteria, and usually occurs around 24 weeks, and the peak is about 20 weeks. So that is the thing that we have to first, when we are managing hypoglycemia in pregnancy, we really have to differentiate whether this is diabetes in pregnancy or just gestational diabetes. So we can define it as, I'm just going to try to move the screen, is that diabetes diagnosed in the second or third trimester of pregnancy, which is clearly not overt diabetes and not prior to pregnancy, is gestational diabetes. And the definition of diabetes in pregnancy should be understood. That may include cases that are undiagnosed. So basically, it's not that the patient has to be diabetic before diagnosed. But what if the patient didn't know? We have so many of those patients who come with heart disease or kidney disease, or now with dengue, and then suddenly they're like, oh, you're diabetic. Same way in pregnancy also, that can be that they were not diagnosed. They did have the type 2 diabetes, but now they got diagnosed during the pregnancy. This is one of my favorite slides, that how, when we are infants or childhood or adolescents or adulthood, how the plasticity of our life actually, which is maximum, decreases. And then that is why the earlier interventions improve the functional capacity of us, whereas the late interventions, when we could become older, there is actually an inadequate response to the new challenges. So the late interventions have less impact for vulnerable groups. That is why patients with diabetes, hypoglycemia in pregnancy, but the pre or post pregnancy, really we have to give a good impact to the children. Because if we see, this can be like a vicious cycle in diabetes, right? So we have somebody who's an adult who's pregnant, develops gestational diabetes, gives birth to a large baby. This baby is a girl child, becomes overweight. During adolescence, she might have PCOS, obesity, and with the fetal programming, when she's an adult pregnant, a pregnant patient, she again becomes gestational diabetes. And then, the cycle continues. So we really have to break that cycle. This is another thing that whenever we are talking about what we want to do, we have to consider that in South Asia, people are paying out of their pockets. We have our own culture. So there are a lot of barriers which we have to keep in mind, just because we just had such a good talk about, trials and papers and everything. But in real life, it can be different, because there can be individual barriers of literacy, of awareness, of fear, denial, of characters. And then there can be logistic barriers, availability of specialists. I'm for sure in India also, in Bangalore also, it's there that you have centralization of healthcare. Everybody wants to come to Professor Arvind, and there are not enough Professor Arvinds around the smaller towns around Bangalore. And that might become a problem for these pregnant patients who don't have the family support for transportation. They have to take public transports, the clinical distance, timings, the finances, the cost of healthy nutrition, all that we have to consider in mind. So this is my disclaimer that I'm sure whatever we say, we want to do our best. But sometimes I say that best should not be the enemy of good. So if we see the prevalence of diabetes, which was there diagnosed pre-gestation and the gestational diabetes, with age, actually it increases. So I think this is one message we want to take, that really gestational diabetes it's common, but pregnancy in diabetic people who are pregnant before gets more and more as we age, and we know that women are choosing to get pregnant later in life. So we do get to see more diabetes in pregnancy, or patients who were diabetic before pregnancy, now as we are choosing to get pregnant later in life. And as the previous doctor was saying, that we have more women empowerment, and that has also been one of the things. But the downside is like we do see more of diabetes mellitus, which was diagnosed previously than the GDM. Hypoglycemia in pregnancy is a major global health problem, and actually this is something that is Caucasian. But in India and Nepal and in South Asia, it is more like 1 in 5 or 1 in 4 live births actually are affected with hypoglycemia, and they both have maternal and fetal bad outcomes. What are we talking about pre-existing diabetes? What are the complications, or what are the adverse maternal and child outcomes in women? Is that in pre-existing diabetes in pregnancy, or DIP as we call it, the maternal outcomes is pre-eclampsia and cesarean delivery, which might be similar to that of gestational diabetes, but the child outcomes may be a bit more. We have more congenital defects, cardiac congenital defects, preterm delivery, stillbirth, macrosomia, and respiratory distress may be higher with diabetes in pregnancy, with pre-existing diabetes. With gestational diabetes, it is a milder form, but definitely the volume is too high. Like 85% of people and 1 in 4 are affected. So it's that we see a lot of patients with gestational diabetes, and they do have the complications, which include fetal programming, which can cause the child to have later develop cardiovascular and metabolic syndrome, and even the mother might have lipid abnormalities, hypertensive disorders, hyperinsulinemia, and cardiometabolic adverse effects. So having said all that, what is the difference in the management, which is the topic for me today? So I just wanted to bring this in, that we really need to know why we are so particular about the difference in management. Because diabetes in pregnancy is the elevated blood glucose since before pregnancy, right? So it affects the organogenesis. So that is one thing we have to be careful. So they have congenital fetal defects 8 times higher than in normal pregnancy, and can also cause growth retardation. In GDM, yes, we do have it, but usually no effect of organogenesis. And macrosomia is the most common fetal complication. And then we also have hypoglycemia in these patients with prolonged jaundice. So these are the most common in GDM. So what do we do for the diagnosis checks for pre-existing diabetes in pregnancy? We have to see the HbA1c, we have to check for the protein, and we have to check thyroid. In both, I think for me, it's both now type 1 and type 2. Also, when we're clinically screening, we have to discuss about, whether they used contraception, what were they using, which pills they were on. And one thing we have to understand is that really we have to screen them for OSA. OSA, we always hear about it, like we know if somebody says obstructive sleep apnea as a screening thing, we are not immune to it. But what it is like, maybe it's because it's cumbersome. It's very difficult for us to actually diagnose it. Tell patients to go do a sleep study or come to a hospital, stay the night. But I think in these pregnant patients, especially who are obese, we really have to make an effort to tell them that they need OSA screening. Retinal examination and considering of CAD screening in multiple risk factors are present. In the first trimester, we have to tell them to do monitoring. You can, if they can afford, you can do the CGMS, retinal examination repeatedly. And when it comes to fetal assessment, second and third trimester, we have to do a detailed anatomical survey via ultrasonography in the 18-20 weeks. Consider fetal echocardiography. In my institute, it is available. I know it's not available in most institutes, but we have to give this choice to the patients. Evaluate the fetal growth in the third trimester, and formal fetal monitoring often started in the 32 weeks. Okay, so what are the management pros? So for the when we are talking about pre-existing diabetes, preconception is the key. Like that is it. Like if we don't learn anything, the one thing we have to learn is we have to have a preconception, because most of the patients in our society, South Asia, as we can say, also have this thing that they don't have a planned pregnancy. They just come and they're like, oh, we got pregnant, you know. So definitely that does not work for the pre-existing diabetes. We have to keep telling them whenever we're treating them and we know that they're in the reproductive age, we have to say, see, if you're getting pregnant, tell me 3 or 6 months ahead. You know, we need to know that you're going to get pregnant. And it is very important to avoid the unintended pregnancies and to minimize the congenital defects. The HbA1c goals are less than 6.5 at conception and less than 6% during pregnancy. Important to screen for comorbidity, as we have already discussed, and the medications known to be unsafe, because it's one of our reflexes, right? We have to use an ARB, we have to use the statins. But, you know, if they're planning to conceive, we have to stop that. Then the women with obesity have to be screened for the OSA. We have enough studies, enough papers to show that they, if undiagnosed, can really have a bad outcome. Blood pressure goals must be met, have to be monitored, and women have to be monitored for the microalbumin or the urine protein albumin ratio. During pregnancy, continuous glucose monitoring with the whether it's SMBG, whether they go to the lab because of whatever issues, or whether they can afford a continuous blood glucose monitoring needs to be done. And especially for type 1 diabetes, and we have seen that type 1 diabetes patients are more vulnerable. They are more careless about their health than the type 2. Management role 3 is insulin in first line of therapy for all women with pre-existing diabetes. There is no doubt, like we have to put all of them on insulin, injections, insulin pump, whatever is good for them, whatever they can afford. This somehow insulin pump is not common in Nepal. I know especially in South India, it is there. You are very technologically advanced, so you have the advantage for that. And even for severe hypoglycemia, according to the books, according to theory, glucagon has to be available, but it is not available in Nepal. So we usually tell them to keep glucose tablets, or simplest, keep some fruits available. Do not correct it with chocolates and lots of other things that they eat. And usually we have to have a fast-acting glucose, which we have to counsel them about. And low-dose aspirin is recommended. And usually the gynecists also are very aware these days, and they start after 12 weeks of gestation to minimize the risk of preeclampsia. The importance of discussing long-acting reversible contraception has to be there and cannot be overstated or understated. So what is the ADA's recommendation for glycemic target? HbA1c preconception 6.5, during pregnancy under 6, which is very, very difficult, I know, but we have to try to achieve it. Glucose or fasting of less than 95, first 1 hour of 140 and 2 hours of 120. Weight, the typical insulin requirement, if we see that, something that we have to keep in mind is that not every time the doses are increasing. First, 0 to 9 weeks, it usually increases. 9 to 14, it kind of decreases. 14 to 16, our insulin sensitivity is good. But we know that the worst is between 16 to 37 weeks. At least it doubles. And, you know, we need more monitoring, more vigilance during this time. And usually after 37, it can decrease, or as I say, can plateau. Immediately after pregnancy, especially when we're giving out the orders, when they've admitted, we have to tell them about how to decrease the insulin doses, because it can decrease to almost half of the pre-pregnancy needs. Therapeutic considerations for the pre-existing diabetes and pregnancy is the non-pharmacological intervention. Really, like, this cannot be overemphasized, that weight optimization with lifestyle modification, food, nutrition, exercise, everything has to be told to them, because if previous to the conception they are not able to do it, we know that how difficult it is going to be to maintain an HbA1c of 6 during pregnancy. We have to give them about the consultation for lactation, considering the ongoing nutrition support even after that. Pharmacological intervention, we optimize the glucose accordingly, and then like we stop all the oral tablets, put them on insulin so that they know what they are dealing with, stop the sulfonylureas, TZDs, all the SGLT2s, DPP4 inhibitors, and we can start them on the prenatal vitamins, encourage them to take vitamin D, calcium. Of course, as discussed, we have to discontinue the ACE and the ARBs with statins and give them the appropriate antihypertensive agents. We initiate and titrate the insulin accordingly and start the aspirin at 12 weeks. This is, and then also make sure that sometimes we can tell them that metformin is safe for women who are breastfeeding and during pregnancy. So it depends if they're obese and what is the insulin sensitivity. What is the mandate? So this was the pre-diabetes, right? It looks so complicated. There's like so many things to do: insulin, medication, nutrition, contraception. But really, management of gestational diabetes is that we have to get the medical nutrition therapy under control, right? This is one of the most important and one of the most effective ways of managing gestational diabetes. We can achieve normal glycemia, prevent ketosis, make sure we have adequate weight gain, and contribute to the fetal well-being. So it sounds so easy, management of GDM, like just medical nutrition therapy for almost 60 to 80% of our patients. Tell them to be physically active, self-monitor the glucose, pharmacotherapy then if all this fails, and then have a fetal and maternal health surveillance. And the glycemic targets are the same, less than 95 in fasting, 140 1 hour, and 2 hours of 120. Also, the weight gain, we can say that in gestational weight gain, the weight gain guidelines can be a bit different. If you are somebody who's lean, less than 18 is your BMI, 12 to 18 kgs is allowed. But if your BMI is more than 30, 5 to 9 kgs of weight gain is enough. But we know that the challenge is, right? Like it sounds like, okay, it sounds more challenging that you have to do in pre-gestational, pre-pregnancy diabetes, that, you have to control the insulin, you have to stop the statins, control the blood pressure. But somehow I always feel that it is easier to manage than the composition. So with composition of diet, a low GI always works rather with the correct nutrition. Exercise prescription is difficult, but if you tell them properly, they will listen to you, and they need to monitor the blood glucose before and after the exercise. Pharmacotherapy is there. Insulin will be the number one, metformin and glyburide. I just want to put in, my time is running out, but I want to put in that insulin is always safe. Insulin is always good. Tablets, somehow we know that if the patient is not literate, they don't have money, sometimes we can use metformin and glibenclamide. So management of gestational diabetes, lifestyle is the essential. Insulin is preferred if we have to use medication. Metformin and glyburide can be used. We have to have the ultrasound to see how is the growth, if there is any malformation, how to monitor the growth. Labor and delivery is important, that, for gestational diabetes, diet control can be taken to term. GDM does not cause an indication for C-section, and really, we have to make sure that, especially for the neonatal hypoglycemia, that the blood glucose is well controlled. This is one of the toughest things to do, is before hospital discharge. Again, tell them that you have to come back for postpartum visit, impaired blood glucose. You have to make sure that you control your diet, don't overeat, exercise, even when you're postpartum, and this is my last slide, and tell them that, this time if it was gestational diabetes, next time you can be pre-diabetes. So your pregnancy, if it's his first or second pregnancy, the risks might be different, and later in life you might have diabetes and other complications. So in summary, existing diabetes in pregnancy is complex and associated with significant maternal and neonatal risks. Optimizing of glycemic control obviously is important. Recognizing the scope and significance of GDM because it's very common. Be careful, cost effectiveness and rational and locally relevant things we should tell the patients. Keep reminding the patient to have regular follow-ups, which is one of the most difficult things after gestational diabetes pregnancy, and keep an eye on these babies of mothers with who were born to gestational diabetes. Thank you so much.
So Dr. Dina Sister from Nepal, she has covered all aspects to approach the pre-existing diabetes and gestational diabetes. It was very wonderful. Actually, GDM, it is the very delicate and sensitive type of diabetes because patient, not only herself, her in-laws, house members, then parental house members, all are worried about her GDM. So that is the patient and family interface. But what about our physician interface? We are hearing from our very good and beautiful speakers. Dina Seshta from Nepal, she has covered almost all aspects of approaching GDM. Now, I like to invite one or two questions from audience, if any.
Yeah, Dr. Suresh here. Dr. Dina, how about CGM? Do you want to maintain throughout pregnancy or only for some part?
I think the problem with CGMS now is that when, first of all, I want to say that CGMS is rarely available in Nepal. We have just very little experience. But now that, we also get it from India, the machines, and people are using it. But with CGMS, the problem is that we also need to calibrate. So the patients still have to do the finger prick. So I think some of the patients are disappointed and disheartened that, they need calibration, and in the end, they still have to use it. So my experience is that CGMS is good if they can afford it and they have very high educational level and tolerance. But otherwise, it's difficult to ask the patient to continue with it. But the targets would be.
I think it's most useful if there is a pre-existing diabetes, you do it before planning for pregnancy. Then again, for one trimester you can take, or if they're affordable, you can do once in every trimester.
Yeah. But CGMS is not locally available in our country.
Good morning, Dr. Dina. It is very nice presentation. I just want to know, is there any difference while managing a twin pregnancy than a single pregnancy, or no?
Definitely.
Just a random thought.
Definitely. I mean, twin pregnancy, patients with IVF, been definitely that the insulin demand really goes up. They're more difficult. They tend to gain more weight, and then a lot of time, if you're trying to control diabetes, then the weight gain is not good enough, which is also not. So there's a lot of teamwork and education needed for the twin work. I agree, but I've just been blessed these 3 days ago that I had a patient who was almost in her 40s. We've been trying for the last decade or more, and I had a twin son. So I was like, it works. But definitely, it's not going to be an easy pregnancy when it's with the twins. The insulin demands, the insulin resistance, the hypoglycemias, the hyperglycemias are all much more difficult to manage in these patients.
But treatment pattern is same. You have to be more vigilant. That's it, right?
Yes, and then we just have to know that the insulin resistance might be more. The nutrition, the food that we are giving them is much more. So sometimes what happens is the growth might be retarded in one of them, or so we have to make sure that the nutrition is enough. And then because it's a twin pregnancy, so the insulin resistance will be higher. So you might end up using a very large dose of insulin.
I always use metformin with this because of the resistance part.
Definitely.
Yeah.
We do use metformin in pregnancy actually, and we rarely stop it.
Thanks, Dr. Dina, for the wonderful presentation and being a part of our conference from Nepal. So thanks for your time and your discussion. Thank you so much. So we'll move on to next session. Dr. Suresh, kindly proceed, please.
Yeah. I think Dr. Madhul will introduce our next speaker, Dr. Om Lakhani.
Okay, no problem. Okay, Dr. Om Lakhani from Ahmedabad. He is a consultant endocrinologist, Department of Endocrinology, Zydus Hospital, Ahmedabad. His qualification is MBBS, MD, and DNB in endocrinology. And he has achieved winner of President NB Gold Medal in endocrinology, national winner of ESI TISA in 2016, second runner-up of A.B. Gandhi Award in 2017, winner of 2 gold medals in MD, winner of 5 gold medals in MBBS, winner of API DR Vital Rao Nadgowda for best thesis in MD medicine, and he's developer of the Notes in Endocrinology app. We are proud to have him in our session. So, Dr. Om Lakhani, stage is yours.
Thank you so much, sir, for the kind introduction. Am I audible? Hello.
Yeah.
Okay. Thank you, Dr. Arvind, for having me, and thank you to the chairpersons for the kind introduction. I'll start by sharing my screen. So I've been asked to talk about novel insights in management of gestational diabetes before, during, and after. Is my screen visible?
Yes.
Yeah, okay, thank you. So I'm Dr. Om Lakhani. I'm an endocrinologist from Ahmedabad. So, this was consider this as a continuation of what Dr. Deena talked about. She talked about the current management of diabetes, gestational diabetes. I'm going to talk about the futuristic aspects of gestational diabetes, especially with recent evidence. So what I did is, when I was given this topic, I went through PubMed articles in the last 1 year. So, and I tried to select some useful articles and also given some general trends which are changing in terms of gestational diabetes management. So that will be the basis of my talk. So consider this as an year in review for gestational diabetes starting from September 21 to September 22. So we'll mainly discuss the current evidence, and it will be like a continuation of the previous talk. So first, let me talk about prolactin and the risk of GDM. And there's a lot of data emerging in this area. Especially, I would like to point out this recent abstract, which was presented at EASD in Stockholm currently, which is an ongoing conference. This is by Loeffler et al. And the study found that higher prolactin during pregnancy was associated with better beta cell function and less risk of GDM in future pregnancies. And nulliparous women who had highest prolactin level, while women with 1 or more pregnancies had lower prolactin level. And this indicates that subsequent pregnancy, the prolactin levels being lower are associated with a higher risk of developing gestational diabetes. And again, both animal data and the study in this study shows that there is a stimulatory effect of prolactin on beta cells, and this could contribute to the insulin secretion, and lesser prolactin would perhaps lead to higher risk of GDM in subsequent pregnancies. So very interesting area of research. And in fact, the study prolactin has been studied for its metabolic consequences, especially with relation to pregnancy. What we know is that as far as action on pancreas is concerned, increased prolactin causes beta cell proliferation, increases the beta cell mass. But on the other hand, also increases insulin resistance to some extent. But at the same time, the rate limiting step often becomes the beta cell mass in gestational diabetes. On the other hand, in the liver, it increases the hepatocyte proliferation and angiogenesis. As far as the adipose tissue is concerned, it increases the browning of adipose, the beiging of the adipose tissue. And on the brown adipose tissue, it increases the maturation of brown adipose tissue. So overall, prolactin may have a positive effect as far as the risk of gestational diabetes is concerned. And I think in a correlation, you could perhaps say that breastfeeding perhaps would be protective against future gestational diabetes in women who are planning for multiple pregnancies. This is an interesting area of research. And please do watch out for more papers on correlation between prolactin and gestational diabetes. So moving on to another trend, which is emerging, again, an abstract from the currently ongoing EASD in Stockholm. They are looking at fasting cutoff for GDM, and that perhaps needs to be revised. In fact, I'll show you more papers where this continues to be a theme in overall management of gestational diabetes. So in this study, what they did was, they divided women into 3 categories. One were the women who were diagnosed based on isolated fasting glucose levels with normal post-glucose load levels. Second was the group where you had the entire GDM criteria fulfilled, both the criteria were fulfilled. And then third was women who were diagnosed with GDM based just on the post-glucose load level with normal fasting glucose levels. So this study by Cosson et al. You can see the link below. So they adjusted the odds ratio for large for gestational age infants, which was the endpoint they were studying. And they found that those women who were diagnosed to have GDM with isolated high fasting GDM, fasting glucose levels, compared to the other two groups, had higher odds of having large for gestational age infants. So what this tells us that the fasting glucose level, which are current cutoff for fasting glucose level, may be actually higher than what probably should be in terms of physiological range. So currently, you have the fasting glucose of 5.1 millimole as the cutoff, which is 92 milligram per deciliter, and perhaps this is probably needs to be revised to a lower fasting glucose level for threshold throughout pregnancy. So I think the post-meal glucose levels tends to be more appropriate for GDM, but the fasting glucose levels perhaps needs a revision. Now, continuing at the same theme, there is a very interesting study by Dr. Yashdeep Gupta from AIMS. This is an Indian study. They looked at the cross-sectional data with women with singleton pregnancy at 8 to 19 weeks. So this is early GDM or early pregnancy, and they are looking at those women who are having normoglycemia or those women who are having GDM. So this is a CGM-based study. So what they did was, the entire paper could not be put here. So the idea was that they looked at all these women in between 18 to 19 weeks of 8 to 19 weeks of pregnancy, and they put a CGM in these women. And what they found was similar to what the previous study showed, is that the fasting glucose criteria for GDM perhaps needs to be revised and needs to be set to a lower threshold. And they found that those women who would normally be categorized as normal fasting glucose had higher glucose values post-meal when CGM was done. This is probably not picked up on a glucose challenge test or a OGTT test. So what this tells us is that perhaps the fasting glucose level, especially in the early pregnancy, needs correction and revision, and we need to probably look at more data about using fasting glucose as a criteria for diagnosis of gestational diabetes. Now, we all know about PCOS and the risk of GDM, but this is a large study from Massachusetts where they looked at a registry-based study where they looked at women who are having PCOS. And as expected, as we all know, that those women which had history of PCOS had 51% greater risk of gestational diabetes and 25% greater risk of pre-eclampsia compared to women without the diagnosis of PCOS. So I think why this is important and why I put this paper is because we see a lot of women nowadays with PCOS. We also see a lot of these women undergoing IVF treatment or other forms of ART. And hence, we need to be very cognizant of the fact that these women are at a greater risk of gestational diabetes and need to follow up these women more closely throughout the pregnancy. So this is an important study in that regard. And I think this is something we should be watching out for. Closer to home, now we have this conference from Bangalore. And I'm sure a lot of you would be aware of this study, which is ongoing, which is called the MASTI cohort. MASTI stands for Maternal Antecedents of Adiposity and Studying the Transgenerational Role of Hyperglycemia in Insulin Cohort. This is a study by Dr. G.R. Babu's group, where they'll be following this patient for both the mothers and the offsprings for up to the age of 4 years. So they had completed the recruitment of this study in 2019, and now they are doing an annual follow-up up to the age of 4. So the idea of this study is to look at the future risk and the risk of childhood obesity in these children who are based on the glucose levels during pregnancy. So what they're looking at, and this idea is to form a policy formulation and create awareness about non-communicable disease and health promotion in general population. I think Dr. Nina showed you a slide where there is a transgenerational problem with gestational with GDM, where what happens is that obese women tend to have obese children, tend to have GDM, tend to have when poorly controlled, tend to have large for gestational age children, which go on to become obese children, and then again become obese parents. So I think that creates a generational shift, and I think the idea of the study from Bangalore is to follow up these patients and really see what happens to this cohort of patients. So now let's look at some evolving trends in gestational diabetes management, right? These are, I reviewed about 200 papers, not mainly abstracts, but the papers which I showed you were the papers I read in detail. But there was a general idea which formed in my head as far as some of the trends, in the last 1 year, if you see the papers, what are the trends which we are looking at as far as gestational diabetes is concerned. So I have collected a few important trends, and I think this could be again basis for future research in gestational diabetes And I think, especially postgraduates are listening to this, this could be potential research papers which they could perhaps consider studying. So there is a lot of data now emerging in terms of early GDM, right? We are looking now at more of biomarkers for diagnosis of GDM earlier in the pregnancy. So, we generally conventionally diagnose GDM at 24 to 28 weeks of pregnancy, but can we have certain biomarkers which can indicate that the risk of gestational diabetes is higher, and perhaps consider screening some of these women earlier than 24 to 28 weeks, as we usually do? HbA1c is fast emerging as an important cutoff for screening patients who are at higher risk of GDM. There have been various cutoffs which have been proposed, but HbA1c of more than 5.9 early in the pregnancy seems to be an important cutoff and suggests that these women are at a higher risk of developing GDM, and perhaps it would be a good idea to screen them earlier, perhaps at 18 to 19 weeks instead of 24 weeks, to really see where we deal with. Also, something very interesting from the field of radiology, they're looking at visceral fat thickness in women early in the pregnancy, and it's quickly emerging as an important non-invasive tool for predicting the risk of GDM in pregnant women. Now, unfortunately, we do not have the debate really lies in terms of cutoffs, which we should use for visceral fat. But remember, all of these women are undergoing ultrasound early in the pregnancy for, of course, confirmation of pregnancy and for looking at the fetal growth. So, can visceral fat be added to this in terms of criteria and looking at this as an important marker for predicting risk of GDM? Time will tell. But there is a lot of data emerging in this area. There are now some meta-analysis also published in this area. And this is something, again, both physicians, endocrinologists, and OBGYN, and along with radiologists should be looking out for, and perhaps, looking at as a form of research. So again, if you have postgraduates listening to this, I would insist that, just try to look at some of the papers here. And this could be a very good thesis topic. It's very easy to conduct study in Indian patients, especially, in an academic institution where ultrasounds are done at routine basis. So maybe along in conjugation with the radiology department, this could be a very useful study. I don't want to get into the debate of metformin versus insulin because it's a big debate on its own. But now, again, a lot of data is coming in terms of metformin and the risk of small for gestational age infants. So I think one of the concerns of metformin was always SGA, and there is a lot of data emerging in this field. And now I think perhaps we should be looking at this data more closely and perhaps considering that does metformin really increase risk of small for gestational age, and something which could be again an important tilt in the favor of insulin for using GDM. However, like I said, in my practice, I continue to use metformin in some of these women, and again, I'm like all of you looking closely at this data, but there's a data emerging in this field quite rapidly. Then you have some non-traditional biomarkers in prediction of GDM. We know that metabolic disorders are involving multiple organs, not just the pancreas and liver, but the use of non-pancreas and non-glucose, non-metabolic markers perhaps could be very useful in GDM prediction. Especially, there's one study which looked at hepatic parameters like PT and APTT and found that it had linked with future risk of gestational diabetes. Some adipokines like adiponectin are also strongly emerging as tangential biomarkers in gestational diabetes diagnosis. So I think, again, these are areas where, alternate biomarkers could be perhaps used for predicting GDM or predicting outcomes in GDM. Again, this is an area where a lot of research is emerging. And again, postgraduates could consider using this as study. Remember, APTT, APT are very easy to do in your patients. And again, if you are in an academic institution, you get small amount of funds for this. It's very easy to conduct this as a study and follow up these patients throughout pregnancy. So again, doctors who are doing their postgraduates in OBGYN can perhaps look at this as a potential research topic or thesis topic, which could be used. Again, as expected, GDM is an important risk factor for cardiovascular disease in women, and it's rapidly emerging as a risk factor. And we need to consider GDM as an important, when you are doing the cardiovascular risk assessment in women, you need to consider history of GDM as an important history. I think this should be part of, again, in terms of history taking. So whenever you are dealing with patients who have, increased risk of cardiovascular disease, women with increased risk of cardiovascular disease, a past history of GDM or past history of large for gestational age infants should be part of the discussion. Again, just like so, we know in India we use the DIPSI criteria also, where we use a single sample analysis. But sometimes the West follows the East, so the West is now following the same thing. There's a lot of data emerging and looking at just the glucose challenge test. That is the 50-gram glucose challenge and 1 hour glucose cutoff of 140 may be associated with high risk factor and poor pregnancy outcome in women. So they're saying that perhaps a GCT, a positive GCT may also be a risk factor, and perhaps we could simplify the process of screening this women and just have GCT and then follow up these women. So this has already been proposed by the DIPSI guidelines for many years, but now West is also looking at this as a potential strategy for screening more and more women for gestational diabetes. A lot of data now emerging on the use of CGM. We had this little discussion on CGM for use in gestational diabetes and pre-gestational diabetes or hyperglycemia pregnancy in general, and increasing use of CGM for diagnosis and follow-up, and insulin pumps now, especially sensor-operated pumps for management of diabetes in pregnancy, is emerging as an area of both research and clinical use. And I think this is something we should be looking out for. Okay, so finally, again, no presentation of mine is complete without. Sorry, yeah, this is the last couple of slides quickly. So, no presentation of mine is complete without a little bit of technology addition or value addition to this. So we have made this chat bot for diagnostic criteria of GDM. I often get calls from my OBGYN and from my friends and colleagues who practice OBGYN about the diagnostic criteria and cutoff for GDM. So anybody who is in this field or physicians who are working in this area or endocrinologists, can take a screenshot of this. The link is also given below. We have made a chatbot which helps doctors make clear diagnosis of the GDM based on the data. I'll show you a demonstration of the same here, right? So the first thing, obviously you need to have the reports available with you. You need to, of course, type in your name, your a little bit of data we are collecting just so that we can follow up with you in case required. You need to tell us what kind of practice. So glucose values you need to enter. You can use 1 step, 2 step, or you're not sure then, right? So let's say 2 step, 50-gram glucose challenge. We enter the value. It will tell you whether it suggests you positive glucose challenges. Then you can take 100 gram second step glucose values. Let's enter these values and see how it goes, right? So first fasting was 189, 1 hour glucose challenge was 160, 2 hours glucose challenge was 140, and 3 hours challenge was 190, let's say. So it will suggest that this patient has positive for gestational diabetes. So you can use this chat bot if you are confused about the cutoffs, and because now you have so many criteria and cutoffs. So I think you can use this in terms of, we're not unfortunately included DIPSI criteria. We'll add this in future for sure, but at least the currently available ADA and ACOG criteria we have used, and I think it will be useful to anybody who is practicing. So again, these are the link. This is the QR code and the link to this chatbot. It's completely free of charge. Try using this, and please do give me feedback if you find this to be useful, right? So as said in the introduction, we have made this app called Notes in Endocrinology app. It's a useful resource for doctors interested in the field of endocrinology. And then you have this, we also have the Centurion Insulin app that helps doctors, initiate insulin in patients with type 2 diabetes. And recently we launched the Hypothyroidism in Pregnancy app. This app helps doctors manage hypothyroidism in pregnancy better. So, whether the patient is planning for pregnancy, this patient is already pregnant, you can use this app. It's available both on the iOS and the Google Play Store. So thank you for a patient listening. And if you have any questions or queries, you can shoot an email to dromlakhani@gmail.com. And thank you once again to the organizers for having me for this presentation. Thank you.
Thank you very much, Dr. Om Lakhani. I think because of order of time, we can take one question.
Sure, sir. Would love to answer that.
Okay, I'll ask one question. Dr. Lakhani, before getting pregnant, if there is a history of paternal or maternal diabetes, how she should be educated or counseled? What is your opinion? What type of counseling and education she should get?
Yes. So I think, yes, absolutely. It's a good question, sir. If the patient is standing at a strong family history of type 2 diabetes, I think two things you need to do. A, screen this woman before pregnancy or as soon as they become pregnant as early as possible, even the first trimester, screen this woman for diabetes. I think the patient may already be harboring pre-existing diabetes right at the beginning. So this is something we need to do for sure, especially those women who have strong family history. Those women who are planning for pregnancy but may be pre-diabetic or have strong family history and are pre-diabetic. In such women, we all know that pre-gestational loss of weight, especially in obese women, improves the glycemic outcome and improves the overall outcome during pregnancy. Also reduces the risk of preeclampsia, hypertension in pregnancy, other outcomes as well. So I think what I do in my practice is this counsel this women for losing weight before they plan for pregnancy. Generally, a weight loss in the tune of 5 to 7% before pregnancy is a reasonable target to consider. And I think a planned out pregnancy in these obese women, especially with those with strong history of family history of diabetes, is something which is very useful. And again, those women who already have diabetes, don't forget to screen them for retinopathy. Remember, there could be worsening of retinopathy, pre-existing retinopathy, or pre-existing vascular disease. Patient could have nephropathy as well. So anything like that, any vascular disease pre-existing needs to be corrected and screened for before the patient becomes pregnant, or as soon as the patient becomes pregnant, because this could worsen during pregnancy and something you need to watch out.
Thank you. Thank you very much. So without wasting time, we'd like to go to our third speaker, Dr. Shalini Jaggi from New Delhi. Thank you, Dr. Om Lakhani. I would like to request Dr. K.G. Suresh sir, please introduce Dr. Shalini Jaggi and invite her.
Thank you, sir. Dr. Shalini Jaggi is a consultant diabetologist and director of Life Care Diabetes Center, New Delhi. She is also FRCP from London, Edinburgh, and Glasgow, all the three colleges. She is fellow of American College of Endocrinology. She is a National Executive Council member, RSDI, and also governing council member of DIPSI, Secretary RSDI Delhi chapter, and she is serving as AAC Advisory Board member, Diabetes Committee and Lipid and CV Health Committee. She is member of RSDI and also...
I think, sir, we can start because I think we're already short of time, so...
Okay, so Dr. Shalini will be speaking on GDM is mother of non-communicable diseases. Over to you, Dr. Shalini.
Thank you so much, sir, and good morning, everyone. Thank you, Dr. Arvinda, for having me here and letting me talk on a topic which is very, very close to my heart. So without wasting much time, so we've heard two excellent presentations from Dr. Deena and Dr. Om on different aspects of gestational diabetes and pre-gestational diabetes. And I'm going to take a step further and say, why are we talking about gestational diabetes? The reason is not only is there a problem with the index pregnancy if the mother develops GDM, but also we now know that GDM is the mother of NCDs. And if we are talking of the epidemic of NCDs, diabetes, we need to, if we want to stop this, I think you need to start much earlier, even before the baby is born. So the current IDF statistics clearly tell us that hyperglycemia in pregnancy is increasing, just as we say diabetes is going up, and you can see it clearly, Southeast Asia taking the lead with almost 28% age-adjusted prevalence and a raw prevalence of 25.9. In short, this means 1 in 4 live births in the Southeast Asia region are affected by some amount of hyperglycemia in pregnancy. 80% of this is gestational diabetes and the remaining is pre-gestational diabetes. Now, to put things in perspective, FIGO very clearly says hyperglycemia in pregnancy has 2 categories. One is, of course, women who already know about their diabetes, who have either type 1, type 2, or any of the other forms of diabetes and are getting pregnant. That is pre-gestational diabetes. And then on the other arm, you have women who do not have a history of diabetes, but you pick up diabetes once they get pregnant. Now, if it is picked up in the first trimester, we now call it diabetes in pregnancy. And if it is picked up in the 2nd and 3rd trimester, that is true gestational diabetes. So there's always been a gray area because conventionally any diabetes picked up for the first time in pregnancy was called gestational diabetes, and any woman who knew that she's got diabetes and got pregnant was pre-gestational. But now there's a clear demarcation by the ADA, which clearly says if you are picking up diabetes in the 2nd or the 3rd trimester of pregnancy, which is not clearly pre-existing diabetes, that is gestational diabetes. And any woman, if you've diagnosed in the 1st trimester, is still classified as having pre-gestational diabetes or over diabetes. Of course, DIPSI in India is what we all follow. And DIPSI clearly says GDM is any degree of glucose intolerance with onset of first recognition in pregnancy, because we now know that it represents a state of chronic beta cell dysfunction and is just a stage in the evolution of type 2 diabetes. So GDM actually represents chronic beta cell dysfunction already existing in the mother. And because of the diabetogenic stress of the hormones, increasing insulin resistance, you get hyperglycemia, and eventually the woman develops type 2 diabetes if we do not take steps well. Now, the problem with GDM is not only in the index pregnancy, because not only for the mother and the offspring, as Dr. Deena said, a number of complications can occur, but beyond this also the transgenerational transmission that we talk of is very, very important, because a baby who is exposed to hyperglycemia in pregnancy gets primed for long-term outcomes of increased obesity, increased risk of diabetes, metabolic syndrome, and all the NCDs that we are talking of. Not only the mother is at a high risk of developing type 2 diabetes in the future, but she's priming the baby to this NCD pandemic. So the lifetime risk for type 2 diabetes increases in women with gestational diabetes. So they have a 10-fold increased risk for developing type 2 diabetes compared to women who do not develop GDM in pregnancy. And this risk goes up linearly through her woman's lifetime. So with almost 50% of these GDM women eventually land up with IGT within 5 to 10 years of their pregnancy and then convert to diabetes as the time passes. Dr. Om Lakhani touched on this, the increased risk of CVD in women who have GDM, and we have a lot of data which links and says that a woman who's had history of GDM has a higher prevalence of not only metabolic syndrome, but an increased risk for cardiovascular disease, and numerous studies have shown this after adjusting for age, ethnicity, and comorbidities such as preeclampsia and obesity, the risk remains. The ancient Indian literature does talk about the womb being a very, very important influencer on how the baby develops in the future. And this is the Garbha Upanishad where Acharya Chanakya clearly said that the environment in the womb fixes not only the lifespan of the baby, but the future of the baby, including the time of the death, probably hinting at the development of NCDs as well. And this is the modern man, Dr. David Barker, who actually came out with the fetal and infant origins of adult disease hypothesis. Now, what this clearly says is that susceptibility to diabetes, to cardiovascular disease, to insulin resistance syndrome is programmed in utero. The fetal exposure during a critical period in its development to stress factors induces metabolic or physiological functions changes which influence this in the adult life, and this adverse environment in the fetal life and early childhood leads to an increased risk of diabetes. So it's basically the genetics that have loaded the gun, but the environment, which could be the intrauterine environment inducing epigenetic changes, as well as the adverse postnatal environment, which actually set off this gun. So gestational programming is where the stimuli such as the hyperglycemia occurring at a critical or sensitive period of fetal development lead to permanent changes in the structure, the physiology, and the metabolism of the fetus, predisposing this fetus to all these adult NCDs that we talk of in the future. So the origin of these adult diseases lies in the fetal environment. Fetal insulin hypothesis again talks of the maternal glucose concentration, which actually transplacentally increases the glucose concentration of the fetus, resulting in hyperinsulinemia in the fetal pancreas also, which impacts the fetus birth weight. So the famous Pedersen hypothesis that we talk of about the influence of maternal hyperglycemia resulting in macrosomia basically talks of this transplacental transfer of glucose, producing a state of carbohydrate surplus in the fetus, increasing insulin secretion, stimulating protein, lipid, and glycogen synthesis, resulting in not only a macrosomic fetus, but also a fetus born probably with complications such as neonatal hypoglycemia, polycythemia, or even respiratory distress syndrome. Norbert Frankel went a step further and said it's not only the glucose, but the entire gamut of maternal fuels, which includes the fatty acids and the amino acids, that produce what is called the theory of fuel-mediated teratogenesis, which says that a surplus of all these fuels is the basis of the long-range anatomic and functional changes in the fetus. So basically, all of these fuels transplacentally produce a state of hyperinsulinemia, resulting not only in a baby who is born large for gestational age, but predisposing this baby to all these metabolic problems, obesity, IGT, diabetes, and CVD after birth. So the vicious cycle of diabetes begetting diabetes continues. More so, if the child born to this gestational diabetic mother happens to be a male, if this child grows up to be obese, develops IGT, so the diabetes continues in the next generation. But if the fetus is a female, this female also gets primed. So when she becomes obese in her pregnancy, she is at a high risk of developing GDM, and then eventually post-pregnancy converting to diabetes, and the cycle goes on and on. So women with a history of GDM are at an increased risk of future diabetes, predominantly type 2 diabetes, and so are their children. And we now have sufficient data to tell us that there is a transgenerational transmission that occurs. So NCDs adversely impact the maternal health, and on the other side, the poor maternal health again increases the risk of NCDs. So both maternal overnutrition and maternal undernutrition program the fetus adversely to develop diabetes and all these NCDs in the future. So on the one hand, you have in utero overnutrition, probably because of an obese mother with gestational weight gain, or a mother developing GDM, inducing epigenetic changes in the genes of this developing fetus, resulting in this baby born with an altered physiology as it grows up, increasing insulin resistance, increasing beta cell dysfunction, increased risk of obesity, diabetes, and CVD in the offspring. On the other hand, in India, another very common feature is maternal undernutrition. So an increased nutrient demand more than the placental supply, resulting in hypoxemia, metabolic changes, endocrine changes. All of these again cause structural changes within the organs, programming this fetus not only to poor childhood growth, but metabolic and endocrine dysfunction. The DOHAD hypothesis talks of all these different environmental exposures, and we now know DNA methylation is very, very important. All these different epigenetic changes that are produced, they influence the later trajectory of how this child grows to be an obese child, a pre-diabetic child, or eventually somebody developing diabetes in the future. So hyperglycemia exposure to hyperinsulinemia, inflammation, and oxidative stress, all of which are components of GDM, produce an adverse intrauterine environment, and these are the offsprings who are eventually born not only with anatomical malformations if this happens in early pregnancy, but eventually neurophysiological defects, hypothalamic dysfunction, obesity, delayed neurocognitive development, neuropsychiatric disorders, anxiety, neurodegenerative diseases. So the entire gamut of NCDs that gets primed right in the womb. The sterile inflammation that is produced in GDM dysregulates expression as well as activity of different placental, adipose tissue, and skeletal muscle pathways, which eventually result not only in placental dysfunction, endothelial dysfunction, and enhanced state of inflammation, inflammatory markers, and the offspring gets primed not only to the short-term outcomes of macrosomia and an increased fat mass, but the long-term outcomes of an increased risk of obesity, diabetes, and metabolic syndrome. So friends, GDM plays a crucial role in increasing the prevalence of diabetes and obesity, and is now very clearly known as the origin of all the cardiometabolic diseases that we talk of. A suboptimal in utero environment impacts all the organ systems in the body, as you can see here, and therefore it is important that we nip it right in the bud. We now have data on the influence of diabetes in pregnancy on negative outcomes when it comes to the respiratory disease. So pre-gestational type 1 or type 2 not only results in the malformation, major morphological abnormalities when the baby is growing up, the organogenesis defects, but gestational diabetes per se can result in alveolar sac formation, surfactant production during 26 to 36 weeks of gestation, resulting in functional defects and mechanisms, and the child may even be born with COPD and all the different respiratory conditions that we talk of. So consistent with this decreasing plasticity of the epigenome that I talked about, all these epigenetic changes which are predisposing this baby to develop NCDs in the future, when we're talking of breaking this cycle, the impact will be most if we make an effort right in the preconception, in the periconception, and in the prenatal period, rather than after the child has been primed and is born and becomes obese and we tell him to lose weight to avoid diabetes. So GDM plays a crucial role in increasing the prevalence of diabetes and obesity, and that is why universal screening and prompt management of all pregnant women for glucose intolerance is very, very essential. It has to be taken up as a public health priority. We know that all the interventions that can come in very early on, resulting in a baby born appropriate for gestational age, goes a long way in preventing obesity, IGT in the offspring, and trying to stop this pandemic of NCDs. Preventive measures against diabetes need to start during the intrauterine period itself and continue throughout the life cycle of that child if we want to stop the NCD pandemic. So GDM offers an important opportunity for the development, testing, and implementation of clinical strategies when we're talking of diabetes prevention. So like I said, on the one hand, maternal undernutrition, on the other hand, maternal overweight, all of them predict the development of NCDs. And the solution is a baby who is born neither SGA nor LGA, but with an optimal birth weight to prevent, so that the priming can be taken off right in the bud. Female gender is the key to NCD prevention, and we now know that a child who is born either above or lower birth weight in adult life has an elevated risk for obesity, diabetes, hypertension, and CVD. And the intergenerational transfer of risk can be stopped if we take care of the mother right in the beginning, even in the preconception period, before she becomes pregnant, so that the next generation can be protected. So maternal health is actually the link to the NCD epidemic, and we need to look at that. That is very, very important if we're talking of NCD prevention. So the goal of GDM is management, early detection, screening, everything is not only to improve the perinatal outcomes in the current pregnancy, but also to prevent this long-term maternal and fetal effects. So friends, if glycemic control can be maximized to an extent that the fetus no longer recognizes that the mother has diabetes, then the treatment of mother during pregnancy may eventually be the first step when it comes to preventing obesity and diabetes in the offspring, or the NCD pandemic that we are talking of. So to sum up, GDM actually we now know is the mother of NCDs and offers us a window of opportunity to do something proactively, to provide maternal care services, to reduce the traditional maternal and perinatal morbidity and mortality indicators, and address this intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease, and stroke. So we as clinicians have this rare opportunity to actually alter the natural course of disease and change the future health of women and their offspring today. So GDM is definitely the mother of NCDs, and therefore we need to take it as a window of opportunity if we want to prevent NCDs. And like the father of GDM in India, Professor Viseshia, clearly says, if we want to achieve a diabetes-free generation, it's time that we focus on the fetus for the future. Thank you so much.
It was a very vibrant presentation from Dr. Shalini Jaggi. Thank you very much. You have covered all the aspects of GDM, its impact to give birth of NCDs, and its impact in the fetus and the children later. So without wasting time, I would like to invite only one question, because we are going ahead of time.
It was an excellent presentation, Dr. Shalini. And one more thing, you finished in correct time.
Thank you so much. Just a quick addition, Dr. Om Lakhani was reviewing all the future aspects. You know, I was reading this paper that now links the sex of the fetus also to a future risk of GDM. So, you know, if the mother is carrying a male baby, the risk of GDM in the next pregnancy goes up compared to a mother who's carrying a female baby. So they say if the fetus is a female, then the mother already, there is some kind of beta cell dysfunction which is already there. But if the fetus is a male, so even if she does not develop GDM in the first pregnancy and she's delivered that child, the risk of GDM developing in the second pregnancy goes up compared to the first child being a girl child. So, you know, so that's how the field is evolving. I mean, this is just data from Dr. Ravi Ratnakaran's group from Canada. He went back and retrospectively looked at 6 lakh pregnancies. And that's how they've come up to this. So this is a field that is just opening up. And I think we just need to keep our eyes open and see what we can do to actually pick up GDM early, the risk factors for GDM, and try and nip it in the bud if we're actually talking of diabetes prevention.
Thank you very much, Dr. Shalini Jaggi. Thank you very much for your presentation. And Dr. KG Suresh, sir, I think we should conclude the session, isn't it?
Thank you. On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit, I wholeheartedly thank Dr. KG Suresh, Dr. Mridul Das, Dr. Deena Shrestha, Dr. Om Lakani, and Dr. Shalini Jaggi for their wonderful deliberation and for their valuable time and for being a part of our conference. Thank you so much. Thank you.
Thank you.
Thank you so much. Pleasure being here. Thank you.
Thank you.
So moving on to your next session, which is an important session, much awaited session, that is oration by Professor Anup Mishra. So to chair this session, I welcome Dr. R. Suman from Bangalore. He is the diabetologist and the occupational physician, MBBS D&D, fellowship in diabetes, PG diploma in industrial hygiene. He is the current chairman of RSSDA Karnataka chapter. And Dr. Syed Zawaj is the chief consultant diabetologist at Diascope Polyclinic and Laboratory, Bangalore, India, and medical superintendent and trustee at Bangalore Diabetic Hospital, Bangalore, India. So we welcome you for this session. To give the oration today, that is Lord Sri Basaveshwara oration. So to tell few points about Lord Basaveshwara. So Lord Basaveshwara was politically known as Basavanna. He was a 12th century Indian statesman, philosopher, poet, and a Lingayat social reformer in the Shiva-focused Bhakti movement and a Hindu Shaivite. He was active during the role of both dynasties, but reached the peak of his influence during the rule of King Bijala II in Karnataka, India. He spread the social awareness through his poetry, popularly known as Vachanas. He rejected gender or social discrimination, superstition, and rituals. So for this reason, he is the biggest social reformer in India, especially in Karnataka. So on his name, we have formed this particular oration, which is an important oration for all of us. To deliver this oration, we have honored to have Professor Anup Mishra, Padma Shri Professor Anup Mishra, who is the leading endocrinologist from New Delhi. Can we have your CV, please? Professor Dr. Anup Mishra is the Executive Chairman, Fortis CDOC Hospital for Diabetes and Allied Sciences. He is the Director, National Diabetes, Obesity and Cholesterol Foundation. He is the President, Diabetes Foundation, former Professor, All India Institute of Medical Sciences, New Delhi, former faculty, UT Southwestern Medical Center at Dallas, Texas, USA. His major achievements is more than 300 published research papers analyzed by Stanford University to be among top 2% scientists in diabetes from India, ranked globally. He is the editor-in-chief for Diabetes and Metabolic Syndrome, that is the Clinical Research and Review, Elsevier. He is Clinical Keys and Elsevier. He is the Associate Director of Journal of Diabetes, European Journal of Clinical Nutrition, member of Academic Board of British Medical Journal, member Lancet Commission on Obesity, awards Padma Shri Award by President of India in 2007, Dr. B.C. Roy Award in 2006. His author of book is Diabetes with Delight in both English and Hindi. We are extremely honored to bestow Lord Basaveshwara oration to Professor Anup Mishra. We heartily congratulate Dr. Anup Mishra for this prestigious oration, and I request Dr. Anup Mishra to proceed with the oration. Before that, I would like to ask our chairperson, Dr. Suman and Dr. Javas, to say a few words, please.
Thank you, Dr. Arvind. And as you know, told by you, we have really taken bath with your soap and we are fresh. Probably sitting in the conference. And probably this is one of the greatest ever conference what we have attended. A lot of insight has been given across, and probably to bestow upon the Basaveshwara oration to Sir Dr. Anup Mishra sir is something very great actually. who will be talking about the difficult phenotypes of pre-diabetes. Like to hear from him. We'll just start off.
What do you say?
Thank you. Thank you, Dr. Arvinda. It's indeed an honor for me to present this lecture in the name of a great reformer who thought well ahead of time. Thank you once again, all of you, for giving me this opportunity. I'll be talking about difficult phenotypes of prediabetes. One would think that prediabetes is an easy entity, and that it actually is just intermediate condition leading to diabetes and does nothing. But I'll clarify that this is not so, and also dwell upon some of our research papers which deal with prediabetes and also reversal of prediabetes. So just to start, what is prediabetes? Just to recap, most of you know about this. But there are two components to prediabetes. There's one, impaired fasting glucose, other is impaired glucose tolerance. The definition is impaired fasting glucose between 100 to 125, and post 75 gram glucose, if it's between 140 to 199, it's impaired glucose tolerance. It's also defined by hemoglobin A1C between 5.7 to 6.4, but I would probably rely more on oral glucose tolerance than hemoglobin A1C for diagnosing either pre-diabetes or diabetes. Now, if you see this classical diagram from 2005, it shows rise of insulin resistance and also decrease in the insulin secretion and the rise of postprandial and fasting blood glucose. Now, if you look at this specifically, the years before diabetes, the fasting and postprandial blood glucose start rising, but the postprandial blood glucose rises earlier than fasting blood glucose. Hence, just to diagnose any diabetes or any pre-diabetes just based on fasting blood glucose is going to be faulty, and you must consider a post-glucose 75 gram glucose load blood glucose, add on to this and complete the test to diagnose pre-diabetes and diabetes. Now, pre-diabetes is prevalent to India, and the next diagram will show you that, and this is our study in the Annals of Epidemiology. My colleagues and myself, we analyzed 1.7 million adults and put this diagram. Now, this diagram is based on number of studies, and if you see on the right side up panel, there is rise of diabetes, that we know. But what is more important in the panel below is rise of pre-diabetes. And if you look at this, the more importantly, rise of pre-diabetes in the rural population. So overall prevalence of diabetes is pre-diabetes is 10.3%, but it is more so in urban areas, less in rural areas, but rising fast in the rural areas. Now, pre-diabetes is pathological from multiple points of view, but I'll show you just one point of view. The time does not permit to show other pathological aspects of pre-diabetes. The most important aspect of pre-diabetes is heightened cardiovascular risk. And this diagram from 2 decades back, an excellent study which was published in Diabetes Care shows that the moment you become pre-diabetic and especially impaired glucose tolerance, then your risk of cardiovascular disease is almost double. And the moment you become newly diagnosed diabetes, it's almost triple. So pre-diabetes is pathological and is associated with elevated cardiovascular risk. So the emerging questions are, do Indians convert from pre-diabetes to diabetes faster than other races? This is particularly important for implication, and it has implication for application of lifestyle and other strategies. Besides heightened risk of cardiovascular disease, does pre-diabetes decrease lifespan? Now, this is a very important question, and hardly any studies have been done worldwide. Which factors hinder reversal from pre-diabetes to normal glucose tolerance? So we need to be aware of these factors so that if these factors are present in a particular person, then we may have to be aggressive in our strategies. And finally, does vitamin D deficiency increase risk for prediabetes or diabetes? And what happens when we supplement vitamin D in individuals with prediabetes? Each of these questions will be answered with the help of international data and with the help of data generated by us. Now, ethnicity, as far as Indian population is concerned, whether prediabetes converts faster to diabetes, and the next diagram very nicely shows that. And this is a diagram by my colleague Namit Sattar from UK, published in Lancet in 2015. I don't think any diagram has bettered this diagram since then. And if you look at this, the pre-diabetes rise in the Indian population is fast, and conversion to diabetes is also fast. And the difference between the pre-diabetes converting to diabetes in Indian population versus Caucasian population is almost a decade. The progression to diabetes is 12 to 18% roughly per year in Indian population versus progression to diabetes is only 5 to 11% roughly per year in the Caucasian population. So much slower progression in the Caucasian population. And furthermore, if you apply the lifestyle strategies to the Indian population, it is reduced by 30% with the present lifestyle intervention. And in Caucasian population, it is reduced much more than 50% with the present lifestyle intervention. So what does it mean? Faster conversion from pre-diabetes to diabetes and slower reversion or less incidence if we apply the same lifestyle strategy to the both population. So something is wrong in our bodies, that the blood sugar rise is faster and does not come back to the normal glucose regulation. And I shall discuss some of these factors subsequently. Now, pre-diabetes in Asian Indians decreases leukocyte telomere length. Now, what is leukocyte telomere? I'll explain to it next slide. This is surrogate for longevity, and especially when they have truncal obesity. Now, this is our recent research, but before that, the shortening of leukocyte telomere length is not a good news. Now, this is the telomere at the end of the chromosome, and if the telomere length is favorable, then aging is healthier. And if telomere length is unfavorable, there is accelerated aging. So a shorter telomere length means the problems are much more, and is going the aging is going to be faster. Now, this particular paper, we only took the pre-diabetic women. 797 women were recruited, and the leukocyte telomere length was quantified by quantitative polymerase chain reaction, and subjects were separated into quartile group according to LTL. Now, if you look at this, the correlation between the LTL and various parameters, there are a number of parameters that we took. And if you look at the central skin fold thickness centrally, over the trunk, peripheral, the total skin fold thickness, peripheral plus central skin fold, the body mass index and body fat, all correlated very well to the shortening of leukocyte telomere length. Now, if you look at this particular diagram, the black bars are the first quartile, and this is where the shortest telomere length is. And then there are other quartiles. So the skin fold thickness were actually divided into 4 quartiles according to leukocyte telomere length. And if you look at this, the higher the skin fold thickness, the shorter the telomere length. And this is particularly apparent in the central skin fold, which is subscapular skin fold and suprailiac skin fold. And if you combine all skin folds together, total skin fold. So truncal fat is doing something bad to the leukocyte telomere length. It is shortening, and this is bad for longevity. So in the multivariable linear regression analysis, central skin fold, total skin fold, BMI, and body fat were all correlated to the leukocyte telomere length. So what does this study add? The leukocyte telomere length is linked with aging and associated diseases such as obesity, type 2 diabetes, and cardiovascular disease. This study, what does it add? This is the first study to investigate the relationship of LTL in women with abnormal fasting glucose. This is the first study worldwide. Specifically, relationship of LTL with subcutaneous adiposity, particularly in truncal area. Now, truncal adiposity, we have been stressing that truncal adiposity is something which is very bad as far as Indian population is concerned. So this is being reported in women for the first time, and in women with abnormal fasting glycemia. Just the diet will not be enough. Diet, lifestyle, everything to reduce the adiposity and truncal adiposity is particularly important. And this is particularly important in women in the middle ages and women who are around the menopause. Now, going further, prevention of prediabetes to diabetes. There are a number of studies are there. And this is the most important study, diabetes prevention program, which was done a number of years back, 2 decades back. 3,234 patients with impaired fasting glucose and impaired glucose tolerance without diabetes were subjected to lifestyle, metformin, and placebo. Now, look at this. Cumulative incidence of diabetes was best decreased by the lifestyle and then by metformin by 31% as compared to the placebo. So this was a 4-year study, and then subsequently the study, the control trial was opened, and the patients were told to go back to their general practitioner, but were followed up for 15 years. And this is the DPPO study, 15 years after the DPP study, published in Lancet in 2015. And look at the graphs now. Now, graph lifestyle is slightly weakening here. The incidence of prediabetes is slightly increasing in those with the lifestyle alone, and those who were on metformin alone, the incidence is decreasing. So two graphs are converging together. And I wrote editorial on this particular article, and we wrote that there are more, the more the answer, there are more questions which are emerging as far as prevention of prediabetes is concerned. Now, this has been done in the Indian population as well by Dr. Ramachandran, and this is the classical DPP study as far as India is concerned. However, in this study, there is no divergence of graph between lifestyle and metformin. Metformin plus lifestyle and lifestyle all had similar reduction as far as the incidence of diabetes is concerned as compared to controls. Now, going further, what are the phenotypes or genotypes which may impede prevention of diabetes? Now, one of the first one is the age. Now, age is often considered for any lifestyle prevention strategy or lifestyle application strategy. And if you look at the DPP trial, there are 3 age groups here, 25 to 44, 45 to 59, and more than 60. And the lifestyle versus metformin versus placebo, and look at the more than 60 years of age, where lifestyle is actually working more in reducing diabetes versus the metformin. So younger ages, metformin may work more, older ages, lifestyle may work more. Going further, non-obese individuals. And non-obese individuals, they're likely to be low insulin secretors. They may convert to diabetes pretty fast. Now, if you look at these data from 2007, number of ethnic groups have been compared. Indians, Japanese, Maltese, Europeans, Chinese, and there are according to BMI, prevalence of diabetes has been calculated. And if you look at that, Indians at the high risk group at any BMI, even at the low BMI below 20. So Indians are the only group which are developing diabetes at a low BMI versus the other group. So something wrong here. Indians have possibly the problem with the insulin secretion, especially when they have low BMI. And this has been time and again proven that those people who are obese versus those people who are lean, they have the lean people have less beta cell mass. And this is one of the autopsy studies which clearly shows that in lean people, the beta cell mass is lower. Going further, early remission of prediabetes. Now, suppose a person comes to you with a prediabetes and we try to do everything possible, lifestyle measures, etc., metformin, whatever we want to do. And we have a remission of prediabetes early on. What does it mean? Now, this is the DPPOS data, which shows that if you have early remission of prediabetes and then patient may revert back to prediabetes again or diabetes, there is less incidence of diabetes versus those who never reached remission in diabetes prevention trial. So initial 4 years of the diabetes prevention trial, those who reached remission at least once did not have that much cumulative incidence of diabetes as compared to who. So one should try to be aggressive in initial part of prediabetes to remit these people into normal glucose regulation. Now, there are a number of other phenotypes, and liver is one of the most important phenotype. And liver, the enlargement of liver, non-alcoholic fatty liver disease not only predicts diabetes, but impedes regression to normal glucose regulation. Now, we published some time back in 2015 that if this is the normal liver, the usual span of the liver, which can be measured by ultrasound, is 11 centimeter to 12 centimeter approximately. And if this span increases, this is the typical grade 3 fatty liver with the liver span of 22.8 centimeter. And we calculated that if span increases more than 15.6, so any person with the ultrasound can measure the liver span and look at this. And if span is more than 15.6, the possibility of having diabetes is more than 4 times. So this is regarding liver and having a possibility of diabetes. What about having a liver in a patient with in a pre-diabetes and regressing this person to trying to regress this person to normal glucose regulation? Now, this is a very good trial by Stefan et al. In 2015. Now, there is one phenotype which is a high-risk phenotype. They have insulin resistance and non-alcoholic fatty liver disease. And the other phenotype is the low-risk phenotype, all other traits. Now, 9 months of lifestyle intervention, fat loss is much less in those people with non-alcoholic fatty liver disease. Postprandial glucose decrease also was less, and reversion to normal glucose tolerance was 31% in people with high-risk phenotype versus 67% in low-risk phenotype. So liver and insulin resistance are doing something to actually impede reversion to normal glucose tolerance. There are various other phenotypes which have been implicated, and these are 6 types of phenotype of prediabetes. Now, I'll not delve into all phenotype. This is the low-risk phenotype, this is the very low-risk phenotype, and low-risk obese phenotype. So let's leave that and look at the other phenotypes, number 3, number 5, and number 6. They were overweight or obese, but number 3 has beta cell failure, number 5 have high-risk insulin-resistant fatty liver, which I just showed you, and number 6 is high-risk visceral fat with nephropathy and renal sinus fat. Now, these have imminent danger of going into the diabetes category. And also, besides the danger of going into diabetes category, number 6 has high mortality rate. So within the pre-diabetes, there are a number of phenotypes, and they will depend on the presence of insulin resistance, presence of insulin deficiency, presence of fatty liver, presence of intra-abdominal or subcutaneous fat, and also the renal sinus fat. Now, a word about gestational diabetes. We've heard so much about the gestational diabetes in the previous lecture. What about after gestational diabetes? Gestation has occurred, and then subsequently, what is the risk of converting into diabetes? Now, this should be considered as one of the difficult phenotypes. Now, this diagram shows you that the risk is very high in first 5 to 10 years, and then possibly levels up, although there are not many studies between 10 to 20 years. One in the Indian study shows that at median of 20 months following delivery, dysglycemia was found in 57% of patient, diabetes in 10%, and pre-diabetes in 47.2%. So Indian population may be more predisposed to develop diabetes after gestation of diabetes, after delivery, and they should be told, many of them are not told, that a proper lifestyle and reduction of weight is what is absolutely important for prevention of diabetes. Now, what about some unknown factors? One of the unknown factors is pancreatic fat, and we have recently researched pancreatic fat in some of our studies. Now, look at these two pancreas. On the left side is non-obese case of type 2 diabetes, young person with a non-obese BMI, body fat of 29.4%. On the right side is non-obese but non-diabetic subject, age 25, young age. Again, BMI is normal and body fat is 27.2%. And these two pancreas are different. The person with diabetes has a higher volume of pancreas, meaning thereby that the fat in the pancreas is much more. Now, what does the fat in the pancreas do? The next slide will show you. Now, this slide shows the beta cell, a clean beta cell, adipocyte-free islets. Here, this one. And the slide below shows that the fat cells are encroaching the islets. Look at this. And the moment fat cells are encroaching the islet, there is an influx of inflammatory cells and release of cytokines, which may decrease insulin secretion. So fatty pancreas is the emerging entity which may cause decrease in the insulin secretion, and the diabetes may occur fast or may progress fast. Now, how can we reverse this? How can we reverse this kind of fatty pancreas? Now, fatty liver and fatty pancreas both can be reversed. Now, reverse, or at least the fat decreased. Now, this is one of the first studies which formed the basis for reversal of diabetes, where 11 obese patients were taken and 600 kilocalorie diet were given to them, very low calorie diet. And they were followed up for 1, 4, and 8 weeks. Now, look at this. The fasting plasma glucose normalized within the first week, and they did not need any treatment. And then look at the hepatic fat. It decreased from 12.8 to 2.9% in 8 weeks. And now remember these figures because I'll come to these figures in subsequent slides. And the pancreatic fat content also decreased from 8% to 6.2% in 8 weeks. These authors said, and they continue to say till now, that if we decrease hepatic triglyceride content and pancreatic triglyceride content, we may have a better diabetes, we may reverse diabetes, and this is basis of reversal of diabetes phenomenon, which has gone on and has been applied in the community. Now, what we did was we used a drug to decrease hepatic triglyceride and pancreatic content. Now, this we published recently in Journal of Clinical Endocrinology and Metabolism. These were overweight, obese patients which are uncontrolled on metformin and sulfonylurea for at least last 8 weeks. We measured hepatic and pancreatic content with MRI proton density fat fraction, and these patients were followed up for 90 days. Now, look at this, the skin fold thickness. Take any skin fold, it decreased over that period of time with the use of dapagliflozin, which was given for 90 days. And 120 days. The liver fat decreased from 15.2% to 10.1%. In limb study, which I projected previously, it decreased up to 10%. So it was not so much, but 5% at least. Reduction of pancreatic fat was much more impressive, from 7.5 to 5.99%, 1.5%. Limb study, it was 1.8%. So what does it mean? That not only it can better the diabetes, skin fold, and insulin secretion, which is shown in the next slide, the C-peptide and insulin secretion, they all become better. It has potential for reversal of diabetes. So those who cannot tolerate a 600 kilocalorie diet, we can use some of these drugs for attempted reversal of diabetes. Now, another very simple point is dorsocervical and chit fat deposition. Now, it can have a genetic basis, it can have non-genetic basis. We, sometime back, in around 14 years back, we correlated double chin and excess fat deposition over the neck to the metabolic syndrome and diabetes. Now, this idea was not novel. I'll show you. This is the double chin. This is the buffalo hump. Idea for buffalo hump was taken from Cushing syndrome and HIV-associated lipodystrophy, which have high prevalence of diabetes. And idea for double chin was taken from the familial partial lipodystrophy patient. This is the autosomal dominant condition where there is excess fat deposition over the neck. Look at the MRI neck is full of fat versus MRI neck of normal people. And these people have almost no fat over extremity and abdomen. They have early onset of diabetes and other multi-system dystrophy associated, and the mutation of LMNA gene here. So we took these two markers, and these two markers may, if you find in any person, you look at the neck, along with acanthosis nigricans, buffalo hump, and double chin, may find a marker which may portend early onset of prediabetes and diabetes, and we do not know whether presence of these actually will impede conversion of prediabetes to normal glucose regulation. We have yet to prove that. Now, another unknown is whether the muscle mass, our bodies have less muscle mass, Indians have sarcopenia, whether low muscle mass and we have excess body fat, whether this ratio actually impedes conversion from prediabetes to normal glucose regulation and faster conversion from prediabetes to diabetes. Now, in this respect, we investigated a gene, a gene called myostatin gene, which when mutated caused muscle hypertrophy in infant. Look at the muscles here versus normal people. And we looked at the polymorphism of myostatin gene, and we found that the polymorphism of this myostatin gene was correlated to low muscle mass and high body fat. Now, this is the phenotype that we have. Further research is required. Ours is the only study from India as far as this gene is concerned. And finally, coming to the low vitamin D. Now, vitamin D is enigma, associated with various diseases and associated with also low insulin secretion, high insulin resistance, prediabetes, and diabetes. Now, some of the early studies, this is one of the early studies, which show that if vitamin D is deficient versus vitamin D is sufficient, the metabolic syndrome in those who have sufficient vitamin D is much lower, and abdominal obesity and hyperglycemia. Look at this. This is the odds ratio. So this is one of the early studies. And then subsequently, we showed that the abdominal obesity is clearly correlated with low vitamin D in this particular publication, and specifically subcutaneous fat. We've been talking about subcutaneous chuncal fat, subcutaneous fat, and this correlation was very, very strong. And also showed that non-alcoholic fatty liver disease was correlated with low vitamin D and high parathyroid hormone levels. Number of association studies, look at this, which showed that blood glucose or insulin levels or insulin resistance is correlated with the low vitamin D levels. These are heterogenic studies, but the association was almost uniformly seen. We also showed, we published in BMJ, that the lower the vitamin D level, and look at the low vitamin D levels here, the higher is the fasting blood glucose in women. But controlled interventions where the vitamin D has been given to people and then their blood sugar and insulin resistance has been checked, show a different story. Now, look at this. These are controlled, randomized controlled intervention of vitamin D supplementation in countries other than India. It shows that hardly any study shows a positive result. And one of the largest study, this particular study, Pitta's study, D2D study, did not show any association. But many of these studies were done in people who are not vitamin D deficient. Now, the meta-analysis show that though there may be modest reduction in A1C compared to placebo in patients when the vitamin D is given, the repletion of vitamin D deficiency, there is a greater mean reduction of A1C. So those with vitamin D deficiency, if we give vitamin D, there is a greater reduction of hemoglobin A1C, and similar findings were shown in another meta-analysis. Now, these are Indian studies, and our study is at the top. It is a long study, 18-month study versus other studies. But surprisingly, Indian study, wherever the vitamin D has been given, show positive association. And this is our study, which was published in Scientific Report. 121 females with pre-diabetes and vitamin D deficiency were randomly allocated to intervention and placebo groups. And the fasting blood glucose, 2 hours oral blood glucose, post-load blood glucose, hemoglobin A1C, a reversal to normoglycemia was followed up for 78 weeks. And look at this. The subscapular skin fold thickness improved in those patients who received vitamin D versus the control group. And more patients reverted to normal glucose regulation. So pre-diabetes became less and normal glucose regulation became more, whether you take fasting blood glucose or post 75 gram oral load blood glucose, both ways. So this is one of the strongest studies that 78 weeks of replenishment of vitamin D in patients with pre-diabetes decreased truncal subcutaneous fat, and we have been talking about truncal subcutaneous fat, and reversion to normoglycemia from pre-diabetes in many individuals. So finally, I summarize. Pre-diabetes is an important intermediate condition which identifies those at risk for diabetes and coronary artery disease. It is common in Asian Indians, and conversion to diabetes is faster than whites. Identification of difficult phenotype which may impede conversion of pre-diabetes to normal glucose regulation is important for every clinician, and application of aggressive lifestyle and medical therapy is warranted here. Among these important are young age, absence of quick remission with lifestyle measures, history of GDM, and presence of non-alcoholic fatty liver disease. More research on several proposed phenotypes, for example, pancreatic fat, and we have been researching on this question for some time now. Low muscle mass, again, our research focus, and genotypes are needed. And vitamin D, we have been researching again further on this, has potential for reversal of pre-diabetes, but more data are needed. So thank you, Arvind, once more for giving me this opportunity and present my data in front of all you people. Thank you.
So thank you so much, sir. It was a wonderful oration. I know that orations we usually don't have questions, but we take an exception because you are here, and if that will take this opportunity to have a discussion. If anybody has any questions, kindly post to Professor Anup Mishra, please. Okay, so thank you so much, sir. Thank you so much for your valuable time and insight. We are really honored from our center and ADC International Diabetes Virtual Summit for your wonderful Basavareshwara oration. So I thank you so much from the bottom of my heart for your valuable time and for being a part of our conference, sir. Thank you so much. Dr. Jawaz, you have to say any few words?
No, it was a very excellent and self-understanding and very self-explanatory facts which sir has brought up. Congratulations on behalf of Dr. Ravind also. I congratulate and do namaste to Dr. Mishra sir. Now we will be going ahead, I think.
Thank you. Thank you, Arvind, and thank you, everybody. Thank you so much.
Thank you, sir. So moving on to next session, again chaired by Dr. Suman and Dr. Jawaz. Over to you, Dr. Suman.
Thank you, Dr. Arvind. I think probably this is a newer session, what we are doing, something called as a newer updates. To have here, we have got two speakers. First one will be Dr. Osam Ghazi from Egypt. Can have this one. TV, please. Yeah. Dr. Ghazi is a lecturer at Internal Medicine, Faculty of Medicine at Mansouri University, Egypt. He's a consultant diabetologist and endocrinologist at the same hospital. He has completed PhD degree in 2017, and he's in general medicine. He has a diploma in diabetes in Cardiff University. He has a diploma in endocrinology from South Wales University, member of scientific committee in International and Pan-American, Pan-Arabian Diabetes Conferences and Arabian Diabetes Forum, a reviewer of the national, international and Egyptian journals. His interest in the field of diabetes in the elderly and intervention thyroidology. He's going to talk about mitochondria, the newer player in the type 2 diabetes management. So good to hear from you. Probably we'll start out.
Good morning, everybody. Thank you first, Dr. Aravenda, for kind invitation. And actually, I'm to be happy always with any activity of my colleagues from India. Today, I'm going to talk about the mitochondria, which is the newer player in the type 2 diabetes. First, this is my city. I'm living here in Mansoura, which is about 80 kilometers to the north of Cairo. This is the Faculty of Medicine, in which I am working as a lecturer of internal medicine there. And this is my hospital in which I'm working as a consultant of diabetes, and our unit is present here. Before I start, this is my disclosure. I do not have any conflict of interest for this lecture. When you are going for the basic science from the undergraduate studies, all of us know that the mitochondria is the home of the energy to the body. Simply, we can say that the mitochondria is having respiration. This respiration is simply when the oxygen is entered to the mitochondria, the glycolysis is happened, and about 38 molecules of ATP was liberated, and then the hydrogen is excreted from the mitochondria. Actually, the mitochondrial dysfunction is linked to many of the diseases. Our colleagues in the neurology was first describers for this mitochondrial dysfunction among a lot of muscular disorders and neurodegenerative disorders. Then our colleagues in the oncology. Then now we started to enter in the track by linking the mitochondrial dysfunction with the type 2 diabetes and the obesity. Actually, more than 10 years, there is a starting papers to link. There is a mitochondrial dysfunction in the patients with type 2 diabetes. At the first, we are thinking that the mitochondrial dysfunction may lead or may be a result from the dysglycemia which is happening and may lead to complications in the patient with diabetes. But now the way is thinking, and we need to rethink our mindset that the mitochondria now may be a pathogenesis of type 2 diabetes. Simply, how we can measure the mitochondrial dysfunction, this apparatus is called the seahorse technology. This seahorse technology or this seahorse apparatus is simply measuring the mitochondrial function. How this is done, I will explain later. But if you imagine that this is the mitochondria, the oxygen here is entering. This apparatus can measure what's called in the left upper diagram, which is the oxygen consumption rate, which is measuring the entering oxygen to the mitochondria. Then the same apparatus can release a graph, which is explaining the hydrogen release from the glycolysis procedure, which is linked in the apparatus as an extracellular acidification rate. So we have the OCR and the ECAR, which is linking to the mitochondrial dysfunction. Normally, as you see here, with increase of the oxygen enter to the mitochondria, it is associated with increased hydrogen from the glycolysis, which is mean that there is a good mitochondrial function. If there is a problem in the phosphorylation, so there will be a discrepancy between the oxygen entry to the cell and the hydrogen exit from the mitochondria. Actually, this is the apparatus. We take a blood sample from the patient, and it's put here in this special kit and with a special preparation. And this is the graph which is giving us analyzing for the data to make us know if there is any mitochondrial dysfunction among this person. Simply, the procedure is having, or this apparatus, the seahorse apparatus, is having a fluorescent sensors, which is linking, as I said, the OCR and the ECAR. Actually, this apparatus is not yet present in Egypt, but I have some training on it in a scientist training course sponsored by the ASD in Copenhagen and Steno Diabetes Center. And it is a bit expensive, but it is still under trials. So all of that part is a theoretical part. All of us are clinicians. Why we are needing this apparatus? How can we apply this among the patient with type 2 diabetes? Actually, the application is in trying to find a treatment for diabetes. And one of the most recent drugs, which is expected to be launched in the next few years, which is the Glimens. Glimens is the name of the family. All of us remember more than 20 years that Professor DeFronzo said that the patient with type 2 diabetes is having 3 problems mainly. It is an impaired insulin secretion as a response to hyperglycemia and increased hepatic glucose production in a state of postprandial and excess increase in the state of fasting and decrease the glucose uptake by the muscle. If we remember from the undergraduate studies that the most important link between these 3, apart from the glucose metabolism, that all of them are rich in mitochondria. And that time there was a 2 important question. Is mitochondria a cause or a result from the insulin resistance? And the second question is, there is a link between the mitochondria and the lipotoxicity, or it is only related to the carbohydrate metabolism and the glucose metabolism? Imiglamine is the first drug which is already present in Japan now and some European countries, which is the first drug in the family of the Glimens. The main action is linked on the mitochondria. The main action, the end result of this drug, it will decrease the hepatic gluconeogenesis. It will increase the muscle glucose uptake. It will increase the insulin secretion in a glucose-dependent manner, not like the sulfonylurea. If we come back for the basic science from the biochemistry and genetics, this is the mitochondria. If you remember that the mitochondria is having 5 complexes. Complex number 1, number 2, 3, 4, and 5. In patients with type 2 diabetes, there is genetically predisposed and the abnormal glucose metabolism leading to dysfunction of the mitochondrial respiration. And this will result in increased superactivity of the complex 1 and inhibited complex 2 activity. This dysfunction in the mitochondria will result to the main problems is seen among the patient with type 2 diabetes: insufficient insulin secretion, insulin resistance at the level of the muscle and liver, beta cell dysfunction, and progressive cell death with progressive glucotoxicity and increase of the inflammatory mediators, increase of the reactive oxygen species from the abnormal mitochondrial respiration and the abnormal pathway, and this will accelerate the diabetes complications and lead to endothelial dysfunction. The imiglamine is restoring this abnormality. It inhibits the complex 1 activity and restore the complex 2 activity. So this will result for improvement of the previous pathology. This will decrease the reactive oxygen species and protecting the mitochondria and the beta cell from progressive apoptosis and progressive failure due to improvement and protection from the oxidative stress. This will make the pancreas secrete the insulin in a proper way, in a glucose-dependent manner, like the DPP-4 inhibitors and the GLP. Moreover, this will help in improvement of the insulin sensitivity in the muscle and the liver due to improvement of the mitochondrial dysfunction. And by the way, this will improve also the endothelial dysfunction and diastolic dysfunction and the cardiovascular complications among the patient with diabetes. And this also will progressively increase the prostaglandin CA1, which is increasing the mitochondrial number. Actually, imiglmin is produced by a Japanese company which is called Voxel Company, but there is a collaboration with AstraZeneca to be released and launched worldwide. Phase 1 was already completed, and phase 2 is also completed, and it was expected to be launched and the main study to be launched at 2020, but due to the COVID problem, this is delayed for 1 or 2 years, but it is expected to be launched in a multinational way next year. It is taken orally. It has a short half-life, so it should be taken twice daily. It is mainly directed metabolism and excreted through the kidney. No, till now, with drug-drug interaction with the major anti-diabetic drugs, no effect on the ECG or changes or QT interval, no difference between ethnic abnormality. This drug had nearly no significant side effect apart from few GIT side effects like the nausea and vomiting and diarrhea, and all of this will improve like the metformin with a gradual increase of the dose. Now we are in the era of weight loss anti-diabetic medications, but unfortunately this drug is not weight loss, but fortunately it is not causing weight gain. It is a weight neutral, so it is having some properties of the metformin. These drugs, maybe we can classify it as a moderate to high intensity, because if we're looking for the studies, if we are taking 500 milligram, this can decrease the A1C from about 7.9 to 0.5 gram per deciliter. And if we are taking the highest dose, which is the 1,500 milligram per day, it is expected to decrease the A1C 1. But the A1C, if it is decreased 1 from a baseline 7.9, and this is maybe considered as an intermediate to high efficacy drug. There is, because it is not direct secretagogue for the beta cell, so the severe hypoglycemia among the different concentration is similar, and no reported attacks of severe hypoglycemia. But till we are waiting for the imiglmin, please do not forget our old friend, which is the metformin. Till now, the actual mechanism of metformin is not known. But the main accepted hypothesis that the metformin is acting through the mitochondria by causing activation of the adenosine monophosphate kinase. And this is will improve the insulin sensitivity and decrease the hepatic glucose production during fasting. And this is one of the theories that the mitochondria can be affected in a patient with type 2 diabetes, and it is a target for the anti-diabetic drugs. Sorry for that. Also, SGLT2 inhibitors, its main action among the kidney, with its launching and cardiovascular safety trial, we noticed that there is a good action on the heart. And one of the theories to explain its benefits, especially among the heart failure, it is action on the mTOR gene and the mitochondria. SGLT2 inhibitors will regulate the mitochondrial function, will modulate the glucose metabolism. It will shift with a subclinical ketosis, which is a beneficial fuel for the myocardium. It enhances the free fatty acid metabolism and the branched chain amino acid. All of this may be linked to improvement of the insulin resistance and heart failure. And final results of the SGLT2 inhibitors, this graph from the American Heart Association journal said that the SGLT2 inhibitors is a beneficial for the heart, and one of the theories which is action among the mitochondria. Mr. Chairman, dear colleagues, let me end my presentation by this slide. Mitochondrial function is already involved in the pathogenesis of type 2 diabetes and its complications. So it is a cause and result from dysglycemia among patients with type 2 diabetes. We are waiting for the imiglmin, which is augmenting the ATP production among the patient with type 2 diabetes through correction of the abnormality in the mitochondrial dysfunction. The patient with type 2 diabetes is if they are using the imiglmin, there will be improvement of the insulin secretion in a glucose-dependent manner from the incretin-based therapy like. It will improve the insulin resistance in the muscle and the liver and decrease the hepatic glucose production. So this is main share with the metformin and pioglitazone action. Lemmiglipine, it looks to be safe and tolerable. Till now, we do not have any data about its beneficial effect for the cardiorenal problems among the patient with type 2 diabetes, but we are waiting for the result. Seems to be safe, seems to be intermediate to high efficacy with a minimal GIT action. At the end, I would like to thank Dr. Aravenda and the organizing committee for inviting me to share with you in this prestigious conference, and happy to share any questions with you. Thank you.
Thank you, Dr. Osama. That was a good talk. We are very pleased to have you as a faculty from Egypt, and good wishes from India, and especially from Bangalore. That is, we are in south part of India. I'm sure you know about it, because I saw in Facebook that you were recently in Trivandrum, isn't it?
Yes, well, Dr. Jyotidev is one of my teachers, and I have training there. And I have a lot of Indian friends, and happy to be with you next year physically, inshallah.
Yes, sure. Over to Suman and Dr. Javas.
Yeah,
Dr. Khazi.
Yeah, Dr. Syed, go ahead.
Dr. Khazi, Assalamu alaikum.
Alaikum assalam.
An excellent presentation, Dr. Khazi.
Thank you,
really,
sir.
you have shown a lot of work done in the mitochondrial metabolism and proved that you are, say, major development of insulin secretion from pancreatic cell. We have also shown the targeting mechanism of mitochondrial function, and the good mitochondrial function shows the good secretion of insulin in diabetic patients. Also, you have shown a very good points and the emerging molecule to come to the market, emiglipine. All the best for your work, and thank you so much for your good presentation.
Thank you, sir.
Well, sir, because of lack of time, I think we'll not be taking any questions. I think probably questions will be posted to you. Thank you for the excellent talk. Actually, it was really heartening to know that. And I just hand over the mic to the Syed Jawad sir to introduce the next speaker, and we'll go ahead with the next speaker talk. Dr. Jyotidev.
Okay. Our next speaker will be Dr. Jyotidev Kaushdev from Trivandrum. And he has done his MBBS, MD from Trivandrum, and an endocrinologist fellowship training from Mayo Clinic in USA. Is the chairman of Jyotidev Diabetic Research Center, Trivandrum, Kochi, and he is a managing trustee in various forms and editor-in-chief in International Journal of Diabetes and Newer Technology. And probably it is because of his credential, he has been given an excellent topic by Dr. Arvind as to how automated insulin delivery, especially the 780G, transformed the lives of type 1 diabetes. Without much wasting the time, I request Dr. Jyotidev to go ahead with his topic. I think we are not hearing the sound.
Neelam, we are not hearing sound.
For giving me an opportunity.
You are muted, yes.
Trivandrum in Kerala. First of all, let me congratulate Dr. Aravinda Jagadisha, my dear friend, for the stupendous success in the national RSSDA elections. And many, many congratulations for yet another successful educational event. And thanks for giving me an opportunity to be part of this event. So let me share the screen. And this is a title which is given to me. And this is a discussion on the success story of automated insulin delivery device and how it has transformed the lives of those with type 1 diabetes in our own India. And whenever we discuss about the newer devices in diabetes, the newer technologies in diabetes, the question used to be, are they affordable to the common man? Of course, we will have a lot of inventions in technology, but that is only for the rich and affordable. We will also try to find answers to these questions from our patients. But before that, let us respect and consider those who are interested and enthusiastic in academics, those who are medical students attending this program. The first insulin pump prototype, this is not the first insulin pump, this was a prototype, and that was developed by Arnold Kadish in the year 1963. You can see that it is a cumbersome device and cannot be used in our patients. But I would say that historically, the 1974 discovery by Dr. Ernest Frederick on Biostata. Biostata is a device, as you can see here. The person with diabetes is admitted in the hospital and in the intensive care unit, and there is intravascular sensing of glucose and intravenous infusion of insulin. So the device was good, and almost a full automation was also possible. But unfortunately, the results and the findings couldn't be replicated outside the hospital environment. And hence, it was only an idea which remained static for many decades to come. Which was the first commercially available insulin pump? The answer is Dana pump from South Korea in 1979. However, in the documentations, including the chapters and the reviews that we have written in the journals, we have the Minimed in 1983 as the first globally acceptable and available insulin pump therapy. And it became so popular because this insulin pump, Minimed 502, was also used in DCCT randomized clinical trial, which eventually has proven that intensive glucose control can result in robust reductions in complications in type 1 diabetes. And this has actually contributed to the eventual acceptance of insulin pump therapy in the management of diabetes. Always remember, insulin pens came after insulin pump therapy. So insulin pumps were in 1979 and insulin pen from Novo got launched in only 1985. And when did insulin pumps came to India? Officially, Minimed Medtronic launched insulin pumps in the year 2004 in India. And initially, we all started using the refurbished insulin pumps. And these were the 508 insulin pumps, which were in another 2 to 3 years got replaced by the paradigm insulin pumps, the 722, 714, 722, 715, and so on. So let me now briefly discuss what are the stages of automation. The insulin pumps that I have shown, they were all standalone insulin pumps. The continuous glucose monitoring devices and the technology was not popular at those times. So when it got popular, the two devices and technologies started getting combined, wirelessly getting combined, which resulted in stage 1 of automation, that is shutting off the delivery of insulin the moment it hits hypoglycemia to prevent a further or a severe hypoglycemia. Stage 2 is it could predict when the glucose is going low and can automatically reduce or stop the delivery of insulin. And these two devices were launched in India. And stage 3 of automation was not available in India, and that was automatically changing the basal delivery once in every 5 minutes. But I would say that the biggest discovery, stage 4 of automation, has been made available in India. And that is why we are all together today to discuss on 780G. And that is a device where even the bolus delivery or the correction boluses are delivered automatically. And at stage 5, which is currently undergoing clinical trials, that is a dream come true. That is a fully closed system, either with insulin alone or insulin in combination with multiple other hormones. For example, the bionic bihormonal devices. Of course, this is going to be the device which will even detect the carb in the meal automatically. And currently in India, for many decades, we were only using the tethered insulin pumps. The patch insulin pumps are not even now available in India, but we are anticipating the arrival of solo micro pump. Of course, it was originally launched in 2009, but now it has been been acquired by Roche, and this is now supposedly getting combined or integrated with a continuous glucose monitoring device so that the patch pump will be automated when it is launched in our country with no tubes and strings attached. It was a necessity way back in 2010 to publish the guidelines for insulin pump therapy. So I would say that when you are selecting a person with diabetes, it can be type 1 or type 2 diabetes, there are certain criteria to be fulfilled. And there are indications as well as contraindications to put patients on insulin pump therapy so that it is ensured that the optimal benefits are there resulting from the therapy and the pump failure rates are also minimized. So what is the definition of a closed loop system? So we are discussing about automated insulin delivery devices, which are otherwise called as artificial pancreas, and closed loop system is another synonym. So in a closed loop system, apart from the insulin pump, apart from a continuous glucose monitoring device, there will be a very sophisticated control algorithm. So control algorithm will be sitting inside the pump, or it can be in a mobile phone. And this will control the delivery of insulin. Of course, a completely closed loop system is not yet available in the market. It will be available maybe in another 2 to 3 years' time. In 2015, we witnessed the launch of 640G in India, and that is the one with predictive low glucose suspend mechanism. Hybrid closed loop system was in 670G, and that was in the year 2016. But today, we are going to focus on other systems, not only hybrid, but the advanced hybrid closed loop system. This is how it evolved. If you are interested in knowing about the details of the evolution of insulin pump therapy, this is the review that we have published in Diabetes Therapy India 2020. From syringes, pens, and pumps to do-it-yourself artificial pancreas. From Arnold Kadish to 2015 innovation of iLet, and then in 2018, Omnipod Dash, and in 2019, the 780G from Miniman Medtronic. And in 2020, the FDA approval of Tandem Control IQ. Tandem Control IQ is almost similar to 780G in establishing almost close to 80% percentage time in range. And Omnipod Dash is also now connected to Dexcom so that it has created an artificial pancreas. So the ulterior aim of an advanced hybrid closed loop system. So a hybrid closed loop system is still a hybrid. It is not completely automated so that you are minimizing the errors of automation. And 780G can automate not only basal, it can also automate the bolus delivery of insulin. So imagine a situation where the patient has forgotten to bolus before a meal. The device can recognize the spike in the glucose levels and can automatically deliver the bolus. That is auto delivery of bolus, and that is determined by the algorithm in response to the sensor glucose levels. The control algorithm, I would say, they are an integral part of any artificial pancreas. So there are 3 different types of algorithms: the proportional integral derivative, that is the PID, the model predictive control, that is MPC, and the fuzzy logic. These are the ones with knowledge-based systems and they represent the bolus delivery, the automated bolus delivery in automating delivery of insulin. In 780G, at any moment of time, if the physician or the person with diabetes would like to know the percentage time in range in the last 24 hours, it will immediately display over the screen the percentage time in range, above range, and below range. And the CareLink download will provide you with sufficient information, wealth of information. So if you are looking at the evidence, what is the evidence currently on this system? Because I have listened to many patients, they will say that I am very comfortable with my pen devices. I can inject with my pen I have a pen for the long-acting insulin. I have a pen for my rapid-acting analog insulin, and I'm using a sensor, and that is the flash glucose monitoring system, and I'm quite comfortable with my delivery of insulin. But remember, if you look at the percentage time below range, it will be significant, and the percentage time within range in type 1 diabetes and in difficult to treat type 2 diabetes is almost close to 40 to 50%. However, when you are, this is the adaptive clinical trial comparing the two modalities. It has shown 1.54 reduction in the hemoglobin A1C with 780G compared to just 0.2% reduction with multiple daily injections and intermittently scanned continuous glucose monitoring device. And this is very important. When you are using an automated insulin delivery device, it is not only eliminating hypoglycemia time below range, especially the time below range for 54 milligrams per deciliter, that is level 2 hypoglycemia, but it is ensuring that it is remaining within range, and that is usually more than 80% of the time, which is exceeding the standards. And this has resulted in even celebrities such as, and this is a celebrity from Kerala, the well-known actor, and he was also a member of parliament, Suresh Gopi, and he is donating 780G to not only one person with diabetes, but to multiple people with type 1 diabetes, and that too, those patients who were having an indication for an automated insulin delivery device. Repeated admissions for diabetic ketoacidosis, repeated episodes of serious and symptomatic hyperglycemia. Look at the time and range. And this is 1 month after the deployment of 780G. It is 100% time and range. So it need not be all the time 100%, but in majority, it remains between 80 and 100%, almost every time you look for a TIR. And this is one of the statements from a parent. According to her, don't call it an insulin pump because we have exceeded the expectations of an insulin pump. Call it 780G. And I can't believe the transformation which has happened in my daughter. And with another person who has gone for the device, with experience, we have learned that with standalone insulin pumps, we can probably reach a TIR of 50 or even 60%. But with 780G, 85% or more is easily achievable. It is worth the cost. It is definitely worth the cost. But the question here is, how many can afford it? The only worry of affordable patients and the parents is, how many of people who are eligible for this device in India can afford it? And these are some of the solutions. The do-it-yourself artificial pancreas, but my dear doctors, we cannot recommend this because these are devices which are created by the people with diabetes or their parents themselves. And this is the result of we are not waiting movement by the people with type 1 diabetes. However, look at this review written by us, an extensive review on how the people are creating their own artificial pancreas. And this is the Riley link, which is a bridge between the two devices. And the same review has been referred to at the ADA EAST consensus statement, as well as the American Diabetes Association Standards of Medical Care in 2021, in 2022, and so on. So what does it mean? Though this is not approved by the US FDA, though this is not approved by the authorities in India, we as doctors treating diabetes, we are supposed to have minimal or optimal knowledge, I would say, know-how on how these are operated. So if our patient is having an issue or having a challenge with the use of DIY, we as doctors should be able to assist them. We should be capable of assisting those patients or troubleshooting those who are using it. And we are not supposed to discourage. The reason being, most of these DIY used by adult or adolescents, they are able to reach a TIR of close to 100%. And this is shared by Jas Sethi in her own experiences published in Diabetes and Metabolic Syndrome. DIY-AP, the narrative of the first patient from India. So this is how technologies are evolving. The technologies continue to amaze us. And luckily, when more and more of our patients are using technologies, the cost is also coming down. So let us all work together. Let us all work together along with the patients to bring down the cost of life-saving technologies. Thank you again, my dear friends. And once again, thanks to Dr. Aravinda Jagadisha for giving me an opportunity to connect with us.
Jagadev, your presentation was very self-explanatory. Due to want of time, I think we will not be having any question and answers in this simple your talk. And you have shown an excellent presentation of 780G, which will help to achieve the metabolic goals like HbA1c, time in range, and improve the glycemic control in type 1 diabetic patients. Thank you very much for your excellent presentation. Over to Dr. Arvind to go ahead with the...
On behalf of Dr. Arvind Diabetes Center and the ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Suman, Dr. Syed Jawad, Dr. Anup Mishra, Dr. Osama Arafa Ghazi, and Dr. Jyoti Dev for their valuable presentation and discussion. And I also thank for their valuable time and being a part of our conference. Thank you so much for your time. Thank you. So moving on to our next session, that is the Newer Insight session. We have got 3 interesting talks. To chair this session, we have Dr. Pradeep Kumar TJ. He is my friend and is a senior consultant physician and a cardio-diabetologist. He is a medical director and CEO of Brookfield Hospital, Bangalore. And we have Dr. Archana Sarda. She is a consultant diabetologist and director, Sarda Center for Diabetes and Self-Care, Aurangabad. Over to you, Chairperson, for the further proceeding.
Good afternoon, dear delegates of ADC, and a warm congratulations to Dr. Aravinda on the successful organization of this fantastic summit. You have exceeded the expectations of all the faculty and the delegates, Dr. Arvind. Many congratulations on this achievement and all the very best for future endeavors, seeing you in the national scale in the National Forum of RSSDI. So since we are running a little late, I would request my co-chairperson, Archana Sarda, to introduce our stalwart for this particular session. We are fortunate that we are chairing a session which has got the stalwarts of our country, Professor Dr. A.K. Das, Dr. Mangesh Tivaskar, and very dear friend of mine, Dr. Vijay Pandikar from Bombay. So I would request Dr. Archana to introduce Professor Dr. A.K. Das.
Good afternoon, everyone. And genuinely, this is an honor and pleasure to have such a wonderful mentors, teachers, and genuine clinicians that we are going to hear. And also compliments to Dr. Aravinda for this topic, because these are newer insights into something that we do every day in our practice. And we are going to really hear the knowledge and the experience married together and take it home. So my first introduction is of our first speaker. It is absolute honor to introduce Dr. A.K. Das, sir. He is a consultant physician endocrinologist at Pondicherry Institute of Medical Sciences and New Medical Center, Pondicherry. He's a patron of RSSDI, co-chair for ICMR and the in-depth study, the chair for diabetes in the Young Registry, former national president of RSSDI and API, former dean of Indian College of Physicians, and former professor and head of endocrinology at JIPMER and PMG Pondicherry. But in addition to that, he's also a very warm guide, mentor, great speaker, clinician, and he's always there for us. So over to Dr. Das for his topic, Type 2 Diabetes, First-Year Control Matters, an emerging concept in diabetes management.
Esteemed colleagues and dear audiences, large number who have joined today, I'm extremely grateful to Arvind for giving me this opportunity to share with you on a very important concept how the first year of treatment matters in type 2 diabetes mellitus. It is not ordinary early intensification in diabetes, but it is about the first year of treatment which matters. Now, this can be a game-changing, a life-changing concept. The first year after diagnosis is the crucial time for the persons with type 2 diabetes. While it is always important to have the healthy blood glucose control throughout, I don't contest that throughout. But new research in 2022 has shown that the first year control can reduce the long-term complications like the cardiovascular disease, the diabetic kidney disease, diabetic eye disease, and the non-alcoholic steatohepatitis. Fortunately, early diagnosis may be the first opportunity to intervene. Dear friend, when one gets diagnosed with diabetes, it is a great changing moment. It could be used as an opportunity to change one's health-seeking behavior. It is a teachable moment. We call it a teachable moment. Now, the researcher has said, the Leiter-Perrin has said that this study that I'm going to describe to you shows that the first year is the probably most important time of all others. So that is best time to make these changes in the life. Now, there is a study published in the Journal of Diabetes Care in 2022. It compared the two blood sugar levels and their complications over an average of 13 years. It compared the early blood sugar levels to the changes that happened and to the rates of complication that occurred almost over an average of 13 years. The researchers found that the patients with HbA1c values above 6.5% in the first year were much more likely to develop complications later. I'll repeat again. The researchers found over a study of 13 years that when the H1C values are above 6.5% in the first year, they're much more likely to develop complications later. Patients with H1C values over 7% in the first year even had a risk of early death. Dear friends, I'll repeat again, not to scare the population, but to be aware of the fact that if H1C values in the first year is not controlled and it is above 6.5%, they can develop complications later. And patients who have H1C values above 7%, they had an increased risk of early death. Now, there's a new study led by Neda Leiter-Perrin, assistant professor of medicine at the University of Chicago. They have analyzed about 34,000 patients to review their hemoglobin A1C values in the years after their initial diagnosis. Somebody was diagnosed with that type 2 diabetes mellitus, and their H1C values were followed up after the initial diagnosis. As you know that H1C is a common measure of blood sugar control. The lower the H1C is, the better. Now, the national medical organizations all over the world typically say that H1C between 6.5 and 7 is a healthy target for most diabetics. Now, dear friends, this study gave the take-home message that treating diabetes in the first year is important because it puts patients' health on a trajectory for the rest of their life. It puts their health on a trajectory for the rest of their life. It is not that one cannot improve one's blood sugar level later, but if you don't start early, you have to work much harder to stay healthy. That is the message. If you start early, you can do it easily. If you start late, you have to work much harder. Treating diabetes early is important because it patients' health is put on a trajectory of a good health for the rest of their life. Long-term high blood sugar levels caused by uncontrolled diabetes can cause inflammation and changes at the cellular level. As the body produces less insulin and struggles to process excess glucose in the bloodstream, this inflammation and changes at the cellular level happen. This disrupts the foundation of the blood flow and the way the blood vessels are formed, which can lead to circulatory issues, years later, called the microvascular problem, like kidney disease, eye disease, poor circulation in the limbs, the diabetic ischemic foot, and the macrovascular problems like the heart disease and the stroke. The so-called legacy effect of controlling blood glucose early can prevent these problems, but the delayed benefits pose a great problem for the physicians. Now, the same researcher in 2016 also found a very interesting observation, which we have also found. They found that in 2016, they published the paper that to convince people to take medication that can help them years down the road when they may not necessarily show any immediate benefits. When we start late, and the legacy effect definitely works, but the changes come after 10 years, 15 years. It is very difficult to convince the patient that you stay well controlled today, you will get the benefit after 10 years. In that particular study, 40% of the patients with hypertension and diabetes said they were less likely to take a medication, which when they were told that it could take up to 10 years before they could realize benefit out of it. Therefore, when we tell the patient very frankly that today you have diagnosed diabetes mellitus, please take care to see, and we also ourselves pull up our socks and say that we want to control the maximum in the first year. The patients accept it. The benefits are much more. Now, diabetes is increasing by leaps and bounds. And now there are many challenges posed by type 2 diabetes in India. But what is the most important challenge in our country is the suboptimal diabetes control. Suboptimal diabetes control, which gives rise to limited health because of a limited healthcare facility. And this suboptimal diabetic control can give rise to complication with high cost of disease management. Now, therefore, it's a big challenge to have our patients achieve our targets. This from the I7 in-depth study. You see the 4 states we published first. You will find that both in Tamil Nadu, Jharkhand, and also in Chandigarh and in Maharashtra, the HbA1c in the overall HbA1c was about 9.1 to 8.4 to 8.2, and it was higher in the rural area, more so in the urban areas also. And how many times you have to say to the patients that 1% drop in HbA1c can reduce the long-term complications between 43% to 12%, and the clock is ticking away. Therefore, there is a need of an early and the first-year intensive approach in type 2 diabetes management. Because already at the type 2 diagnosis, 50% have already complications. 50% of beta cell function has been lost. In the current management, 2/3 of the patients do not achieve target HbA1c. Majority require polypharmacy to meet the glycemic goal over time. Now, instead of a reactive stepwise treatment, in the first treatment, one has to give the frontal assault, and the therapy has to match to the individual. We do not customize when the sugars are high and the patients are very young. We do not customize the treatment. And we have a conservative approach in prescribing anti-diabetic agent. For the limitations of the reactive stepwise treatment, this well-known slide which shows start with diet exercise, 1 monotherapy, 2 OADs, then OAD combinations, OAD with basal insulin, OAD with multiple daily injections. But you see the HbA1c remains high for a very long time. Now, it has been shown today that drawbacks of a stepwise approach is number 1, even short periods of hyperglycemia can increase the risk of complications. Proactive approach that I'm talking about today of controlling maximum in the first year is required to get patients to achieve their glycemic control sooner, which can prevent microvascular complications and the macrovascular complications. Now, diet and exercise is beneficial to glycemic control. Patients need motivation. Diet, exercise are very good. But however, delays occur between the stepping up from the monotherapy to combination therapy of the tablet. The length of time between the first monotherapy when HbA1c more than 8.0 and to switch over to other drugs. Just see this cartoon. Sulfonylurea alone, patients were maintained in a study up to 14.5 years and 14.5 months, and for 1 year and 3 months. For the sulfonylurea alone, in about 1 year and 9 months. Now, up titrating monotherapy to the maximum recommended dose may not provide the benefit. Today, it is no more the market of a monotherapy. One has to escalate the dose, and proactive management means that you start with early combination and upgrade it early. Now, what are the advantages of early combination therapy? It achieves therapeutic goal, reduces the risk of side effects when you combine two drugs, opportunity to combine oral anti-diabetic drugs with a complementary mode of action. I'll show this slide to you in a minute. Potential to delay disease progression. And how quickly one should be going for a combination therapy. The global partnership recommends that treat the patient intensively so as to achieve H1C less than 6.5 with the first 6 months of diagnosis. If it is not achieved, please go for the combination therapy. Now, therapy, we are not matching it to the individuals. Now, individuals with high baseline H1C require more intensive management. Risk of complications increases with H1C. Individuals with high baseline values require particularly urgent and intensive treatment. Monotherapy is insufficient. The global partnerships recommends initial combination therapy or insulin immediately for all patients with H1C more than 9% at diagnosis. There is inappropriate prescribing of anti-diabetic drugs because we have a conservative approach because of the familiarity with the traditional agents, concerns regarding the newer oral drugs which has hit the market very heavily, the DPP-4 inhibitor, the SGLT2 inhibitors, the oral SEMA, perceived lack of efficacy of the anti-diabetic drugs. Now, the global partnership recommends use combinations of oral anti-diabetic with complementary mechanism of action. And this the cartoon which shows all the available anti-diabetic drugs today. And we can combine any drug, metformin, sulfonylurea, metformin, pioglitazone, metformin, DPP-4 inhibitor, DPP-4 inhibitor with SGLT2 inhibitor. And you know, any type of permutation combination possible today to combat the hyperglycemia. Now, delay in treatment intensification with oral anti-diabetic drugs puts us at the risk of macrovascular events with the poor glycemic control. Therefore, these results highlight the potential impact of treatment inertia and the importance of timely treatment intensification with the combination therapy. Dear friends, before I close, I must tell you early that the first year aggressive treatment with 2 drugs or even 3 drugs combined together to control blood glucose is most ideal if that is required. I'll give the example of the experience that I gained from the Dr. Daral Difronjo, from my praise Paresh Dandona and others who practice this early combination, multiple combination therapy. And they have shown by giving this early first year aggressive treatment with 2 drugs, if need be 3 drugs. And you know, they combine metformin with metformin, the foundational drug. Over and above that, one can give DPP-4, SGLT2 inhibitor, one can add even pioglitazone. You know, this 3 or 4 drug combination at the start with has almost eradicated complications in their patients. Therefore, if need be, early first year aggressive treatment with 2 drugs, 3 drugs, or even 4 drug combination to control blood glucose is very important. It can change the complication cascade and that are going to happen later. The complications can be kept in abeyance for a very long time. Dear friends, thank you very much for a patient hearing. Thank you very, very much.
Thank you so much. That was a very strong emphasis on early control, whether it is using a single drug, 2 drugs, 3 drugs, but the emphasis on the early control in the first year to prevent complications. And that is what has been talk always now to shake maybe the physician's inertia. And of course, the patient does as we feel. So we move over to the next topic, and that is clusters of type 2 diabetes, an Indian perspective. And we have Dr. Mangesh Diwaskar for the same.
And Dr. Mangesh Diwaskar will be talking to us on clusters of type 2 diabetes and its Indian perspective. Let's start off with the lecture for want of time.
Thank you for those kind words of introduction. And thank you, Dr. Arvind and the team for this wonderful, wonderful opportunity. I hope my screen is visible and I am audible. My topic today is going to be clusters of diabetes and its Indian relevance. I've been speaking on this topic of late, primarily because I think that everyone who practices diabetes needs to also have this understanding about the various clusters of diabetes. Especially when I'm talking about diabetes, here I mean type 2 diabetes. And before I deliver my talk, the next 10 minutes or 12 minutes of time or so, I just have to declare that I do not have any conflict of interest for this talk. Now, this is the IDF 2021 data. We are all aware about it. But what is most concerning about the whole data was that it's just not the number of diabetics that we are witnessing, especially as being the Southeast Asian country, but the percentage of growth, which is alarmingly high. And also, we need to understand that in comparison to our counterparts in the Pacific region, like China or in other areas, there is a significant drop in the percentage rise in comparison to the Southeast Asian population. And hence, that brings a big question to our minds, is that is our phenotype of the diabetes is different? And here I'm talking about type 2 diabetes. We all are aware about the Indian phenotype of diabetes and the high prevalence of diabetes in the Indian subclass at the much lower levels of obesity. In fact, this beautiful paper, which was published by Dr. Anup Mishra and Dr. Shashank Joshi in JAPI of February 2009, clearly showed that Asian Indians are specifically a metabolic syndrome people with high amount of visceral fat. We have got very high waist circumference. We have got a significant sarcopenia, which ultimately causes reduction in the adiponectin levels, which increases the cardiovascular risks in comparison to the European population or the Caucasian population. And hence we are called as Mound Indians, or what we also call it as thin fat Indians, toffee Indians, thin from outside, fat from inside. And this paper, which was published in BMJ, showed that low lean muscle mass is the specialty of the Southeast population. Now, why Southeast Asian population is vulnerable? Because there is a distinct connect. There is a genetic connect between the muscle mass and the Southeast Asian population genes are concerned. There is a gene which is called as myostatin, which is increasingly selected, and this inhibition of this myostatin leads to the lower skeletal muscle growth in utero, which ultimately leads to sarcopenia. This beautiful slide is from Dr. Chittaranjan Yagnik's paper, which talks about omnious octet of difference starting right in utero. So it's not just sarcopenia, but Indian babies, even though are the smallest born babies in the world, are still thin fat babies with very high amount of visceral fat, with very high amount of cord blood insulin levels. And you will be surprised that Dr. Chittaranjan Yagnik and his team has clearly demonstrated that Indian babies have nearly 3 times higher insulin levels in the cord blood in comparison to the Caucasian population. So it's just not the thrifty gene hypothesis, which we discussed since last 20 years as a cause of increased rise in the type 2 diabetes incidence in Indians, but also our population is hyperinsulinemic population, which led to people thinking that probably Indian people or the Asian people are highly insulin resistant people, which is true. But then, are there any other more clusters which would differentiate us from the Westerners? Is the $1 million question. Now, this slide of YY paradox. Y stands for this. YY stands for Chittaranjan Yagnik from BJMC Pune and Dr. John Yudkin from Oxford. And this is 2003 publication. I still remember Sir Dr. Chittaranjan Yagnik sir presenting this paper in the Melbourne IDF in 2003 and also got published in Lancet in 2004. Was an instant super hit, which proved that in spite of the fact that the BMI of both these people is similar, but look at the body fat percentages that they have. Dr. Yagnik has a body fat percentage of 21.2 versus 9.1 of John Woodkin. But this is also changing. Look at with the age of Dr. Yagnik, the body fat has gone up significantly by nearly 15%. But the Western Caucasian counterpart working in Oxford, you can clearly see that there is also a rise in the fat percentage. So this is a continuum of YY paradox which is happening. And hence, it's not just the insulin resistance that we are talking about, but there are a good number of the publications which have demonstrated that there are novel subgroups of type 2 diabetes, what we call it as the clusters of diabetes in the Southeast Asian population country. And one of the prominent papers was by Dr. R. A. Manjana, which was called as an inspired study. I also had an opportunity to work on the similar topic with Dr. V. Mohan and the team, and we also looked at new and unique clusters of type 2 diabetes in India. And here, in nearly 20,000 patients, we looked at 8 different parameters: age, BMI, waist circumference, their glycemic status, their Indian phenotypical lipid profile, and of course, the fasting and the stimulated C-peptide levels. And apart from a classical Asian Indian phenotypical Indian high insulin resistant type, we also have realized that there are 4 various clusters of type 2 diabetes in the Indian subclass of the patients. And what are they? Commonest is what is called as the mild age-related diabetes, which is around 35% of the population or 36% of the population has. Usually manifest in the 5th or 6th decade. HDL levels are well preserved. They also have got fairly well preserved beta cell function, which can be easily assessed by doing the C-peptide levels. So they have a milder form of diabetes and they are less vulnerable to develop the target organ damages or complications. But then the most alarming thing is the second group, which is SIDD, that is severe insulin deficient type 2 diabetes that we have. Surprised you? They contribute nearly 25% of the population and they develop diabetes in very early age. They have very low BMI, they have low waist circumference, but they have very low beta cell reserve. So they have got low C-peptide levels and a low HOMA beta and the HOMA IR levels. And they present to you with grossly uncontrolled diabetes, very aggressive presentation, and HbA1cs are sky high. And remember that this population is vulnerable for developing retinopathy. Then comes the third cluster, which is called as IRODS, insulin resistant obesity related diabetes, where there is not only insulin deficiency, but there also is a significant insulin resistance in combination. They also contribute to nearly 25% of the population. And they have high BMI, waist hip circumference is very high, and they have got a fairly well preserved beta cell function. These patients are vulnerable to develop diabetic kidney disease in comparison to the other clusters of the patients. And lastly, there is a combination of insulin resistance and insulin deficiency coming up together, where again the onset is very early in the age. The BMI, the waist circumference may be in between the 2 categories of SIDD and IRODS. They do have got a very high triglycerides and low HDL cholesterol, and they are at the risk of developing both kidney disease and retinopathy very, very early. So out of these 4 clusters, very commonly seen clusters of type 2 diabetes in Indian population are IRODS and CIRDD. Why it is important to understand this? Because we need to see and understand that now when we look at our young Indian type 2 diabetic patients, there is a clear demonstration of a very poor impaired beta cell reserve right at the time of diagnosis, which is evident on this slide. You can clearly see that the beta cell capacity in the Indians in comparison to the Caucasians. Not only that, look at the Chinese counterparts. They also have got a better beta cell capacity in comparison to the Indian population. And hence this paper by Dr. Anjana and team again as an ICMR in-depth data analysis makes a lot of sense to me, where she has clearly shown that SIDD presents very early and at a very low BMI. And as far as our young type 2 diabetic patients are concerned, in comparison to the European counterparts, you can clearly see that it's not the insulin resistance, but it is the insulin deficiency forms the most significant part of the population, which is young type 2 diabetes. So unlike in young Europeans who have high still amount of insulin resistance, where Indian population has got very significant young type 2 diabetics with a very poor beta cell reserve. Now, why this happens is because there is a clear diverge the way we develop diabetes. It is the tale of two different stories, where we follow what is called as a phenotype 2B pattern, where we have narrow beta cell capacity, which actually manifests with a very high fasting glucose level, and a slight to moderate stress can suddenly increase the need for the insulin very rapidly. And that actually makes the impaired insulin secretion extremely evident. And how we develop it is through what is called as an impaired fasting glucose. So we as an Indian population, we have got a very high amount of impaired fasting glucose in comparison to the Caucasians, where they have got the IGT as a primary source of developing diabetes. And the conversion hence occurs very fast in the Asian Indians. So the peculiarities of Southeast Asian population is just not the evolutionary determined, but also we have an additional lifestyle challenge, which is also responsible for the impaired insulin action. So insulin resistance on one side, insulin deficiency on other sides, we suffer a lot. Last 2 minutes, are there any clinical implications? Yes, there are. Naturally, it makes the whole approach to type 2 diabetes more, I would say, accurate the moment you start interpreting your patient's clusters of type 2 diabetes. That will also help you to accurately subclassify type 2 diabetes in different subtypes, which will also enable you to plan the therapeutic interventions depending on the pathophysiology. So the precision diabetes can be practiced when you are talking about various clusters of type 2 diabetes. We need to also understand that it is a need of the hour to develop the India-specific guidelines for the management of diabetes. We always, being Indians, believed in intensification with the oral therapies. But this beautiful paper by Dr. Borgarkar and team in BMJ Open, published in 2019, in a tight study showed that, even though you intensify with the OADs, you keep on adding the OADs, but the results are not as effective as it would have been the insulin initiation. And hence, Dr. Anup Mishra again came out with the proposed India-specific algorithms for the management of type 2 diabetes, where he clearly says that if first line is inadequate, the second line is the best way to start insulin in most of the patients. So to summarize, friends, Southeast Asian populations, we are witnessing the onslaught of diabetes because of not only our lifestyle, but also the prevalence and the incidence of both pre-diabetes and diabetes has gone up. We do have a challenge of impaired beta cell reserve along with the ectopic visceral fat as a form of the pathophysiology of our type 2 diabetes. So early insulin initiation is necessary and must be kept always in mind when you are managing patients of especially young type 2 diabetes. And hence, India-specific guidelines and algorithms will always make a huge difference as far as the management of diabetes in India is concerned. Thank you very much for the kind attention. I also once again appreciate the chance given to me by Dr. Arvinda and the team. Thank you.
Thank you, Dr. Mangesh. Thank you. Wonderful lecture on this topic on clusters of type 2 diabetes. I think the stage is now just right for the stalwart for the day, Dr. Vijay Panikar, who always sets the stage on fire with his thought-provoking and anecdotes that keep coming up. I'm very fortunate to chair this session by Dr. Vijay Panikar, who's a consultant, honorary consultant, and heading the Department of Endocrinology, Diabetes and Metabolism at Lilavati Hospital in Mumbai. He's an ex-professor of medicine at the KJ Somaya Medical College. He's the ex-vice president of the RSSDI, past chairman of the RSSDI, past president of the College of Physicians and Surgeons of Bombay. He's organizing chairman for RSSDI in Mumbai in November 23. We will be seeing him shortly in the next year's time. He's got a vast number of publications to his. He's done a massive pioneering work in the triple drug therapy and low dose pioglitazone, which is the ace up his sleeve. And he's co-authored the RSSDI chapter on recommendations for diabetes management, and is authored the RSSDI guidelines in hospital management for diabetes in 2016. And now that we know the various clusters and how important the legacy of treating diabetes is, now we look forward to Dr. Vijay Panikar on how he's going to guide us on the intelligent use of OHAs in our day-to-day practice. Now over to you, sir, and all eyes and ears on you.
Over to Bade Bhai. Bade Bhai, we fondly call him Bade Bhai.
Pradeep, thank you very much for a very kind introduction.
Pleasure.
At the outset, let me congratulate Arvind for this excellent program that he has put together. And if you see, the speakers before me have done an excellent job. Mangesh and this needs to move out. 1 second. Can you see my slides?
Yes,
yeah,
sir.
PowerPoint mode,
Yes,
sir.
sir.
PowerPoint mode.
Yes,
Yeah,
okay.
yeah.
All right. Yes, Arvind, I was just congratulating you. Excellent program put together. I heard many of the talks today. It was really brilliant. The topic given to me by Arvind is intelligent use of OADs in day-to-day practice. And it should be evidence-based. Knowledge is having the right answer, but intelligence is using that knowledge wisely. Now, today I would tell you that it's a golden era for diabetics and diabetologists, because all the drugs have gone off patent. So cost is not a major issue when we are treating our patients today. And we have a much better understanding of the pathophysiology of diabetes and the medications which are available to us. So why intelligently manage type 2 diabetes? Look at this. An average Indian who is 30-year-old can live up to 75 years of age. This is the Indian statistics today. But if you have a diabetic who becomes diabetic at the age of 30, he stands to lose 14.5 years of his life. And that is what
we need your presentation in the slide presentation mode.
diabetic, he stands to lose 14.5 years of his life. So when we are treating a type 2 diabetic, let us not just be sugar controllers. We need to look at it very holistically to see where we are and what needs to be done to help these patients to live a normal, healthy, complication-free life. If you look at the UKPDS, at the time of diagnosis, more than 50% of the patients already have complications. So like Dr. we need to start early, hit early. We have no time to waste. What do patients really die of? 80% of type 2 diabetics will die of a macrovascular disease. 60% of patients in the dialysis center are diabetics. So you have a renal pathology which is high on the card with a diabetic. And now we have a new kid on the block, the NASH, NAFLD, which is going into cirrhosis and hepatocellular CA. And it is becoming the leading indication for liver transplant in the US. And in fact, we are conducting a study in all our patients doing fibroscans to all the patients that are coming. And we find that we are discovering a huge population of fatty liver in our patients. Now, the UKPDS was the first study which really showed that good glycemic control will help. And they said that HbA1c was 7. Now look at this ADA ESD guideline of 2006. It says if HbA1c is above 7, you treat. If it is below 7, you don't treat. That was glucocentric in 2006. But then came major studies. They said, oh, let's get the HbA1c down to below 6.5 and we will get much better benefits. So you had 3 massive studies, ACCORD, ADVANCE, and BADT, which tried to get the HbA1c below 6.5. And what was the outcome? Little benefit, except for nephropathy in ACCORD and ADVANCE. And the ACCORD showed increased mortality, weight gain, and hypoglycemia. And that trial had to be stopped because there were 250 deaths in that trial. So what is the big message for cardiovascular disease? That good glycemic control does not prevent heart attack. You can die of a heart attack with an HbA1c of 6.5. So there are other factors which need to be looked at. So when you talk of knowledge and treating type 2 diabetes, these are the parameters that you need to look at. You need to achieve good glycemic control, preserve the beta cell, treat insulin resistance, should not have hypoglycemia, should not cause weight gain, should be renoprotective, and have cardiovascular benefits. These are the parameters. Currently, we have 6 oral. In fact, we can make it 7. You have oral semaglutide here, and you have 2 injectables. This is raldefranzo's ominous octet. You have 8 pathophysiological mechanisms which cause hyperglycemia. And you have different drugs which work at different sites. So obviously, like Dr. A.K. Das also said, a single drug is not going to work. You need to have a combination of drugs right from day one. So when you're optimally treating type 2 diabetes, you need a good glycemic control. And that good glycemic control is going to prevent mainly the microvascular complications. For the macrovascular complications, you have to address the dysmetabolic syndrome, which is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, etc. And diabetes is a procoagulant state, basically. So let us look at the current OHAs and how you can analyze them. You want to achieve good glycemic control? All the drugs can cause good glycemic control. So choice is yours. So all. You want to preserve the beta cell, which will give a durable glycemic response. Progression of type 2 diabetes is dependent on the beta cell integrity. If you look at the UKPDS here, at the time of diagnosis, 50% of the beta cells are already gone. And over a period of 6 years, there is a steady decline in beta cell leading because of apoptosis. This is what leads to the progression of diabetes. These are 10 studies which used sulfonylureas. Initially, there is a good decline in HbA1c, which lasts for a year or 2, but then there is a steady increase in the HbA1c. What does this tell us really? It tells us that the beta cells are dying and the disease is progressing. These are 8 studies which use a TZD or a glitazones. Good reduction of HbA1c,
and then it is maintained for 5 to 6 years, suggesting that this class of drugs has a beta cell preserving effect. And what are the factors that drive the decline in beta cell? You have a genetic background, you have glucotoxicity itself, which can be toxic to the beta cell. But most important is lipotoxicity, elevated free fatty acids, triglycerides, which is the driving force for apoptosis. And insulin resistance drives both these factors, plus directly affects beta cell apoptosis. So how do the glitazones really prevent beta cell apoptosis or delay the beta cell apoptosis? There are many factors there, but what is highlighted in yellow is mobilization of toxic lipid metabolites out of the beta cell. That is reducing the lipotoxicity in the pancreas. So when you talk of preserving beta cells and giving a durable glycemic control, you have only one molecule, which is a pioglitazone. Now you need to treat insulin resistance. 83% of type 2 diabetics will have insulin resistance. Some will have more insulin, but less insulin, but insulin resistance is there. These are two studies, the Helsinki and Verona studies, which showed that insulin resistance is a very strong, independent predictor of cardiovascular disease. This is the Nurses' Health study. I won't go into the details of it. It was a long study done over 20 years. And what is the outcome of this study? It tells us that the elevated risk for cardiovascular disease began at least 15 years before the diagnosis of diabetes. Before you had hyperglycemia, the risk for cardiovascular disease has already started. So what are we talking of HbA1c and blood glucose? We need to look much deeper into it in terms of giving your patient a long and healthy life. So insulin resistance promotes atherosclerosis even before it produces diabetes. And these are the clinical manifestations of insulin resistance. You have insulin resistance, which leads to glucotoxicity, lipotoxicity, decreased adiponectin, and you have a typical dyslipidemia, which is low HDL, small dense LDL, and hypertriglyceridemia, which are all driven by insulin resistance. And what are the clinical consequences of insulin resistance? You have diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, and the NAFLD NASH, which is all driven by insulin resistance. So now the big question is there evidence that treating insulin resistance can help? All the DPP or your diabetes prevention programs have been successful. Non-pharmacological treatment of insulin resistance is diet, exercise, and weight reduction. Pharmacological is metformin and pioglitazone. These are all the diabetes prevention studies which use exercise, diet, metformin, and they showed anywhere from 30 to 58% reduction in new onset diabetes in patients with impaired glucose tolerance. But the best results were seen with the glitazones, whereas the tripod study, pipod study, dream study, or ACT now. And now we have the IRIS study with pioglitazone. What is the IRIS study? This was unique because this was done in non-diabetic patients who had a TIA or a stroke. But they looked at the insulin resistance. They did a HOMA. HOMA can be calculated by doing a fasting sugar and a fasting insulin level, and there is a formula to check HOMA. If that HOMA was more than 3, they were labeled as insulin resistant and were put on pioglitazone 15 to 45 milligrams per day for 5 years. And what were they looking at? Fatal, non-fatal MI, non-fatal stroke. And what did they find at the end of 5 years? Recurrent stroke was reduced by 24%. Myocardial infarction was reduced by 24%. And new onset of diabetes reduced by 52%. So here was a study for the first time, a therapy which was directed only at insulin resistance has been shown to prevent cardiovascular and cerebrovascular events in these patients. And mind you, these were in non-diabetic patients, suggesting the importance of treating insulin resistance. But in this same subgroup, in this same IRIS study, there was a subgroup of 2,885 patients who were pre-diabetic. They were not diabetic, but they were pre-diabetic. And they looked at those pre-diabetic class to see what happens. So combined stroke and myocardial infarction reduced by 40%. Stroke itself by 30%. acute coronary syndrome by 52%, and new onset of diabetes 80% over a median period of 4.8 years. This is telling us something very, very important. The importance of treating insulin resistance across the board in all our patients. And the current guidelines regarding this from the American Heart Association, American Stroke Association, that treatment with pioglitazone may be considered to prevent recurrent stroke. And this is again in non-diabetic patients. So why not the diabetic patients? And what really causes all this? The insulin resistance causes, there is an increase in the atherogenic adipocytokines, interleukin, TNF-alpha, and so on, and which are all increased in diabetes. And adiponectin, which is anti-atherogenic, is grossly reduced in diabetes. And when you give a PPAR gamma activation with a pioglitazone through a direct and indirect effect, it blunts atherosclerosis. And there are many studies which have shown that effect. So this is a gist of the effect of reducing insulin resistance. In the proactive study, there was 47% reduction secondary stroke, carotid intima medial thickness coming down, reinfarction coming down, stroke coming down, and NASH coming down by almost 50% risk reduction of hepatocellular carcinoma by reducing insulin resistance. So when you talk of treating insulin resistance, you have just two molecules, pioglitazone and metformin. But pioglitazone is the main. Metformin doesn't really do that. It just reduces the hepatic glucose output. Should not cause hypoglycemia. We have only two molecules which will cause hypoglycemia essentially, sulfonylurea and insulin. If you don't use them, the rest of the molecules are free. You have no tension of hypoglycemia. It's like, fill it up, shut it, and forget about it. So even when you prescribe all the other molecules minus sulfonylurea and insulin, you can have a good sleep and not worry that your patient is going to go into hypoglycemia. Next is should not cause weight gain or preferably promote weight loss. There are three molecules which will cause weight gain: sulfonylurea, the glitazones, and insulin. And if you knock that off, this will have no hypoglycemia, no weight gain. The weight reduction with SGLT2 is about 2 to 3 kg. This is our paper which we had published. SGLT2 is the fifth drug in the treatment of diabetes, where in 6 months there is 3 kg weight loss which is seen, whereas liraglutide over 36 months gives a 2.3 kg weight loss. So pioglitazone weight gain is there, but there is significant lowering of visceral and hepatic fat. If you look at this, at 16 weeks, pioglitazone, there is an increase in the subcutaneous fat by 42%. And this increase in subcutaneous fat is because of increase in the size of the adipocyte and number of the adipocyte in the subcutaneous fat. But the same thing, if you look at the visceral fat, there is a reduction of 25% in the visceral fat, which is the pathological fat. So this weight gain which you see with pioglitazone is not pathological. It is cosmetic. It has great benefit for the patient because the visceral fat is getting reduced. In fact, I tell my patient, even if he is going to put on 5 kg weight, he is going to live 10 years longer. That's the way I would look at it. So when you talk of weight loss, SGLT2 and GLP-1 are the drugs which are good at weight reduction. Metformin, DPP-4 are weight neutral. Pio will increase weight. And now we have a new molecule, your twin creatine, terzepatide, which can cause a 20% weight reduction. Excellent. Monjaro is a brand name, just approved in the US. Talking of the renoprotective effect, there are some studies with DPP-4 linagliptin which shows that it can bring down the albumin-creatinine ratio. But the most beneficial drug is an SGLT2 across the board for primary and secondary prevention of renal outcomes. There are some studies with pioglitazone also which show the benefit there. But when you really look at renoprotection, to my mind, SGLT2 inhibitors are the most important drugs today. Talking of cardiovascular benefit, the UK PDS had shown that metformin in obese patients had a very good cardiovascular outcome, but that was a small number. And it was based on this study that US really approved metformin for its in the United States. So There are studies of pioglitazone which has shown the anti-atherogenic and cardiovascular cardioprotective effects. That's a proactive study, Chicago study, Periscope study, IRIS, several meta-analysis. The proactive study, which was done in patients who already had a myocardial infarction, mind you. And there they show recurrent fatal, non-fatal MI reduced by 28%, acute coronary syndrome 37%, secondary stroke by 47%. But there was an increased incidence of heart failure, but there was no increase in death in these patients who had heart failure. Yeah.
Could we request you to summarize, sir?
Yes. Pioglitazone is, I will. So cardiovascular, you have the SGLT2, which is very important. SGLT2 is not for primary prevention, it is for secondary prevention. So when you talk of cardiovascular benefit, you have metformin, pio, SGLT2, SGLT2 and GLP-1 are the main things today. You can have a pathophysiological cocktail. This is, I'll come to the summary. So what should be the strategy? Macrovascular damage starts many years before the onset of diabetes. Microvascular complications are linked to dysglycemia. Insulin resistance and its complications and beta cell preservation have to be adequately addressed for positive long-term outcomes. If insulin resistance and dysglycemia are adequately treated right from day one, we will be able to prevent or minimize all diabetic complications, including NAFLD. So metformin with pio is most durable, less weight gain with metformin in place. If you add an SGLT2 inhibitor, that's an unbeatable combination. So metformin pio plus SGLT2 inhibitor with endogenous insulin in place. When you say endogenous insulin, it means early use of this combination, right from day one, is the intelligent use. So what should be the ideal algorithm? You want to reduce peripheral insulin resistance, you want to preserve beta cells, you have the glitazone, then metformin. You don't want any hypoglycemia, your DPP-4 inhibitors, GLP-1, SGLT2. So these are the safe molecules that you use. If you can't control with a combination of these molecules, you need to use a small dose of sulfonylurea, of which I would prefer a modified release glycoside as shown in the advanced study. If there is only postprandial hyperglycemia, you could use alpha glucosidase inhibitor. And if that does not work, you have to add insulin. This would be the algorithm. So this is the basic algorithm. You can use these drugs very freely. No question of hypoglycemia, no question of weight gain when you have glitazones with SGLT2. This would be the ideal algorithm. Thank you very much.
Thank you very much, Dr. Vijay Panikar, for this fantastic lecture. To set the ball rolling, let me pose this question to you. How intelligent are those doctors who would want to use pioglitazone and metformin as the first drug of choice for their diabetic patients? What is your advice to those set of doctors?
Means who would want to use pioglitazone and metformin as the first drug? I think they are the most intelligent doctors this side of Suez Canal.
and how can you increase this intelligence, breadth and width of this population? How could you identify those patients who should be identified based on those characteristics which you would pinpoint to make sure that they are the right kind of a candidates?
See, type 2 diabetic Indian population has got all this built in. Whatever class of drugs you say, whatever subclass you can look at it. And in fact, one of my students has just completed the thesis that if you have the initial HbA1c between 7 and 9, use a combination of 3 drugs, metformin, pioglitazone, and SGLT2. If the HbA1c is between 9 and 11, add a DPP-4, that's a 4th drug. And only if the HbA1c goes above 11 do you add a sulfonylurea. And we have excellent results. And shortly, I think I should be publishing that paper too. So we have got this algorithm built into my system in my clinic, and we use that, and that data is getting ready. Absolutely no problem. Across the board, I think we need to use it in every Indian.
Perfect.
Right. Thank you, sir. I think there are no more questions. Any questions from
So thank you.
Pioglitazone से घाटा है. Patient 2 साल नहीं आता. He is very well controlled, but he sends 10 more patients to you. I have seen.
Yes, Ashish, you're absolutely right.
Patient doesn't come, but he sends 10 to 15 more patients to you because he is very well controlled for many years.
Well said, Ashish.
Yeah.
On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit, I wholeheartedly thank Dr. Pradeep Kumar, Dr. Archana Sarda, Dr. A.K. Das, Dr. Mangesh Tivaskar, and Bade Dr. Vijay Panikar for your valuable time and being a part of our conference. Thank you, sir. Thank you so much.
It is a pleasure. It's a pleasure, Arvind, being with you.
Thank you, sir.
Thank you, sir. Fantastic job, Erwin. Keep it up. And thanks for giving us this opportunity. Bye.
Bye.
Thank you.
Bye. Yes, sir.
So moving on to the next session, we have 3 interesting topics lined up. To chair this session, we have my dear friend, Dr. Utkal. I always call him as a gym man. He's a fit man. So in the diabetology, if you want to select any gym man or a fit man, that is going to be Utkal. He is the consultant diabetologist, Department of Diabetology, Care Hospital, and as well as in Utkal Diabetes Care Hospital, Bhubaneswar. And the music man, I should say, musician, I should say, is Dr. Jaideep Revale. He is very fond of guitars and all. So music he plays it very well. He is chairman and consultant diabetologist at Dr. Revale's Diabetes Nutrition Care and Research Center, Satara. We have 3 important speakers, my friend, Dr. Ashish Dengra from Jabalpur, Dr. Parmesh Shamanna from Bangalore, and Dr. Mithun Bhartiya from Guwahati. Over to the chairperson for further proceedings, please.
Yeah, thank you. Thank you, Dr. Arvind, dear friend. And let me introduce our first speaker, who is a well-known personality across India and making footprints on the world map also. My friend, dear Dr. Ashish Dengra. He's a director at the Mahi Diabetes Thyroid Care and Research Center, Jabalpur. And he's a preceptorship course in diabetes in Italy, 2081. He has a lot of credential to his merits, and he's organizing secretary for Jabalpur Diabetes Update. He's the president of API, president Jabalpur Endocrine Society, and he's fellow of Indian Podiatry Association. So because his CV is very big, so with the considering time constraint, I request Dr. Ashish to deliver his talk. Ashish, over to you.
Thank you, Jaideep, for kind introduction. And at the outset, I would like to thank Arvinda for inviting me for the excellent conference which is going on since yesterday, and we are hearing the very important topics going on. Can you see my slides?
Yes. Make it on slide view.
Yeah. Now it is visible.
Perfect.
So Arvinda, thanks a lot for inviting me here for an excellent conference and the new topic which I have been selected through the article by Dr. Sanjay Kalra et al., a new way to choose the glucose lowering agent, a metabolic fulcrum based approach. In the previous lectures, we have seen that how we have to categorize the patients according to the phenotypes. It is based on that only. So it will be fitting in your flow. So making a choice of anti-diabetic drugs is very cumbersome and it is very confusing. The ADA guideline, EASD guideline, IDF, ACE, all say one or the other things, but the physicians are confused. The classes of drugs are too many. As Panikar sir was saying that we have to select 2 drug, 3 drug or 4 drug, but in which patient you have to use which, that is the main problem. So apart from metformin, there are various drugs available in the armamentarium like sulfonylurea, pioglitazone, DPP4 and n number of drugs are coming up in the market. So challenge of making a choice is always there on the shoulder of the physicians to make the rational, effective, evidence-based prescription safe and well tolerated by the patient. So it is very confusing, but we have to make it simplified. So through this lecture, I hope you will find the simplified way of choosing the drugs. So decision making by the physicians today is a patient-centered decision No clear-cut guidelines are available to help the inform this decision, and physician often relies upon a strategy of trial and error method. So a new approach is a simple metabolic fulcrum based approach to choose the glucose lowering therapy. The advantages of this are it can be practiced not only by the primary care physicians, but also by the specialists. It allows delineation of people with diabetes into various groups. Each are suited to a particular therapeutic approach. So it is a phenotypic approach which defines a sum of external attributes, includes a number of variables which include anthropometric variables like age, gender, and weight. Weight is an important aspect of health which influences the choice of glucose lowering therapy, as we all know. The specific life stages such as preconception, pregnancy, and lactation, they are also included in the phenotypic variables. Other biological variables are cardiovascular health, hepatic function, renal function, and bone health, which we should take into consideration before prescribing the drug. So based on available evidence, a phenotypic framework can be crafted and to choose the rational choice of glucose lowering agent. The multiple variables listed in the modern comprehensive guidelines make it challenging for the primary care physicians to understand and implement the recommendation in practice. So they are a little bit confusing. So you have to choose the phenotypic things like life stage, like age, gender, preconception, pregnancy, and lactation. The glucotype, the patient coming to your clinic is having fasting hyperglycemia or postprandial hyperglycemia. Whether he is at more risk of hypoglycemia, whether the glycemic variability is too high in the patient. The cardiovascular health, you have to check the ejection fraction, lipid status, blood pressure. Comorbid conditions has to be taken care into account like renal status, hepatic status, and bone health before prescribing the medicines. So what is metabolic fulcrum? It is a simple systematics based upon a basic classification of metabolic status to help inform the choice of glucose lowering agent. The metabol means the Greek word for metabol. It includes all life-sustaining chemical reactions that occurs in a living organism. Healthy metabolism is known as eubolism. It can be visualized as a balance between the catabolism and the anabolism. So eubolism means fit banda. So you have the three groups of patients: eubolic, catabolic, and anabolic. So what is eubolic? It is a person with signs of neither catabolism nor excessive anabolism. It is known as eubolism, that is balanced. Predominantly catabolic, which we see in type 1 diabetic patients or patients with very high glucose levels, which has the evidence of catabolism like asthenia, weight loss, cachexia, malnutrition. We qualify this person with diabetes as having severe insulin deficiency. Predominantly anabolic means patient is having weight gain and stigmata of metabolic syndrome, which justifies the label of metabolic maladaptive anabolism. And it represents an insulin resistant condition. So you have three groups of patients: eubolic, predominantly catabolic, and predominantly anabolic. So predominantly catabolic is severe insulin deficient. Predominantly anabolic is obese, overweight, insulin resistant, and eubolic is balanced. So this arrangement allows a metabolic triage of diabetes and lends itself to the choice of glucose lowering therapy easily. So you can see the patient who is eubolic, apart from metformin, you can start these patients on DPP-4 or AGIs. Those who are having maladaptive anabolism like overweight, obese patients with high dyslipidemia, blood pressure, they are insulin resistant patients. Apart from metformin, you can use GLP-1 and SGLT2 as a predominant agent in these patients. The predominantly catabolic, these are the insulin deficient patient. Insulin is the best choice. So this is the simple metabolic triage and choosing the glucose lowering therapy in the three groups of patients. So to summarize, such an approach, though not yet evidence-based, follows the precepts of logical empiricism. It poses many challenges which must be met if it is potential to be realized. But the definitions of maladaptive anabolism and catabolism needs uniformity throughout the world. Consensus is required regarding the exact placement of various drugs and the characterized by its dynamism and flexibility. So my take-home message is, please consider the metabolism. As we have seen, the new classification is also taking into account the SIRRD and CIRD, the DD, the new classification, which says that these patients are insulin deficient and the other group is having insulin resistance, the same theme is applied with the metabolic fulcrum, and it gives you the strength of choosing the rational therapy and facilitate the faster achievement of glycemic target in a more efficient manner. So it is very easy to choose this glucose lowering therapy by categorizing the patient into metabolic fulcrum, whether it is eubolic or anabolic or it is catabolic. So simply I have given the theme of new concept of the metabolic fulcrum. If you are confused, you can categorize the patient into the three areas and you can choose the drug easily. Thank you. Thanks a lot for your patient hearing.
Thank you, Ashish, for a wonderful presentation and highlighting the new concept of metabolism, like eubolism, predominantly catabolism. So I have one question. In routine clinical practice, is it practically possible to look into this metabolic fulcrum and choose the therapy? Have you? This is just my question. How practically it is to use this type of the metabolic fulcrum?
We are using this things previously also, as the patient is coming to you with catabolic symptoms, whether it is type 2 or type 1. So we are starting insulin in those patients because the patient having the history of severe, and we are seeing these patients in secondary diabetes also, like pancreatitis patient, they are taking triple drug, quadruple drug, but still the sugars are very high and they come with weight loss of 20 kg. So these patients land up into catabolic syndrome group, like type 1 with definitely they are catabolic, they will require insulin. The type 2 who are very high sugars with weight loss of 10 to 12 kg and secondary diabetes. So all these group can be placed into the catabolic part. Metabolic part, we already know that obese young patients are coming in our clinic with 100 kg weight, and we are starting the SGLT2 or GLP1 and metformin. And the eubolic part is our major patients which we are seeing in our clinics. We use metformin, DPP4 in those groups. So we can easily categorize these patients and day-to-day practice also.
Great. So basically we were using this, but because of this literature, I think the things have become much clearer and many people can practice.
Newer classification, which Mangesh sir has also told, it is also favoring all these things, that patients are either severely insulin resistant, that is SIRD, and or insulin deficient or resistant. So two groups are already more prevalent in Asian population.
Yes. Thank you, Ashish, for fantastic talk. And any other questions?
We can move on to the next session. Thanks, my bye. Thanks.
Hope I have saved your time.
Thanks, my bye.
Thank you.
Now let's move on to the next topic. This is lunch time, so people will go into hypoglycemia if you delay. And it is my honor to introduce Dr. Parmesh, who is a medical director for Twin Health and is a live member of our SGI. And is principal investigator for 120 trials like TICOS, EVER, and leader. A speaker at different level of forums. And he has presented at ASADA. So, sir, I would like to request Dr. Parmesh to start his talk.
Hello.
Parmesh, please unmute your mic.
Yeah. Thank you.
Presentation topic, remission, hope or hype. I think this will give us a lot of inputs, like how to go forward.
Right.
People talk about this in the Facebook or WhatsApp. They get this diabetes as a remission. So let's see what you get to know.
Thank you, chairpersons, for a kind introduction, and thank you, Dr. Arvind, for giving me this chance to share my experience and also my thoughts on remission. I am definitely biased towards hope for remission. But let us see what the guidelines talk about remission. The American Diabetes Association has termed remission as an appropriate aim of management of type 2 diabetes today. And the World Health Organization has documented that you can achieve remission using either the low calorie or the low carbohydrate diet. And recently, the American College of Lifestyle Medicine has termed that the single greatest need for type 2 diabetes care today is remission. So with that, there is definitely hope for type 2 diabetic patients. And this ancient saying tells that people who know what to eat will not need to eat medicines. This is from our ancient literature. And the current guideline diet that we provide to our patients is ineffective in inducing remission. In fact, if you look at the rate of remission in the population receiving the standard of care, it's extremely rare to see remission happening, 0.007%. It's in fact said that somebody has a higher chance of dying in a year than getting into remission if he has type 2 diabetes. Now, we have to look at other methods to get into remission. The first approach which has been tried is the low-calorie diet. And we all know that low-calorie diet works basically through reducing the insulin levels. And once you reduce the insulin levels, it is effective in reducing the ectopic fat. And the ectopic fat, when you reduce it in the liver and pancreas, can lead to a good improvement in the insulin resistance, beta cell function, leading to remission of diabetes. So we can induce remission not only with the low-calorie diet, we can do the same thing by reducing the insulin levels using either a low-carbohydrate diet. We at Twin have used a meal plan with a low postprandial glucose response, which has also shown a reduced insulin level and leading to the same chain of events. Let's look at the low-calorie diet. And we all know that a very low-calorie diet supplies less than 800 calories of energy per day. And a low-calorie diet is one which gives about 1,000 to 1,200 calories per day. And these are very effective in not only the glycemic control, but also for reduction of body weight. And Lim et al. In 2011 was the first to show that you can normalize the first phase insulin secretion using a very low calorie diet of 600 calories for just 8 weeks of time. But there is a lot of hazard when you use a low calorie diet. There have been more than 60 deaths which have been reported in those who follow the low calorie diet. And this has been reportedly due to the protein malnutrition and also the micronutrient imbalances which happen with the low calorie diet and which can lead to ventricular arrhythmias and death. So because of this, a Codex standard of low calorie diet was introduced in 1995, which mandated that we need to provide at least 50 grams of protein and 8 grams of fat and all the micronutrients needed in the low calorie formula that is made. Apart from this drawback, there is also a drawback of greater reduction that we see in the lean mass and also the resting metabolic rate, which can lead to a rebound weight gain and also the loss of remission over a period of time. So this is the direct trial which used a low calorie diet of about 800 calories per day. And we can see that this is a cluster randomized trial, which actually randomized the practices, not the patients. And 26 patient practices into the control arm and 23 practices into the intervention arm. And looking at the inclusion-exclusion criteria, we can see that type 2 diabetic patients with less than 6 years were included in this trial. The BMI was much higher than our population, 27 to 45. None of these patients were on insulin, and those patients with the A1C of more than 9% were excluded from this trial. The structure of this program was, they took a very bold step of withdrawing all the anti-diabetic medications and antihypertensive medications right at the beginning of the total diet replacement. And they kept the patients in this replacement phase until they lost sufficient weight, usually about 3 to 5 months of time. And after that, the food was reintroduced meal by meal very gradually. for the next period of 2 months, and therein the patients were then shifted to weight loss of the maintenance phase, which is still ongoing. If you look at the results, they achieved a fantastic remission of 46% at 1 year and 36% at 2 years. And we were fortunate to have Professor Taylor visit our poster, who was also presenting his poster side by side in the recent ADA. Next, switching on to the low carbohydrate diet, which is another way to induce remission, which is defined as a diet with less than 130 grams of carbohydrates per day. And the ketogenic diet, which is defined by less than 30 grams of carbohydrate per day. A recent meta-analysis has shown that when you define remission as a A1C of less than 6.4 with metformin, then the percentage of remission at 1 year was 10% for these low carb diets and 4% when metformin was not included in the diet, in the definition. Verta, which is a non-RCT study, showed a remission percentage of about 20%. While focusing on the low carbohydrate diet, what we fail to understand is that macronutrients can only explain 16 to 32% of the postprandial glucose response to the meals. There is a lot of other factors which are involved, such as how much of fiber is there in the diet, what kind of cooking has gone in. Most importantly, the individual factors, the person who eats it, what is his gut microbiome, what are the medications that he is taking. And in fact, the timing of the meal and the sequence of meal that he takes, and whether he slept well or not on the previous day, whether he exercised before or after meal, all this can have a big impact on the postprandial glucose response. So we can see how the mechanism in which this works, where any hyperglycemic spikes which we see in a diabetic population can lead to oxidative stress, advanced glycation end products, and glucotoxicity, lipotoxicity, inflammation. All these lead to formation of new fat in the liver, which also gets transported to the pancreas, leading to both insulin resistance and beta cell dysfunction. We gave this plate of idli, which looks delicious, to a lot of our patients and studied with the CGM what is their postprandial glucose response. We can see that the responses are not identical. There is a widely different glucose response to the same idli based on all the factors that we mentioned, his HbA1c levels, the exercise, the activity, all that makes the difference in the postprandial glucose response. When the same person's BMI, HbA1c, all of that changes over a period of time, the postprandial glucose response to the same meal also can change, as we can see here in the next slide, where a lot of patients had a lower AUC of postprandial glucose response to the same plate of idli. So, if you look at the CGM, we can't have patients on CGM forever. And as we can see here, we have developed the digital twin technology to predict the glucose response. And compared to the actual CGM, we have a very close prediction of 7 milligrams per deciliter using the machine learning and artificial intelligence. And what we use to get this prediction is all the demographic information, the activity level, sleep data, nutrition data, medications, time of the day that a meal is taken, all of that is included, put into the machine learning algorithm, and we can predict the exact meal plan which is best for the patient. And we can see that even the sensors can be switched off over a period of time once the machine learning has become better, and we can do with just the body composition scale and the Fitbit watch. So we did a randomized control trial and enrolled more than 336 patients about 1 year back, and we just have reported the 6 months results. And here we see that the patients had less than 8 years of diabetes, and we did include patients with any HbA1c. And we looked at the primary outcomes of change in A1C and change in diabetes medication. And the secondary outcomes was remission of diabetes. here in this study, we gradually reduce the medications, first eliminating the sulfonylureas and insulin, and thereafter in a month, we were able to eliminate most of the drugs. And after the restricted phase, the food was reintroduced gradually and brought into a maintenance phase. We were able to publish our results of 6 months of this RCT in the recent ADA. And as we can see, the time above range dropped from a high of 43 to just 0.6 and maintained there for the whole period of 6 months. And the time above range improved from 52 to 82.7. EA1C dropped from 8.1 to 4.9. HbA1c dropped from 8.4 to 5.7 in this period of 6 months. And we can see that diabetes medications were eliminated in almost 191 of these 196 patients that we studied. Only 5 patients at the end of 6 months were left with metformin and 1 patient with Januvia. Whereas on the control arm, there are a lot of patients still taking more and more medications. Coming to the mechanism, we see that patients were able to reduce their fasting insulin and maintain it with a lower fasting insulin. And we also showed a pathophysiological change happening with patients, wherein both the insulin resistance measured by HOMA2IR got better, and also the HOMA2B improved to a great extent and was maintained there for the 6 months. Comparing the direct trial, we can see we had good weight loss even in our patients, more than 15 kg of weight loss in 19% of patients, 10 to 15 kg losing about 30%, and 5 to 10 kg 32%. But what is more important than this weight loss is that remission can happen in the Indian population with much lower weight loss compared to the Caucasian population. We have a different phenotype, and this is the difference that we have seen with the remission percentages with regard to the weight loss. And we have reported a 84% remission rate at the end of 6 months, and we are about to publish our 1-year results very soon. And we have a series of publications happening, and in the recent ADA, we had a tweet from the ADA itself, and also a media presentation by the ADA talking about how artificial intelligence is able to enable better remission rates compared to the other protocols. And these are some of the publications that we have done in the last 2 years of time. And this EASD, Professor Joshi presented the regression of microalbuminuria in the EASD conference in the RCT here. And we also showed that remission of diabetes in the RCT was independent of weight loss. And what we essentially are trying to do here is there is big data which we can tame it with artificial intelligence, and we can give the saddle of control to our doctors to enable remission to happen. Remission is not going to be replaced by artificial intelligence. Doctors are still needed to guide and handle the patients for remission. I thank all of you and also thank my team of twin doctors and coordinators for the excellent work they have done. Thank you.
That was a real nice talk, Dr. Parmesh, but I've got a quick question.
Sure.
So when you give this on the low calorie diet, and so do you give any specific exercise program, or you not give just a calorie restriction?
Sorry, could you come again?
Sir, do you give any specific exercise program to this group of patients, or only just calorie restricted diet?
We recommend about 10,000 steps per day. And even though we recommended 10,000 steps per day and we had them monitored with the Fitbit watch, we saw only about 1,500 increase in the step count at 1 year.
Right.
Yeah. I think talk was crystal clear and the message was also crystal clear. Thank you, sir, for the wonderful presentation. And we'll move ahead to the last talk of this session. Dr. Arvinda, would you like to comment anything?
No, I'd like to comment that Dr. Parmesh has become more smarter today. That was a nice talk, yeah.
That's why your conference, Dr. Arvind.
Can I go to the next?
Yeah, please.
Dr. Mithun is the next speaker, right?
Yeah.
Dr. Mithun, are you there?
I'm there. Can you hear me?
Yeah. Hi. It's my pleasure to introduce Dr. Mithun, my good friend, to give the next lecture. And I need not introduce him because I think he is known to almost all the esteemed doctors of India. So I think without delay, I can start to talk. Maybe you can take questions and you can discuss something further.
Thank you, Dr. Utkal, for the kind introduction, and thank you, Professor Aravinda, for the, calling him professor. I call him Rajini, so he's smartest fans around in India. Just get my screen up. So it's a little change from what we have been doing. We talked about twin technology. I'm going to talk about hormones now. So it's a little bit of a movement back to reality. And what I've been asked to talk on testosterone and diabetes and what should we know. Is my slide seeing and moving? Are they moving?
Yeah.
Yeah, okay.
Yeah,
So what I'm going to do is that, clinicians like cases. I like cases. Everybody likes cases. And that puts into perspective whatever we are trying to say. So let me put into a perspective on making some cases. And then I would like to go around testosterone and diabetes and my experience and what some take-home messages could be there. So a patient had a morning. See, nowadays, you see, world has moved on. They don't want doctors to wait to prescribe. People go on to packages. And then they have the package, they have the result, and they come and see us with the results. Okay, doctor, we have done this. Now the report is a little low. Tell me, please, what to do. So similarly, one of these patients had a 700 rupee package, whole body package, and he was done. And then he saw a testosterone, which was low. He got a bit worried because he's a young man. So he came to us saying what to do next. He's also diabetic. He's been well controlled. So the question is, what do we do with the results that comes to us like this? Do we treat it? Do we repeat it? Do we repeat it today? Or we just say, "Kahan karaye ho, sir? You do it in my clinic. Ye to bekar ka jagah hai, sab sasta hai, bekar hai." The question is, we need to have clarity in our thought as to what has been done. So I think simple answer in life is if you are having a testosterone check in your clinic or in any else's, wherever, make sure it is an NABL lab. If it is an NABL lab, some kind of quality has been ensured in the report that has been there. That's point number one. Point number two is when you are going to have the report, make sure because that we repeat the test and it has been done in the morning. So we need 2 morning reports a few days apart to actually label them, or a week apart to label them as that the patient has got low testosterone. Why? Everybody can make mistakes. I have made mistakes as a doctor, and I'm sure all of us have made some errors in life. So a pathologist is also allowed to make an error. A technician is allowed to make an error as well. And there may be other reasons why the testosterone could be artificially low. We'll come to that in the next case scenario. So first of all, repeat it and then decide whether the patient has low testosterone or not in the patient with diabetes. Let's come to another scenario. A 30-year-old man with diabetes who's been admitted for sepsis, his background retinopathy, HbA1c is well controlled. He's been admitted in Bhubaneswar under Dr. Utkal. And while Dr. Utkal was seeing many patients, one of his junior doctors does the ward round. And while the patient is in the hospital, you see patient has a lot of energy and time to think about everything. He might think of his knee pain that has been bothering him for the last 2 years, little bit of knee pain. And he's generally when people nowadays are in hospital, they are under insurance. And in India, we want every value for our money. So while in the insurance, you want every problem to be sorted in your life. So he suddenly realizes or suddenly remembers that his erection is not very good. So he tells that to the houseman of Dr. Utkal, and who is a very good houseman. He goes and checks the testosterone and finds him to have low testosterone. Now this guy is married and has no children. Now what are you going to do? So let us assume the first scenario, as I said, we have to repeat it. You have repeated also, it is still low. So what do you do with these results? Do you prescribe in testosterone gel, Sustanon, 3 monthly injections, or do nothing? I think one important rule of law when it comes to testosterone is testosterone should not be checked in an unwell patient. Anybody ever who is unwell with anything, with sepsis, with anything, he should not check testosterone because it will be artificially low. So this patient is admitted, has sepsis, the report is crossed off, no point doing another test. Maybe do it when he's well if you want to have a look at it and check it. The second scenario is here again, let us change the scenario in the same scenario. Let us change the scenario and say patient is well. OPD case comes and tells you he is low testosterone. Now you have checked his testosterone again in a couple of weeks, as we have said, and it is low. So a married man, young married man with low testosterone on 2 occasions labeled as low testosterone by you. How do you treat this patient, or should you treat this patient? You see, there are 2 thoughts of processes one needs to understand. One, that this guy has no children. You see, any testosterone supplementation that we give for any person may skew up his sperm count. And he will not be a very happy person if he is not going to have any more children. So that discussion needs to happen with the patient. If I'm going to give your testosterone, or you should do a sperm analysis before, but also counsel the patient that testosterone replacement may affect your sperm motility and sperm counts. That is an important discussion. And if he's having low testosterone, and you can always look at his erectile dysfunction by some PD5 inhibitors in the first instance. So I would not go to a young person who is not married with testosterone replacement as my first choice. Now, let us change this scenario. Let us change this scenario to a diabetic person who's well, whose sugar is well controlled, came to your OPD, you checked his testosterone, you repeated his testosterone, and both of them are low. He is married, already has completed his family now, not no children, already completed his family. Now, what do you want to do? You have to give him now testosterone preparation. What testosterone preparation you would want to give to this patient? Do you want to give him gel? Do you want to give him injection? And do you want to give him 3 monthly injections? You see, young children, if you have young children, they come and hug you. Nowadays, everybody is running, so maybe less time. But previously, we had all family members sitting together, young children coming and hugging their parents. And if it's a girl, and if you have applied gel, you don't want the gel to pass on to your beautiful girl and she develop hair in the wrong place. So ideally, and also in our India, there is a lot of moist climate. Humidity is very high. So gel is not the most fanciful things to be used that are there, because absorption going into clothes or sweating, all these issues are there. When it comes to injection, you can go by 1 monthly Sustanon, or you can go by 3 monthly injection. You see, when you give the injection, it's gone in the body, so you know what is gone. But I say, if you want to punish your patient, this is not a sponsored talk. If you want to punish your patient and you don't love him and you want him to feel very bad, you want him to feel very high on his hormones and feel very low on his hormones, then give him Sustanon. Otherwise, a 3 monthly injection is a much better injection depot to be given to the patient. I hope that clarifies testosterone replacement. We're going to come to the T4DM study in a bit. Let's go back to this scenario and then go back. Now we have decided to start a patient on testosterone replacement. Patient asks you, how long will you give treatment, sir? Will you give me treatment for 6 months, 3 months, for 1 year, or for lifelong? You see, testosterone treatment is for life. If you're going to replace somebody's thyroid, you're going to replace the thyroxine hormone for life. You're not going to give him for 3 months, 6 months, and then stop. So testosterone replacement is for life. And generally, it is a good idea to have this conversation before you are testing your patient on testosterone levels. Because the moment you have, in my view, the moment a person or a doctor has tested the testosterone, see, any test that you have done in India, where you have to pay for the test, you've already made a commitment to what you are going to do after you get the results of this test. Then you are not going to waddle around, acha, thoda de, let's wait and let's see and this and that. You've already made a plan in your head. So that plan should be reflective when then it should be very easy to prescribe. The difficulty should be writing the test, not writing the prescription. So I would first have a discussion with my patient that, okay, if you want, I will check your testosterone if it is indicated. If the testosterone is low, I'm going to repeat it. But if second time comes low, I'm going to give you testosterone replacement for life. If he's in agreement, only I test the testosterone, because in a good lab, it will cost anything between 1,500 to 2,000 rupees. If you're going to test it twice, it's going to cost around 3,500, 4,000 rupees. So the plan should be upfront and clear, like water, when you are going to, what action you're going to do before you actually do the test. And testosterone replacement is for life. You're not going to ask a patient or tell the patient, take thyroid for 6 months. It's another hormone, that's another hormone. So let's go back to the case scenario now. Now let's go back to trials. You see, there's a lot of worry knowledge because some FDA statement had come on testosterone and diabetes. And 2 trials were very keenly looked into. One was the T2DM study, which has been published. This is a testosterone for diabetes mellitus study, which is a randomized double-blind placebo-controlled 2-year phase 3B trial in Australia. They enrolled 1,007 men with low testosterone abdominal obesity, and they wanted to know whether treatment with testosterone replacement reduces progression or reverses early type 2 diabetes beyond the effects of community-based standardized lifestyle program. We just had a talk, very nice talk on technology and how to reverse type 2 diabetes and remission of diabetes. So this was a trial which was done predominantly on patients to see whether patients who are hypogonadal, if you give them testosterone, does that have an impact or reverse type 2 diabetes? And the findings were very interesting. The findings said that it reduced, the prevalence of T2DM versus lifestyle alone in men with low testosterone. And there was a 41% reduction in T2DM prevalence, which is fantastic. If you look at it from a perspective of replacement, any drug, if you come across a drug which will reduce a 41% reduction in T2 prevalence, will be lapped up by pharma and marketed like anything else. But we are a little circumspect with testosterone, and we should be. Because one of the reasons why we should be circumspect is the assays are not very good. Testosterone should ideally be checked by equilibrium dialysis, and very few good labs do equilibrium dialysis. And we are then left with total testosterone and SHBG level and DICE-FAT, and then the calculator that you do to provide free testosterone. So hence, the plan should be clear why you are checking the testosterone. If you are checking the testosterone, you're already making a commitment after discussion and then check the testosterone. This is how I do. But if you're going to replace the testosterone to a diabetic person, it may do him some wealth of good as well. PD5 inhibitors also work better in testosterone replenished men than testosterone deficient men. That has been there. But the first course should be PD5 inhibitors, especially from people who don't have children and were young that are there. Next. I think I have some time. Let me know if I have no time. Let's just put another scenario before I end. A 55-year-old diabetic patient with erectile dysfunction comes in our clinic. His prolactin is raised, his TSH is raised, so his hypothyroid, his testosterone is low. What will you treat first? Will you treat TSH? Will you treat prolactin? Will you treat testosterone? Will you treat all at the same time? You do nothing. See, I was trained in England and I was told everything is an option in life. And everything is possible. We are looking what is more possible, what is more commonly. We practice medicine with pattern recognition. We look at pattern that we have been trained and identify the pattern, and hence our pen starts writing automatically the prescription that we are trained to have. So the pattern recognition is hypothyroidism can cause high prolactin. High prolactin can cause low testosterone. That's a known fact. So I think if a patient is hypothyroid, I wouldn't even test his testosterone because it's going to be low. Because you're going to test again, then you're going to test again later on. Again, it's a cost issue in private practice. So a patient with hypothyroidism, I would not even go check his prolactin and testosterone. I'm first going to replace that, get into normal level. And still if the problem persists, then go down the route of checking the other things. I think that we have, we were part of the committee of the RSSDI ESI guidelines, and we've recommended this aspect as well. So we talked about this. Now, I have stood guilty. I have denied sexual medicine. I've been practicing sexual medicine for some years now. And I have, in my earlier stages of my career, not actually ignored and not talked about it or not given the right advice to them. And I think it's important to actually acknowledge that fact. And if I could change anything, any respect of from my talk, is that acknowledgement that the problem exists. If you are not interested, refer to somebody who's interested. But it is not something that we should say, "Arey, you've become old, you should not heed to it," because sexual dysfunction is very important. And testosterone replacement is just not sexual dysfunction. Testosterone deficiency can weaken your bones, can weaken your muscle. There's T trials that are there, which has shown that it has improvement that has been there. So I think that is there. The other aspect on testosterone, which I would quickly share, if you want to replace testosterone, please watch out for PSA at baseline, and greater than 1.4. That's not a good sign between first level and the second level. You must look at the hematocrit that has been there, because if the hematocrit is going high, you might have to stop the testosterone replacement. So these two factors, testosterone replacement does not cause prostate cancer. It may unmask it, because you are going to check the prostate enzymes, PSA enzymes, every 6 months or every 1 year. And if it's going high, you may do more investigation. So there is no data that testosterone replacement causes prostate cancer. There is no convincing data that it helps or it does not help cardiovascular disease. There is a trial going on, which is called TRAVERSE trial, which is looking at replacement of testosterone in men with high risk of cardiovascular disease, and the results should be out very soon. So that will actually end the story in terms of testosterone replacement and the heart disease. But till it stands, it should be done by a specialist who has an interest in it. It can be anybody. It doesn't have to be an endocrinologist. Anybody who keeps in touch and knows what's he doing. I think you can do testosterone replacement. So it's not as bad as it sounds, but it needs to be watched over and kept an eye on. With that, I thank Dr. Aravinda for the opportunity again for giving the talk, and I thank the chairpersons, Dr. Utkal and Dr. Tengra and Dr. Jaiti.
Thank you, Dr. Mithun Bhatia. It was a fantastic, crisp presentation. It was so well, and the basics, and that tomorrow you finish just in time. So it was really great talk. And maybe Dr. Jaydev would like to add on something.
No, I think talk was very clear, and though the topic is really vast, and Dr. Mithun has covered in a short time. So I have one question. So we routinely don't advise screening of testosterone the patients who complain with the erectile dysfunction in type 2 diabetes. That was the, I think, message from the presentation. It is not routinely advised to test testosterone levels.
So my advice would be, if patient, why are you testing the testosterone level? That should be very clear. If you're testing for sexual dysfunction, then you can use PD5 first and then go down that route. If it's a young patient, if you are testing, that is your commitment to actually treat it. You have already decided. You cannot back out now. It's like a one-way marriage. You've already got engaged. You cannot back out of marriage anymore.
Right.
So Mithun, one question from my side, that the guys comes and they say that the female partner is having no libido. So what is the message for that?
See, generally, Ashish, that's a very good question. But generally, you see, in India, still a female feels that the male should initiate the sex. And what you need sex is an interested and an interesting partner. So generally, if the husband is not being able to perform or satisfy the wife, which is 70% or 80% of the case, the wife eventually does not want to say in India that you cannot perform. So it's changing, but they don't. And they kind of take it on themselves, mera mood nahi hai, mera man nahi karta, I'm menopausal, I'm not interested, whatever, because they don't want to tell the husband you're no longer competent to satisfy. So generally, if you take a history and you talk to the, get a confidential history from the female, often I've seen that the wife is not very the husband has not ever been able to satisfy the wife, and that's why she says, "What's the point? You will arouse me and you leave me high and dry." So that is one of the very important factors that are there. But there are other reasons also. There could be other reasons why a female may not be interested. Diabetes, it could be diabetes, it could be vaginal dryness, it could be, perimenopausal. There are other reasons as well. But a man wants to play a 20-20 cricket match. That's not true in most.
Yeah. Thank you.
Thank you.
So Arvinda,
yeah. Thank you. On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Utkal, Dr. Jaidev, Dr. Ashish, Dr. Parmesh, and Dr. Mithun for being a part of our conference and for your valuable time. Thank you so much.
Thank
you.
Thank
you, Arvind. Thank you.
So moving on to the next session, we have a interesting lunchtime talk, that is the food talk. To chair this session, we have Dr. Jai Prakash Sai from Hyderabad and Dr. Prabhakar from Kolar. Dr. Jai Prakash Sai is the consultant, Apollo Sugar, Hyderabad, advisor, SAC, Government of Andhra Pradesh. Dr. Prabhakar is Professor of Medicine, Devarajaras Medical College, Kolar. We have three interesting talks from Dr. Cheryl, Dr. Lily, and Dr. Pramila Kalra. Over to the chairperson for further proceedings, please.
At the outset, I would like to thank Dr. Aravinda for giving me this opportunity. And the food talk, we have three speakers, Dr. Cheryl Salis and Dr. Lily Rodriguez and Dr. Pramila Kalra. We'll be talking different topics on this medical nutrition therapy. As all of us know, the goals of medical nutrition therapy, that is mainly is one on the component of the diabetic management, should focus on the weight loss, but also it also should address the greatly increase the prevalence of the cardiovascular risk factors like hypertension, obesity, and dyslipidemia. And to cover all these things, we have three speakers today. Let me introduce Dr. Cheryl Salis. She's a registered dietitian, certified diabetic educator, insulin pump specialist, and certified sports nutritionist, low FODMAP dietitian, certified onco nutritionist, and the founder of Nurture Health Solutions. And she has a rich experience of over 22 years in the field of dietetics and diabetic education. And she's a ranker in post-graduation authority exams. And she's a recipient of so many awards like Sadhana Award, Inimo Rangoli Award, She Excellent Changemaker Award. So I think it reads more. It's almost endless. I think we should really appreciate Dr. Cheryl Salis for so many distinguished awards and also the credentials to her credit. It's over to Dr. Cheryl Salis, who is going to speak on the making traditional Indian food as diabetic friendly. It's over to Dr. Cheryl Salis.
Thank you so much, Dr. Prabhakar, for that kind introduction. And thank you, Dr. Arvinda, for inviting me. It's wonderful being with all of you. And I thoroughly enjoyed the sessions that have happened so far. And heartiest congratulations for a very successful conference. Kindly allow me to share my screen. Yes. I think in today's times, nutrition has really become a very, very important thing. And I think even doctors and as well as everybody is discussing nutrition, especially when somebody is diagnosed with diabetes. The first thing that comes into their mind is that they have to give up on their favorite foods and they're not very happy about it. And there's so many different kinds of diets which are there online and people try it, but honestly, it is very short-lived. It is not sustainable. And therefore, let's look at how we can make our own Indian traditional meals diabetes friendly, because that is something which can be sustained and can be followed by the person living with diabetes as well as everybody in the family, because we encourage everybody in the family to eat the same kind of food because the person with diabetes doesn't feel deprived. And also that the other members with, living with a person with diabetes are also at a risk of developing diabetes. I think we have discussed this time and again that we are a carb loving country and we have enough evidence to show that we eat a lot of carbs, and our meals, especially whether it's our breakfast, it is carb laden, to lunch, to evening snacks and dinner, is very high in carbs. Protein is a macronutrient which is often a concern, and also the quality of nutrients that we're getting is really poor. The protective food groups in the form of vegetables, fruits, as well as dairy products is also declining. And therefore, and this is the pure study which clearly showed that high carbohydrate was, intake was associated with a higher risk of mortality. And again, if you look at India, with so much of awareness that is happening, we still do not have our patients achieving a good ideal HbA1c, and we see a lot of glycemic variability, especially post-meal excursions. And we know that post-meal excursions, one of the main contributing factor is definitely nutrition and diet. Again, if you look, and today when we take dietary recalls for our patients, be it from any part of the region that they are from, we see the same kind of a trend. The diet is lower in protein, high in carbs, especially simple carbs. Our meals have been replaced by snacks, especially in some, in regions in India. We see that the dinners are becoming more and more snacky, and then they call it as light dinners, or they think it is lower in calories or carbs. They're usually high in calories, high in simple carbs, as well as fats, and therefore it has a negative impact on health, and it definitely influences our post-meal blood glucose values. And today we're all about, when I started my practice 22 years back, we were, taught in college that we have to, avoid a lot of food. So everybody who came to us who had diabetes, we used to tell them, stop eating bananas, stop eating rice, stop eating mango. And there was a big list of what not to eat and a very small list of what to eat. And usually the person never came back to us for a follow-up, because, we restricted a lot of food items. And today we are not talking about people suffering from diabetes, but living with diabetes and winning over diabetes each day. And therefore bringing back the joy of eating into the person's life. I think this is the most important thing. And therefore culinary science has become a big, big part today of our clinical practice, and we are recommending diets to our patients. So it's about promoting healthy eating behavior changes, but very important is to try and improve adherence, because what we see is that what we give in the beginning when they're diagnosed, they follow it for a short period of time, but they're not able to sustain it, because at the end of it, food is comfort, food is what brings joy to us. And therefore, we have to try and bring about the joy of eating and living in the person's mind. And therefore, it is very important to give them the right messaging about food, removing the fear of food, bringing back the joy of eating and living with diabetes, focusing on the quality as well as quantity. So while we're talking about moderating the carbs, improving the protein content as well as the fat, it's very important to look at the quality of nutrients that the person is consuming. And again, if you look at our Indian traditional diets, in fact, we have a paper which is published in the Nutrients, where we've actually spoken about how our Indian traditional diets are extremely rich in nutrients, and there cannot be any kind of micronutrient deficiencies if the person sticks to their traditional diets. Definitely what we need to look at is the amount of food that we are consuming. So if you look at the protein deficiency also in our country, most of our recipes have a good combination of cereals and pulses, or, a good complementation of protein, which is helping the person meet good quality protein requirements as well. And again, I think today as dietitians, we definitely help and empower our patients with healthy recipes, because people want to know what to cook and how to cook. So this is again very important in guiding them the right method of cooking and making our Indian traditional meals itself, diabetes friendly. Now, if you look at India again, as we discussed, India is a carb-loving country. We eat carbs right from breakfast to dinner. And there was this interesting, study that was published in the Lancet, which clearly showed that you don't need to go really low carb, because a lot of people, advocate very, very low carb diets, like 5% calories coming from carb. But honestly, that is not sustainable in the long run. Where we are eating 65% of calories coming from carbs, again, this paper clearly showed that if you go very, very low on carb or very high on carb, both can result in mortality. And therefore, something which is more sustainable is around 40 to 50% of calories coming from carbs. Now, let's look at the different kinds of nutrients. So when you look at all the guidelines, whether it's the RSSDI-ESI guidelines, whether it's the ADA guidelines or the ICMR-NIN guidelines for diabetes, again, very important is when we're looking at our country, we have to reduce carbs. So moderating carbs is important. Reduce calories of weight loss is the goal. Again, very important is to reduce the processed and simple carbs. increase the amount of fiber in the diet. And again, fiber is a very, very important component which helps to keep the post-glycemic control in, excursions and control. It also gives satiety, as well as it helps to, control your dyslipidemia. So fiber recommendations are around 25 to 40 grams of dietary fiber per day. We're definitely, looking at increasing the amount of protein. So one is looking at the quantity of protein, and second is the quality of protein. So getting good biological value protein, because protein has a good effect on satiety. It also helps to improve the post-glycemic blood glucose control. It reduces the HbA1c and also suppresses the appetite. Again, when we're moderating the carbs, so in the past, the fats were a villain and carbs were the superheroes. And again, if you look at every decade, there is a new hero and a new villain. And today we are saying that when we are moderating the carbs, we have to, if we want to meet the calorie requirements, we can give the good quality fats, especially MUFA fats. So replace carbs with the healthier fats. So definitely looking at MUFA fats, lowering the saturated fats, negligible trans fats. And again, it has to be region specific depending on which region the person is coming from. Emphasis on nuts and seeds. And nuts and seeds become a very good addition to the diet because they are low in carbs, and especially as in between snacking, they become a perfect choice. So that's another thing that we can add, and definitely omega-3 fats. Again, physical activity, and this, the recent ESD paper, which is very clearly defining the 5S, which is sitting is the new smoking. We're talking about sweating. We're talking about stepping. We're talking about sleeping. So all these are very, very important aspects. And physical activity, we see, is usually a big challenge with our Indian population. People do not really do any kind of exercise. There's a lot of, mental stress, but physical activity has considerably gone down. Sleep has taken a big beating because people have crazy deadlines, and then they're sleeping for very short duration, sleeping late, and therefore snacking late in the night. Again, when we're looking at our Indian diet, it's very important again to look at glycemic index and glycemic load. And we have enough evidence to show that when we eat a low to moderate glycemic index diet with low glycemic load foods, it definitely helps in improving the cardiometabolic risk profile. And it's very simple. I love the plate method because it's very, very India specific. We're used to eating in a thali. And again, we're talking about the thali, but again, taking a smaller thali, so a 9-inch thali, filling half the plate with non-starchy vegetables. Again, this is an important message that we have to give the patient, because when we ask them what you've eaten, they'll say chapati with sabzi, and we ask them which is the vegetable, they'll say aloo or potato vegetables. So again, potato comes in the starch group. So half the plate with non-starchy vegetables, 1/4 of your plate with cereals, millets, and the starchy vegetable groups, and 1/4 of your plate with protein-rich foods. Just doing this, we're achieving a good diversity in terms of, getting the right amount of nutrients. We're able to get protein, we're getting the fiber, we're getting the healthy fats, as well as we're moderating the carbs. This becomes a nutrient, we're taking care of the nutrient quality as well as the nutrient density. So it's taking a smaller plate. So instead of taking a 12-inch plate, taking a 9-inch plate, and then following the meal pattern, and the plate really helps in moderating the carbs and helping improve the post blood glucose response. Again, when it comes to rice, again, if you look at our population, we do have a certain population who are rice eaters. And we know that rice has an impact on the blood glucose levels because, again, different varieties of rice, some of them have a higher glycemic index. Like if you look at brown rice, it has a glycemic index of 56, which is in the moderate category. Again, the Indian basmati rice is a long grain rice and therefore has a moderate GI. And if you look at the parboiled rice, it has a glycemic index which is less than 55, which is a low glycemic index. Again, we're talking about resistant starch. So cooking and cooling of starch. When you cook the rice and keep it in the refrigerator for 24 hours and then remove it from the refrigerator and allow it to just heat at, to a normal room temperature without heating at very high temperatures, they're able to maintain the resistant starch, which also helps in keeping the blood glucose levels post-meal under control. Again, taking a small moderate portion of rice, increasing the amount of protein in the form of dal, curd, or chicken, or fish, or egg, whatever the person is eating, and having a substantial amount of vegetable. One is that the person still enjoys eating rice, because if you look at South India, if you tell them to stop eating rice, they're not going to be very happy. So again, educating them about, selecting the right type of rice, for example, unpolished rice, or brown rice, you have red rice, the long grain rice will definitely, and the parboiled rice will help them enjoy, eating the rice, but again, moderation is key. Then we're looking at the wheat. We have different kinds of wheat. And this was a very interesting study which was done by Dr. Mohan and team, where they saw that just by adding, roasted Bengal gram powder, which is basically a besan, isabgol, and debittered methi powder to atta, which is in the ratio of 4:4:1, they saw that it brought down the glycemic index of the atta. And again, this becomes diabetes friendly. And this is something that can be done by the entire family. It is not necessary that only a person with diabetes should do this, because this is like using food as a medicine, and it's functional food, which will help the entire family stay healthy, because people in the family may have dyslipidemia, or maybe, having obesity or deranged blood glucose levels. So this is again something which is very practical for a person to do and follow. Again, addition of barley. And if you look at barley, it's a grain which is even mentioned in the Ayurveda scriptures. It's a very ancient Indian grain, which has got a good fiber, which is beta glucan, which helps to keep the blood glucose levels in control, as well as there's a lot of evidence to show that it also helps in lowering the cholesterol levels. So adding barley atta to the idli dosa batter, or to your wheat flour, or just having barley grains and adding that to the soup, or making a one pot meal, again, is a very, very good addition into a person's diet, and also it will give the person the essential micronutrients. Now, ragi. Now, we've seen that a lot of people switch from wheat flour to ragi, thinking that ragi is, diabetes friendly. But if you look at the glycemic index of ragi, it is very high. It is 84. And therefore, ragi by itself, if you eat it as a porridge, especially people eat it as an in-between snack. So between breakfast and lunch is when they will have a bowl full of ragi porridge, because they feel that they're feeling weak because of diabetes. They need something to give them strength and energy. And often that becomes either a ragi porridge or an oats porridge. And if we look at their pre-lunch blood glucose levels, they're usually very, very high. And this is because of the high glycemic index of ragi. Now, we're not going to tell people don't eat ragi, because again, ragi is a very traditional Indian grain, but you have to tell them to add some amount of pulses, maybe add buttermilk to the batter, add some vegetables and make a dosa, and therefore lower the glycemic index by adding protein and fiber. And they can then enjoy the ragi. But eating ragi, especially in our part of the country where I am from, Maharashtra, you get ragi sattva, which is usually with sugar, which is given to children as a weaning food. That definitely increases the blood glucose levels. Again, today we have so many different kinds of millets, and millets are great because they're not water guzzlers, very easy to grow, and they're widely available today on all e-commerce websites. So, when we're looking at even a population with diabetes and celiac disease, millets become a very good addition to the diet. So you have barnyard millet, you have foxtail millet, you have the pearl millet, you have the kodo, you have the little millet. There are several millets which are there, and you can use them in variety. You can make idlis out of them, you can make a dosa, you can make a khichdi, you can make a lot of recipes using millets. And again, people really like it. And, it only brings more variety to the person's diet. Even buckwheat, which is a pseudo grain, it's called kuttu. And now Navratri is around the corner, and everybody will start eating kuttu because that is a grain which is eaten during Navratri fast. Again, that is lower in glycemic index and can be consumed. Lente carbs. If you look at our Indian, traditional recipes, there's a lot of pulses in our diet. And again, if you look at, North India, rajma is a very integral part of a North Indian diet. Or even if you look at chole or, your soaked pulses, etc. All these have got lente carbs. Now, lente carbs are your slow release carbs. So if you want to keep the post-meal blood glucose levels under control, these are the best additions to the diet. So whether it's split grams, lentils, kidney beans, soaked pulses, even oats and barley. But one very important thing is that when people buy oats, they should not buy instant oats. They should buy rolled oats or steel cut oats, because instant oats will instantly rise the blood glucose levels. And therefore, education on what to buy when they're shopping at a supermarket also is something that we dietitians do and counsel our patients on. So again, lente carbs are a good addition to the diet. And if you look at our Indian traditional diets, sattu is very, very popular today. Sattu is basically a roasted chickpea flour, which is ground into a powdered form. That can be mixed with buttermilk, some jeera added to it, pepper, salt, and it becomes an excellent drink. In fact, it's like a protein drink, and that can be consumed in the evening when the person is very hungry. Pre-dinner sugars are going to be very, very good. Now, this is an excellent study done by Dr. Alpana Shukla and team, where they saw that the order in which the person eats is also very important. So starting the meal with salad or, a fiber with protein, and then following it up with the rest of the meal, improve the post-glycemic blood glucose response. So one is we spoke about taking a small plate, how we fill the plate, and then we come to how do we start eating. So when we do this, we actually suppress the ghrelin hormones, which induce hunger. It also helps to keep the blood glucose levels in better control, especially post meals. Now, I'll just take you through the next 5 minutes through, I'll take you on a virtual tour of India. So put on your seatbelts and the mask, and let's look at the different parts of India. If you look at South India, if you go to Kerala, puttu is a very, very commonly eaten breakfast item, which is made with either rice or ragi. If you look at the amount of puttu, which is on the left side, it's a lot of carbs. But if I moderate the amount to a small piece of puttu, say 1/4 of this, it'll give me only 15 grams of carb, and have it like how it's traditionally had with kadla, which is your chana gravy. I'm not only moderating the carbs, I'm getting the protein, I'm getting the fiber, as well as all the essential micronutrients. It becomes a good cereal pulse combination, keeps my sugars under control. Pohe. Now, pohe is something which is consumed everywhere in India, most parts of India, and usually it is had made with potatoes or aloo. Again, instead of doing, with the aloo, you can actually skip the aloo, add some vegetables, add sprouts, add peanuts, squeeze lime, because squeezing lime on the poha will actually helps to lower the glycemic index of the poha. And again, adding your peanuts, adding vegetables, you're adding the fiber, you're adding the protein, the healthy fats, gives early satiety, and therefore you eat lesser of the poha, which is going to increase the carbohydrate amount. Chura dahi, again, if you look at East India, again, reduce the carbs, do not add the sugar, add some, fresh fruit, healthy fats, and, moderate the amount of poha and add more amount of the curd. So that way you get the protein. Again, you look at the aloo paratha. Instead of the aloo paratha, you add a lot of vegetables. You can add even paneer or curd to meet the protein requirements. Or we tell our patients that you take the, the curd, the dal, which you have boiled, you can add that. So that becomes a good cereal pulse combination. And then you add the the vegetables. So it again becomes a complete meal. So you've got your carbs, you've got your protein, and you've got the fiber, and have it with curd so that the post-meal blood glucose levels are under control. Again, dosa. Dosa has a high glycemic index because it's a fermented food. And anything which is fermented is going to spike the blood glucose levels rapidly. So you can opt for a pesaretto dosa, which is made out of moong dal or any kind of lentil or a pulse. Or if they're having the dosa, have it with sambar and the chutney. So smaller portion of the dosa, more of the sambar with vegetables and the chutney. So similarly with idli, so if you're having 4 idlis, cut it down to 2 idlis, have sambar, take a lot of vegetables from the sambar and have it with the chutney. So by doing this, you're adding protein, the fiber, as well as the fat, which will help to keep the post-meal blood glucose levels under control. My last few slides. Thepla again is a very popular item, and if you go abroad, you will see everybody carrying thepla. Again, you can add besan atta, you can add vegetables, you can add curd, and it becomes a diabetes-friendly food. Rajma with rice, instead of putting rajma on the rice, you take the rajma, you add a little bit of rice and always couple it with salad. So that way, again, you've moderated the carbs, you brought in the lentil carbs in the form of rajma, the tomato puree will give the essential lycopene, and again, the salad, therefore moderating the carbs and helping the post-meal blood glucose levels to be under control. And therefore, if you look at our Indian traditional diets, be it any part of India, they're really well planned. We just need to look at the quantity, modify it slightly, and still enjoy the taste and the flavor of it. So by bringing back culinary science and the joy of eating into the person's life will keep it more sustainable and help in the longer run. So therefore, it has to be supervised, simple, sustainable, and an affordable meal plan. It's definitely not a one-size-fits-all. And our traditional Indian diets with slight modifications can be diabetes-friendly meals. So thank you so much for your patient hearing. And thank you so much, Dr. Arvinda, again, for the kind invitation. Thank you.
Thank you, Dr. Cheryl. It was an excellent talk. In fact, looking at your receipts, even I am like, I didn't have lunch today. I felt like having lunch. It's fantastic talk.
Thank you.
So let us go to the next speaker, Dr. Lily. From
why you have not taken the lunch? Arvinda said to everyone, we received our lunch. We just finished. You didn't receive?
For them, it's a dieting. They are on dieting, so
And Dr.
no lunch.
Prabhakar, or you have not received, Arvinda sent to everyone.
So they are dieting, sir.
Okay, then fine. I mean, Arvinda is responsible for today lunch, so don't worry.
Yeah, Dr. Lily Rodriguez is our next speaker. She is a considered physician diabetologist, Hospital Hyderabad, and chairman-elect RSTA Telangana chapter. She is a task force member, Women and Diabetes Center, RSTA, founder, Ever Trade Conference for Women's Health, and principal investigator for several global and national research. It's over to Dr. Lily Rodriguez, who is going to speak about intermittent fasting. Is it a hype or hope?
Thank you, Dr. Prabhakar, for that kind introduction. My topic has already been introduced by the just few comments of Dr. Sabu and the Dr. Prabhakar himself. Am I audible?
Yeah, you're right.
Yes,
what about my slides?
Good.
Yes. At the outset, I'd like to thank Dr. Arvinda for having given me a chance to be a part of this such a wonderful conference from yesterday. I've been listening intermittently, but it is really good and very, very inspiring and international standard, of course. So my topic today is intermittent fasting. Is it a hope or a hype? What is, the standard approaches to the treatment of type 2 diabetes? Always stress on lifestyle management, pharmacotherapy. Yeah? No? Okay, sorry. Why is it not coming? Share the screen.
At the bottom, there is a green column, madam, share screen.
Yes, I did that.
And it will open up your desktop.
Yes.
If you have the presentation, you can click on that.
Yes, I've done it, but it's not coming. I can see it here, but you're not getting. This is a MacBook. Yes, I'm on Zoom. Yeah, I've done that. I can see my slides. Yes. Then I clicked. Is it coming now? Huh. Oops. See, when I share the screen, it is showing desktop.
Desktop only you need to select.
Can we do it later? Let the next person speak?
Yeah, I think that is better, Dr.
I'm so
Pramila, it's
sorry.
ready
Yeah,
anyway.
I can do, actually, I'll do online. I recorded, but I'll do it now again.
Okay, Dr. Pramila. You can start.
Okay, sure.
Meanwhile, Nirav, help Dr. Lily, please.
Yeah.
I hope my slides are visible.
Yeah.
Yeah, thank you. So thanks, Dr. Arvind, for inviting me for this talk. And it's really nice. I was listening to the topics before my talk, and they're quite interesting. And Dr. Cheryl's talk was very, very interesting. So she did touch upon lentil carbohydrates, and I'll just be going and giving a brief overview about that, because this is something which is not new, but we haven't been talking too much about it. So it's why I said it's not new, because even our old textbook of Charaka Samhita does talk about the use of high fiber diets derived from whole grain cereals and legumes. And this thing was mentioned in the older textbooks as well, like our old medical literature. And we know that the fiber intake in the diet is recommended for most of our patients, and we do recommend them a fiber intake to the tune of 30 to 40 grams per day. So this is not exactly a new approach, but it is something which we are discussing now and we have become more aware of, I should say. So when you see the dietary guidelines by the American Diabetes Association or any of the organizations regarding the treatment of diabetes, they have clearly suggested the use of fiber. They have suggested the use of low carb, and we are more and more talking about the use of lentil carbs, because we know that as compared to low carbs, lentil carbs or the high legume diet has been found to be even more useful for the glycemic control and also for weight reduction as well. If you see the initial data, it dates back to around 1990s, 94, when there were some research and papers and review articles which came up on lentil carbs and the physiological effects of altered food frequency. And then there were a few more studies which came on dietary fiber use and the use of lentil carbs in patients with diabetes, and few more data on the high complex carb or lentil carbs. Now, when we talk about the use of carbs or any of the diets, we know that we need to have the nature of the starch. We need to see the ratio of the amylose to amylopectin. We need to see basically the way of cooking, the method of cooking. Dr. Cheryl was pointing towards it, that if the rice is kept in the refrigerator, next day if you boil it too much versus if you just heat it a bit, how much difference it makes on the carbohydrate availability. Parboiling, particle size, like how the patient is eating also makes a difference, whether the patient is nibbling or gorging. And then what are the other interactions in that, and also the amount of fiber. That is what we call as a viscous soluble fiber, which is actually a sort of a barrier to start digestion and absorption. And then we obviously know that there are some enzyme inhibitors, there are phytase, lectins, and tannins. Now, when we talk about the spreading of the nutrient load, basically what we are trying to do in our diets is, like, we are trying our patient's diet not to get absorbed very fast, the carbs not to get absorbed very fast and go slow. So either there is, like, we say, okay, eat less at one point of time, don't gorge. Then we have the addition of the fibers, which we say that we can add different types of fibers, like the guar. There is some data with guar, which I'll show you, pectin, beta-glucan, and xylem. Then we talk about the lentil carbs, which are present in legumes, dried legumes, and the low glycemic index foods. And then we have the enzyme inhibitors, like we use the alpha glucosidase inhibitors for the patients with diabetes. If you see the phytochemicals which are found in Indian foods and their potential in health promotion, you can see that one is the water insoluble, which is the plant one, that is the cellulose. Then we have the non-cellulose, like we have pectin, we have hemicellulose, we have gums, we have mucilages, we have lignin. You know that we have different types of these in the products which we eat, like they can have xylose, they can have arabinose, raminose, and galacturonic acid, and different other products. Now, when we talk about the dietary fiber content, we know that there is some amount of inherent fiber, but we try to add more fiber so that it becomes a low glycemic index. If you see the crude fiber in wheat, it's around 1.2. If you see the dietary fiber, it's around 11.4 to 17.2. If you see for groundnut, it's around 3.1. In the dietary fiber is around 6.1. And the total energy is like around 567. For coconut, it's around 6.6 and dietary fiber is 8.9. Now, initial data about the use of these fibers or the lentil carbs came like long time back, as I showed you, and people started working on it, like the use of the viscous unabsorbable plant polysaccharides like guar and pectin. They put it into the test meals, and it's found that there was a reduction in the postprandial hyperglycemia, even in normal people as well as in people with diabetes. And what they did was they did it in animal model. And what they did was that guar, it was added, and they tried to add this. And what did they see in that when this derived from the Indian cluster bean and one of the most viscous and effective types of fiber, which was added to the dialysis bags. And they found that the glucose and the amino acid uptake was reduced by the segments of the rat intestine. So these were some of the initial animal data which they tried to see. This is the structure of guar, which is a galactomannan and the dietary fiber of the Indian cluster bean, which Dr. Cheryl was also talking about, the lentil carbs, which we see in legumes. So this is how they have tried to see the effect of the low fiber carb with the high fiber, with the high carb, and the differences. So what they have clearly shown here, that if the patient is on a high fiber diet, there is definitely a reduction of the glucose, there is a reduction of the weight, as well as there is a reduction of the insulin dose as well. So this is one of the beneficial effects which we see with the use of high fiber or the lentil carbs also. Now, in this, they have tried to see the effect of the guar, and they have tried to see the effect on the postprandial levels of glucose and insulin in patients who were diabetic, and they have tried to see what is the effect of addition of these. And what you can clearly see here, that the blood glucose values have dropped down, and also you can clearly see here the insulin excursions were not so much. So basically what we are trying to see is it does delay the absorption of the carb, and the carb content, because the absorption is delayed, the glucose rise is not very high, and for a longer period of time the glucose peak is flatter, and obviously that acute insulin surge is not happening. Now, it's not that only when the fiber is taken or the lentil carbs are taken, then only the effect was seen. Now, people have tried to do some other thing also. What they did was that the fiber was eaten with the food, and after 4 hours, they just gave a glucose load. And they did find out, and they did try to see that whether that still had an effect. So actually what was seen, that the glucose load which was taken with guar resulted in a glucose tolerance improvement, not at that point of time, but also to a further glucose load which was taken 4 hours later. And this effect was incidentally independent of the endogenous insulin secretory ability. So meaning to say that effect was remaining even till that point of time. So if you can prolong the absorption time of the carbohydrates, we can get a flatter postprandial glucose profile. We can get a lower mean insulin levels postprandially and over the day. We can reduce the gastric inhibitory polypeptide response. We can also prolong the suppression of the plasma-free fatty acids. We can also reduce the LDL cholesterol levels and the total cholesterol levels. And we can reduce the hepatic cholesterol synthesis. Also, it has some beneficial effect on reducing the uric acid levels and increasing the urinary uric acid excretion as well. So these are different benefits which are seen. Now you can clearly see here, this is a comparison of a low carb with a high legume diet, which we have the lentil carbs in them. So you can clearly see the low carb has fared good, but the lentil carbs, that is a high legume diet, has fared even better as regards to the lowering of the plasma glucose values over a 24 hours profile in type 1 diabetes patient. So other mechanisms which have been hypothesized, that they also do modify some of the gastrointestinal events by not only reducing the absorption of the carbohydrate, but many other mechanisms. Even there are some studies which have come on the gut microbiota. And also they also have a good effect on reducing the LDL levels, that is the blood lipid levels, and also the cholesterol level, which could be direct effect of the fiber per se, and also because of the delayed absorption of the carbohydrates. And this was one of the other studies where they found that 45% of the daily fiber, that is around 54 grams per day, in one of the studies they tried to see, came from legumes. Then those patients had a good fasting glucose level control and a glucose excursion control as compared to the patients who were taking a low fiber control diet. So this was one of the another studies which was done way back in 2002, where they did see the use of lentil carbs in not only controlling the fasting glucose, but also the 24 hours glucose profile. Now, in this one of the other studies, they tried to see that if the patients consume more of kidney beans and dried peas for 6-week period, they did see an improvement in many of the diabetes parameters, glycemic control, ranging from not only the fasting to the postprandial to the HbA1c values. So guar is one of the fiber which has been studied, where people have tried to use it, and they have done one study where they tried to give it over a period of 1 to 12 months as an addition. And they did find that there was a betterment of the glucose values and the glycemic control. And the insulin requirement was also reduced to the tune of around 20%. So they tried to see the reduction in the insulin dose. You can see over months of guar use, and they have seen the urinary glucose excretion became better. There was a reduction in the blood glucose values as well. So whenever there is a slower carbohydrate absorption, like by the use of the types of the carb which is found in legumes, the lentil carbs, the increased amount of nutrients are delivered to the colon. And actually this functions as a substrate for bacterial fermentation, which generates more of short chain fatty acids, which can actually be responsible for some of the beneficial effects which was seen with the use of lentil carbs on carbohydrate lipid metabolism as well. So also, they have tried to see that even the lentil carbs and the physiological effects of the altered food frequency may be similar. So they have found that the similar effect can be also mimicked by altering the food frequency, like I told you, by nibbling versus gorging. And there they have actually seen a reduction in the cholesterol values and the ApoB concentrations as well. A very, very interesting study where they have tried to see that lentil carbs and acarbose action is almost the same, and prebiotics. So here they have tried to see that nutraceuticals which delay the digestion of the carbohydrates, like administration of viscous fiber, like glucomannan or amylase inhibitory phytochemicals extracted from beans, mimic the health benefits which are achievable by acarbose or other pharmaceutical alpha glucosidase inhibitors. So that's one of the ways they have tried to see how the lentil carbs help. So only other important thing is to remember that some of these may have some interaction with the drugs or the fat-soluble vitamins, like glucomannan has the potential drawback of impeding the absorption of certain fat-soluble vitamins, can have some drug-to-drug interaction, so that all needs to be seen when they are administered. Common sources we already saw in the previous speaker's talk: legumes like lentils, split grams, kidney beans, and green peas, soaked pulses, cereal, oat bran, and barley. And we know that this is not the oats which are the steel cut oats, and all those oats are the ones which have a higher content of lentil carbs. So my take-home message is lentil carb is something which basically what we are trying to do is the fiber content is increasing. So this has basically what we have learned is there is a possibility of modifying the absorption of the carbohydrates through the GI by increasing this content of fiber, and that in turn reduces the rate of release of carbs, and obviously that translates into the betterment of the glucose values. Not only there is betterment of the glucose values, but there is also betterment on reducing the lipid levels, reduction of the cholesterol, reduction of the LDL levels. So these could be one of the things which we should definitely study more, and we can learn more by using it in more number of our patients and advising them, because we are actually doing it, not that we are not advising. But the only thing which is happening is there are not dedicated trials which are particularly targeting that, though there are lots of data and studies available. But particularly when we say this lentil carbs, as I showed you the data, even for in place of alpha glucosidase inhibitors, they have told that this could be one of the things which could be beneficial rather than using the drugs where we may get some side effects as well. So work needs to be done to define these foods and the classes of foods which are most effective, especially for our diabetes patients, so that we can have diets which are compatible. Because many a times we just talk about low carb diet for them, and which is sometimes and many times not feasible for the patient to consume. And the concept of this lentil carbs can be very important for our diabetic patients, where keeping the carb content in place and also to some extent increasing the protein content and giving the lentil carbs can be a good option, which causes satiety and actually gives a good glycemic control with a good effect not only on the glycemic levels but also on the lipids and the cholesterol levels as well. So I think with this I end, and any questions I'll be happy to take.
Thank you, Dr. Shamila Kalra. It was an excellent talk. Actually, it is, as you said rightly, it is a reinvented topic. It was there, but it was no one was showing much interest. But
True.
But the recent past, a lot of studies have been done on this lentil carbs. An excellent talk. Questions? Shall we take questions at the end, I believe? We can go to the next speaker, Dr. Lily Radrick. Shared some issues. Madam, it got sorted out?
Yes, I've sent the slides to the RX people. They are going to share. Neera? Yeah.
In between, we forgot to introduce Dr. Pramila Kalra. She did, I think, MD in General Medicine at King George, Lucknow. And she did her DM at prestigious Sanjay Gandhi PGI. We could not induce madam in beginning because of lack of.
No problem. It's okay. No problem.
We are very happy to have you.
She's known to everybody.
No, it's okay.
Wonderful talk, Dr. Carla.
Thank you, ma'am. Thank you.
Dr. Lily is ready?
Yes, I'm ready, but the RX events people have to share the slides. Nirav. Can you come down? Yes, I'm on this slide now. Next. Next, yeah, this is active. So what is fasting? Fasting is when you diet either abstain, when you either abstain from certain foods, drinks, or all foods and drinks. And intermittent fasting is basically a type of eating pattern. It's not really complete fasting, but it's an eating pattern. It alternates between prolonged periods of fasting, not eating and drinking, and periods of non-fasting. Next. Why do people fast? It may be spiritual, or there may be a cause for the fasting, or to lose weight before a medical procedure, and then sometimes to detox, that cleanse the body. Next. So coming to what is intermittent fasting, Intermittent fasting is an eating method that cycles between calorie restriction or fasting and normal food consumption during a specific time period. We don't look at, healthy food. I mean, healthy food, yes, but what to eat, how much to eat is not really specified. So there are many different types of an intermittent fasting routines, including 5:2 method, the warrior diet, and alternate day fasting. Perhaps the most popular kind of intermittent fasting is 16/8 method, which involves eating during an 8-hour time frame before fasting for 16 hours. Next. Intermittent fasting is emerging as a potentially sustainable strategy to achieve control or remission of type 2 diabetes. That is what we are interested in. So fasting is voluntary abstinence from food, and intermittent fasting is an eating regimen by which all meals are consumed within a strictly defined window of time, followed by fasting. Some available studies on intermittent fasting use variations of fasting that allow for the ingestion of fewer calories during this window, while others abstain from caloric intake altogether. So patterns and lengths of fasting also vary among studies. Next. The goals of intermittent fasting, while reduction of body weight is typically the goal of intermittent fasting regimens, not all patients who suffer from our type 2 diabetes are overweight. So many cases of type 2 diabetes improve or remit with weight loss, but the two goals are not the same. Next. So interventional strategies where individuals are subjected to varying periods of fasting, not a diet in the conventional sense, but more accurately described as an eating pattern that cycles between periods of fasting and eating. It doesn't specify which foods you should eat, but rather when you should eat them. It's currently very popular in the health and fitness community. So recently attracted attention because its evidence-based health benefits, its potential for correcting metabolic abnormalities, and better adherence when compared to many other methods like keto diet as well. So there are 3 types of intermittent fasts: 24 hours, 16 hours, 20 hours. You can also vary these fasts with respect to time and eating and drinking patterns. Next. So coming to the 24 hours once or twice a week. If your last meal is at 6 p.m. on Monday, then your next meal will be at 6 p.m. on Tuesday. Some people may do this fast without eating or drinking anything. Others may drink water. So there is the temptation to overeat once the fast is over in this 24 hours method. Instead, some people may have some soup or some smoothie or some tea or as for your first meal. Next. And then coming to the 16 hours, which may be the most popular and easier to follow. Daily up to 16 hours you fast. And there's a slight difference between men and women. Men fast for 16 hours and women for 14 hours. This is like skipping the breakfast. If you are a man and your last meal is at 7 p.m., then your next meal should be at around 11 a.m. If you are a woman, then 9 a.m. This fast is easier to maintain. You only miss breakfast. It provides a greater start especially for the beginners. Next. 20 hours, it's something similar, but here the 20-hour fast where you have one large meal in the night. During the day, you can have fruits, vegetables, or nuts. Try and keep your consumption to natural foods. So even though you will not be having full meal, don't snack to become full. So keep your portions first, fist size, that's all. So your own fist size. You don't have to worry about preparing meals as your foods are from natural sources. Next. So example of intermittent fasting diet plan. Drinking plenty of water throughout the day is common. The morning, you can have a medium banana wheatgrass drink. Lunch, chicken salad, no dressing, spirulina drink. And dinner, steamed fish with lemon, ginger, and chili. Next. So how does intermittent fasting work is a question. Fat burning that happens both during keto diet as well as intermittent fasting. So more energy, less reactive oxygen. And then a calorie restriction also increases the metabolic rate, increases your antioxidants, not exhausted. Avoid eating several hours before going to sleep. This is also one method that we all tell our patients, even if they are not fasting, they should eat at least 2 to 3 hours prior to going to bed. Then there is autophagy, which is nothing but removing the damaged cells and mitochondria, known as mitophagy. Then there is triggering the immune system for cancer patients particularly. Then reducing the cancer recurrence also has been observed, and mortality rates have been reduced because of fasting, especially intermittent fasting. Next. So how does it work? When we eating food increases the insulin, we all know, and this stores sugars in the liver and produces fat in the liver. Not fasting, no food fasting decreases the no food, and that is otherwise fasting causes decrease in the insulin and also burn stored sugar and burn fat. So this exactly opposite of eating food. Next. So this is what happens when we eat. What is seen in red is increase in the insulin, and during the fasting you see something in green. They are all beneficiary effects, which I'll come to a little later. And then 8-hour eating window, you have eating window, and you have a longer greener area where you have beneficial effects of fasting. And then warrior diet or alternate day fasting, you fast for 24 hours and you eat only one meal, one large meal, and then this is what you see. Next. High sugar, especially fructose, turning off the body's appetite control system, insulin and leptin signaling hunger, more eating, gaining weight. This is the pattern that we usually, what happens to us. So when there is intermittent fasting, this eliminates the hunger and cravings. So it improves insulin and leptin sensitivity. It reduces or normalizes the ghrelin effect, the hunger hormone, and so there is a less appetite. So how there is increase in the human growth hormone. The levels of growth hormone increase almost fivefold, and this benefits for fat loss and muscle gain. There is insulin, which improves in its sensitivity, and insulin levels drop dramatically, and lower insulin levels make stored body fat more accessible, and so body fat gets released. Then there is cellular repair that I already spoke about, autophagy. Then there is gene expression also that can happen when there is a fasting period. There are changes in the function of genes related to longevity and protection against the disease. So these changes in hormone level, cell function, and gene expression are responsible for the health benefits of the intermittent fasting. Next. I think this is a repeat one. Next. So this is in a nutshell, benefits of intermittent fasting. You have enhanced cognitive function, increased growth hormone levels, improved blood lipid profile, improved insulin sensitivity, fat loss, and there is increased growth hormone, which again increases the muscle strength, muscle mass, and then and also it wastage whilst fasting, muscle wastage doesn't happen, and overall the person has a healthy feeling. Next. So when you fast intermittently or any sort of fasting, there is a caution always. You may feel sick or lightheaded. This is a result of a drop in the blood pressure and your body struggle to produce energy. So if this persists, you may need to drink some tea or juice. Muscle breakdown, weakened immune system, and lack of nutrients from food can give rise to this feeling or a sensation. Your body goes into conservation mode, burning calories more slowly. Consequently, when you start eating again, it's easy to gain weight. So these are the adverse effects, so to say. Next. So coming to the training and intermittent fasting, studies have suggested that exercising whilst in fasting stage, although should be done under supervision and with care, can actually lead to improved athletic performance. Then keeping workout short may be the answer, less than 30 minutes and intense, short and intense, can help enhance the use of fat as a substrate fuel whilst enhancing growth hormone secretion. So growth hormone in turn leads to enhanced anabolic response.
Excuse me, madam. Will you please shortcut the talk?
Okay.
We are getting late.
Okay. Next. Next. So intermittent fasting safety and limitations are there. So the benefits I already said, safety and contraindications. Limitations are in our children who are diabetic, particularly in elderly and the underweight, and could be harmful in this population. Fast foods fast for periods of time greater than 24 hours may not be ideal for our diabetic patients. Then safety and contraindications in underweight, pregnant women, breastfeeding, and have an eating disorder patients. Next. So these are, intermittent fasting has been studied and weight loss has been studied, and this is a systematic review over 27 trials. So even with the patient with type 2 diabetes has been studied. So in the 27 intermittent fasting trials found weight loss of 0.8 to 13% of baseline weight with no serious adverse events. And in 5 studies which were done with type 2 diabetes, documented improved glycemic control. So in conclusion, intermittent fasting shows definite improvement in the glycemic control and even HbA1c and weight reduction. So health benefits in a nutshell, the hope of intermittent fasting is the health benefits. The health helps in reducing the weight, lowers risk of diabetes, lowers blood pressure and cholesterol level, improves heart health as well, and increases the lifespan, even recurrence of cancer, and then delays the onset of neurodegenerative diseases like Alzheimer's. Thank you very much. This is my last slide.
Thank you very much, madam, for that excellent talk. You spoke about the benefits of intermittent fasting beyond diabetes and obesity. Thank you very much, madam. Because of lack of time, we are unable to take up the question answer section. I'll conclude this section on food talk. And all the 3 speakers spoke very well, and they enlightened the importance of the diet and the management of not only diabetes and beyond diabetes also. And I thank all the speakers, and also I also thank at the end Dr. Arvind and his team for his excellent topics that he has chosen, and also the excellent conference that is going on. I can definitely say it is not just national, it is international level. Thank you, Arvind, for giving me this opportunity once again. Thank you.
Prakash, your comments. Jai Prakash, your comments.
I think Dr. Arvind, it's a very good program. I think I congratulate both 3 speakers, Dr. Cheryl and Dr. Pramila Karla and Dr. Lily Rodriguez, for covering a very important topic, because Indian traditional foods and in relation to glycemic control is very important. Thank you, Dr. Arvind. It's a very good show.
On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Jai Prakash Sai, Dr. Prabhakar, Dr. Cheryl Salis, Dr. Lily Rodriguez, and Dr. Pramila Kalra for your excellent deliberation and discussion. Thanks for your valuable time and for being a part of our conference. Thank you so much.
Thank you very much. Thank you.
Thank you. So moving on to the next session, the much awaited session, that is the keynote address from none other than Dr. Banshi Sabu. So on behalf of ADC International Virtual Diabetes 2022, it gives us a great honor in bestowing keynote address to Dr. Banshi Sabu, who is my mentor, guide, philosopher, and always encouraging person in my life. So he's one of the person whom I always follow, and seeing his enthusiasm and energy, it's always a motivating for all of us. I'm sure all of you agree on this. The way he conducts the meeting and the way he organizes the thing, it is always a learning process for us, and we always get inspired by his words and motivation and all those things. So thank you, Dr. Banshi Sabu, for being part of it, and we are happy to produce bestow you with keynote address from ADC International Virtual Diabetes Summit. Can we have a CV, please? To chair this session, just a second, to chair this session, we have Dr. Ajay Kumar Sinha. He is the head Department of Medicine, NMCH Patna. He has multiple research paper in national and international journal, past chairman RSSDI, Bihar past secretary, APH Bihar. Can we have Dr. Banshi Sabu's CV, please? Thank you. So Dr. Banshi Sabu is the Chief Diabetologist and Chairman, Diabetes Care and Hormone Clinic at Ahmedabad. He is honored with Fellow of American College of Endocrinology, USA, and ACP, USA, International College of Nutrition. He has got FRCP from all the three Royal Colleges, Glasgow, Edinburgh, and London. He has MNMS from Diabetology. We all know that he was a dynamic past president of RSSDA. He is the president of AIARO, Indian Obesity Society, honorable vice president of Diabetes in Asia Study Group, honorable secretary of Diabetes India. He has launched a project of Diabetes Free India 2030. It's a dream project for all of us. We are under the leadership of Dr. Banshi Sabu. It is acknowledged by Honorable President of India, Shri Pranab Mukherjee. He is a founder of NGO, Diabetes Care India, and India Sweet Registry Project. He is advisory board member of API, Journal of Diabetology, JOMR. Expert of RSSDI guidelines for management of diabetes, ATTD, CGM guidelines, and ISPAT guidelines for pre-diabetic diabetes. He has more than 50 publications in Index Journal and have contributed chapters in various textbooks and monogram. He was awarded Most Impactful Healthcare Leaders by World Health and Wellness Congress and Awards. That is KADAM, that is Knowledge-Based Diabetes Awareness Movement. IDEA, that is the Intensive Diabetes Education and Awareness to Stop Heart Attack. Multiple Diabetes Clinic, along with AMC with support of WDF, improve standard of care of type 1 diabetes in Gujarat, supported by WDF. This is I should say this is only a short CV which we can read. If we have a big, go in depth of his CV, it takes minimum half an hour. We have told in very brief. We are honored to have Dr. Banshi Sabu as our honored keynote addresser today. Before we present Dr. Ajay Kumar Sinha, a few words, please.
Yeah, a very good evening, good afternoon, and my regard to all seniors. First of all, I must thank Dr. Ravinda, my young brother and very handsome personality, for giving me opportunity to chair the session of a towering personality, which you have rightly said. I have seen the big conference arranged by Dr. Banshi Sabu, like APCON Ahmedabad, and RSSDI Jaipur and many others. He is a much powerful personality, as you have rightly mentioned. So without wasting time, I may invite Dr. Banshi Sabu sir to give his the oration of the subject, which is coming in a big way, the time in range. And time above range, time below range. So we see that how it is going to shift the paradigm way from the previous metrics which we are using, like HbA1c and others. So over to Dr. Banshi Sabu.
Thank you, Dr. Ajay Kumar, for kind word of introduction. Thank you, Arvinda. It was real Very kind of you for few words which you spoke for me. Thank you very much. And thank you for this keynote oration which you had given to me. A wonderful meeting. Yesterday I could not attend. I was traveling back to India from ESD. What I'm going to talk in next 20-25 minutes, as this is like the paradigm shift. We are changing from evency to time in range, but still we are in a transitory phase. And let me share my slides. Can you see the slides, sir?
Yes, yes, sir.
Okay. So what we are going to talk, the time in range, probably a replacement for A1C, maybe in near future, and it will really, it is already changing the way we are treating diabetes. And that for that, I'm going to show 1 or 2 patient example too. For this particular talk, I don't have any financial disclosure. I'm practicing since last 25 years. Since 1997, I'm practicing diabetology. One very important statement which I would like to hear make, that if you cannot measure it, you cannot improve it. And I think in India, one of the reasons for our patients, that 2/3 of our diabetic patients are not under good control, is one of the reason is we are not measuring it. Many of our patients are not measuring it, and that's the reason they are not improving it also. Now, there are 3 pillars to manage this dysglycemia. We know from our UKPDS and DCCT data, and those days, almost like 25-30 years, that they had clearly demonstrated a link between a chronic hyperglycemia and development of diabetes-related complications. So what we understood, that treat glucose level and try to achieve a tighter glycemic control, try to achieve a good A1C. If you get it, you will have less complication. But it was hypoglycemia, always a limiting factor, because at that point of time, it was insulin, and UKPDS, it was sulfonylurea and metformin. It was hypoglycemia which was limiting factor, and we could not achieve a tighter glycemic control for many of our patients. But then in almost a decade or 2 decades, 15 years, 10 to 15 years, we could also understand it is not only the glucose control or getting a good A1C, it is the glycemic variability, also very, very important, which is also linked with long-term diabetes complications. So even if you have a good diabetes control, you may have a good A1C, but still if there is a glycemic variability, the mean A1C may be normal, but the glycemic variability, that is what we call it, say, you can measure it through time in range. It is also linked with long-term diabetes complication. Let me give you an example. If some patient who is measuring his sugar 3 times, 4 times, like many of our type 1 diabetic patients, they self-monitor their blood glucose level. One of our diabetic patients who is measuring 4 times a day, and you can see almost all 3 and 4 report of his sugar are absolutely normal. Early morning, lunchtime, dinner time, bedtime, absolutely sugar is fine. But if we do the continuous glucose monitoring, what we are seeing that actually he is developing pre-lunch hypoglycemia. Post-lunch, there is a little hyperglycemia, and midnight hypoglycemia too. So actually, on a self-monitoring of blood glucose, which is like taking a photographs, you are taking 4 photographs in a day and putting them on a social media, every time smiling, absolutely fine. People will think that you are very, very happy. But if you do the continuous glucose monitoring, if you do the videography of your 24 hours, 48 hours, 72 hours, or even a week or 2 weeks, then you will find there are time when you are not happy. And this is what you can measure by continuous glucose monitoring, which is like a videography. The same patient who is doing 4 times sugar, but doing a continuous glucose monitoring, we can measure where the person is getting actually hypo and hyperglycemia also. So how do we monitor our glycemic control? We are measuring A1C. Since last DCCT and UKPDS trial, what we could understand, a long-term glycemic control can be measured by just getting the A1C, which gives you roughly the last 3 months, but it does not give anything about the future. It does not give you anything about today. It gives you the what is the HbA1c of last 3 months, the mean A1C or mean sugar of last 3 months. And you may have 2 different type of patients with the same A1C, and you may find that these patients may have different type of glycemic variability. One patient have a lot of fluctuation, while other is almost no fluctuation, absolutely fine, but both patients may have similar A1C. So is it enough to just chase A1C alone. That is what we are doing. Like I'm giving you one more example, where 4 patients, all of them have a A1C of 8. One patient with a fasting hyperglycemia. The other patient is fasting hypoglycemia. The third patient is actually post-lunch and post-dinner actually post-breakfast and post-lunch hyperglycemia. And other patient is a post-dinner hyperglycemia. So all these patients coming with a uncontrolled diabetes with 8 A1C. Now, if I just treat all of them in a similar way, try to achieve from 8 to 7. If I just increase the dose, whatever they are taking, will it achieve a tight glycemic control? It may get a good A1C, but there is always a risk of hypoglycemia, because one patient who is only having morning hyperglycemia, other patient is morning hypoglycemia. Both these patients will require different way of treatment. The other patient is post-dinner is very high, while other is post-breakfast and post-lunch. So you may require the short-acting insulin or AGI or nutrition counseling, but at different times of the day. So it is the continuous glucose monitoring can precisely tell you where you have to do the intervention, while getting a A1C will give you the roughly the average glucose of last 3 months. So these 4 patients are to be treated in a very different way. So what's the rationale when we should get the continuous glucose monitoring? Unless you do the continuous glucose monitoring, we can't get the time in range. So the continuous glucose monitoring is required because A1C does not track the glycemic excursion. 60% of glucose low may not be revealed with only by doing self-monitoring, because they are getting hypoglycemia in between, and you are not going to get it just by getting their self-monitoring of blood glucose or random glucose monitoring. CGM identifies 4 times more serious glucose excursion than SMBG. Now, if I just do it, the CGM is especially beneficial for people who are not meeting their A1C goal, have frequent low glucose level, those are unaware of their low blood sugar level, want to reduce their A1C target without increasing the risk of hypoglycemia, and have widely variable blood sugar level, and the children and adolescents who are willing to use continuously device and to getting their continuous glucose monitoring at a time in range. We have in India almost all different varieties of CGM which are available. We have real-time CGM, the Dexcom one, as well as the Medtronic, and plus Libre. We have intermittently scanned CGM, that is what Libre, not Libre 2. Real time we have Medtronic and Dexcom. Intermittently scanned CGM, which is there with us, Libre. We have blinded professional CGM, which is Libre Pro, and iPro also from the Medtronic. And we have integrated CGM, which is in the pump, the continuous glucose monitoring readings. You can see that's what the integrated CGM is also available in our country with the Medtronic. So now, to tell you what the utility of continuous glucose monitoring of diabetes. I mean, do we have a strong evidence? And this is what the ADA recommends, that we should try to achieve less than 7 A1C for type 1 diabetes. In DCCT trial in 1983, they tried to achieve A1C of less than 7 in type 1 diabetic patients. With a mean A1C of 9, they could achieve 7.2. But at the risk of hypo risk was 62 per 100 patients here. And after 25 years, almost similar type of patients with a type 1 diabetic, adults type 1 were excluded, but these were the juvenile diabetic. Severe hypoglycemia risk is reduced from 62 to 20 per 100 patients here. And the mean A1C they could reduce from 7.6 to 7.1. This is after 25 years. Yes, definitely more analogs would be available for that. But pivotal trial, after 8 years, it was like an integrated CGM where they were using the pump along with continuous glucose monitoring. And what you could see, the risk of hypoglycemia was almost negligible, from mean A1C of 7.7 to 6.9. So this is the utility of continuous glucose monitoring. You are using CGM, and without CGM, you can see significant difference as far as risk of hypoglycemia and still achieving a tighter glycemic control. But we have a lot of data for type 1 diabetes. Do we have data or strong data to suggest that continuous glucose monitoring to be used in type 2 diabetes? This is one of the consensus statement almost 3 years back put in Journal of Association Physicians of India, JAPI, using ambulatory glucose profile for type 2 diabetic patients who are on oral anti-diabetic agents, not on insulin. What's the consensus? Whether they should get it here or not? Yes, by doing ambulatory glucose profile, by doing continuous glucose monitoring, these patients are motivated to have a tighter glycemic control. Similar, one more paper by Mohan also, using the retrospective continuous glucose monitoring, optimizing the management of type 2 diabetes in India. This Mohan paper, again, in both the papers, I was part of it. And this was an international consensus in 2017, where more than 35 experts from all over the world were talking about the consensus on the use of CGM. And I was one of them, is a lucky person to be the part of this CGM international consensus, and we decided that all patients, type 1 and type 2, who are on insulin, on hypoglycemic agent which can lead to hypoglycemia, should be on continuous glucose monitoring. And in 2 years after, in 2019, a time in range, a target was put that if person is doing continuous glucose monitoring in a garden variety of type 1 and type 2 diabetic patients coming to your clinic, more than 70% of the time, they should be in range of 70 to 180. It is not acceptable if they are going more than 5% of the time in hypoglycemia, below 70. It is not acceptable if they are going more than 25% of the time, more than 180. And not acceptable if more than 5% of the time this sugar goes in grade 2 hyperglycemia, which is more than 250. If it happens, change the therapy. That is what is required. And more than 70% of the time, the person should be in the range between 70 to 180. If someone is elderly, high risk for type 1 and type 2 diabetes, hypoglycemia unawareness, or risk of hypo is very high or limited lifespan, then still it is advisable for them to have more than 50% of the time in range. But it is not acceptable for them to go even 1% of the time. Less than 1% is okay, it is acceptable, but more than 1% of the time, even sugar goes less than 70, it is not acceptable. You have to change the therapy. So the hypo risk you have to reduce for these elderly high-risk patients, whether they are type 1 and type 2. If they are becoming pregnant, type 1, for pregnancy, the glycemic control becomes slightly more tighter. Instead of 70 to 180, we want to keep between 63 to 140. Again, more than 70% of the time. And if it is hyperglycemia in pregnancy or type 2 diabetes is getting pregnancy, then it's almost like 90% of the time the sugar should be between 63 to 140. This range or this time in range concept and the target is being accepted not only by American Diabetic Association or ESD, but almost all across the world, all major organizations, which include JDRF, SPAD, AS, Pediatric Endocrine Society, FAND, American Association of Diabetic Educators, and even our Diabetes India too. This is one paper which we have written for time in range as a target in type 2 diabetes, an urgent need. We need a time in range should be a target even for type 2 diabetic patients also. They cannot be only with A1C. But at present in our country, we don't have all the patients are putting on a continuous glucose monitoring, so we can't have time in range for everyone. For type 1 diabetic, there are data to support that. If you have a better time in range, there is less microvascular complication. If you have less time in range, there are more microvascular complications, whether it's a retinopathy or microalbuminuria. It was American Association of Clinical Endocrinology in 2020, when 2019, the time in range concept was put and ADN in diabetes care, it was published. The ACE was the first one to put it in a part of guideline as 11 principles of comprehensive management of type 2 diabetes, using continuous glucose monitoring whenever indicated to assist patient in reaching glycemic goals safely. And this is what CGM is part of a comprehensive management of type 2 diabetes patients. We had also done a few more papers before even TIR and continuous glucose monitoring consensus was there available internationally. We were having few more papers even before it also. This is recently a paper that how frequently we should do a continuous glucose monitoring to get a time in range, a concept of time in range, particularly for South Asian people who are not getting their CGM continuously. And this frequency, which we thought of that at least it should be once in 3 months for an average patient. We were having idea of President-elect Akhtar Hussain, who is from Bangladesh. We have Abdul Bashir from Pakistan. We have Pratik Chaudhary, who is from UK, from Indian origin, from Siddharthwan, from Indonesia, and me, Jyoti Dev and Mishra, were part of this study, the frequency of continuous glucose monitoring, along with Sanjay and Arvind from RSSDI and Diabetes India, that what should be the frequency. But if somebody is keeping very good control, even this frequency could be once in a year also. So at this point of time, can we say the time in range is going to replace A1C? Probably not, because in India, these three technology of monitoring, whether you talk of random blood glucose monitoring, A1C, or doing a continuous glucose monitoring, all three are complementing each other. They are essential for our patients to have A1C. That gives you roughly the sugar of last 3 months, getting the random blood glucose monitoring to guide the therapy, and to do a 14 days either CGM continuously or retrospectively will also guide and motivate and educate these patients for better control of diabetes with less risk of hypoglycemia. Let me give an example for a routine type 2 diabetic patient. This is how the guideline is treating our diabetic patients. A patient with 9.2 A1C had come to us with 3 oral anti-diabetic agents with a gliptin, metformin, and glimepiride. Patient was advised to have insulin because triple drug therapy, 9.2 A1C, insulin is the choice of therapy, and patient was given a choice of starting the basal insulin. Patient was not very keen to start the insulin therapy. Patient of 6 years of diabetes, patient was overweight. The dietary history was saying that a lot of carbs, he's a lot of calorie. What we had done is we asked the patient, let us do your continuous glucose monitoring. On 5th day, we had seen that all reports are high. Post-meal glucose level are high. We asked the patient, yes, it is right time to start you on insulin, but if you can control your diet, let us put you on GLP-1 and SGLT2. We remove the gliptin and putting him on a GLP-1 and reduce the dose of glimepiride. And every alternate day, we reduce the dose from 2 to 1 milligram, 1 to 0.5. And on 11th day, patient sugar was absolutely well controlled. When third time patient had come without any hypoglycemia, and we stopped the glimepiride also. And this patient was ultimately kept only on GLP-1, SGLT2, and on metformin. And after 2 years, patient had lost significant weight loss. Now he's even GLP-1 and SGLT2 also stopped, and now he's only on metformin. And you can see after 4 years, patient is only on metformin, keeping his A1C less than 6. So how the continuous glucose monitoring can guide the therapy, the way we are treating our diabetic patients, even a type 2 diabetic patients, it can change the way we are treating our diabetic patients. Only by going for A1C may not be sufficient. We have to do something more or beyond. Like these type of patients, sometimes only post-breakfast hyperglycemia. Some patients have only post-dinner sugar and their sugar are well uncontrolled. This is 8.1. Otherwise, is fine, except the post-dinner sugar are very, very high. So continuous glucose monitoring is assisting us to discovering unknown hyper and hypoglycemia. It gives us the observation of glycemic variability. It assesses the percentage of time in range and out of range. It also gives us the severity of hypo and hyperglycemia during day and night time. It provides actionable information which is derived from continuous glucose monitoring report. It highlights impact of behavioral variances. It analyzes glycemic effect of new intervention effectively and efficiently. Like in this patient, we had done the SGLT2 and GLP-1, and it also gives us care for diabetes is getting digitalized. Even the distantly patient can send us the report of CGM. So CGM enhances patient self-management, adherence, and confidence in diabetes management. Thank you. Thank you very much, my dear friend, Dr. Arvinda, for giving me an opportunity. And thank you all the participants and audience who are listening to us. Thank you. Thank you very much.
Thank you, sir, for your brilliant and focused presentation. And you have rightly pointed out that based on the data, the newer marker, newer metric, time in range, will supplement HbA1c in a good subset of type 2 diabetes or type 1 diabetes. In fact, one study I have undergone, DICOR study, which has pointed a very important issue that in 7 days period, they have found that there were 44% inadequate prandial dose of insulin. 64% of patients were found to be postprandial hyperglycemia. 40% of the patients were found to have nocturnal hypoglycemia, 35% of patients nocturnal hyperglycemia, and 23% down phenomena. So meaning by that, there are patients, subset of patients, those who need the additional marker, additional metrics, supporting the HbA1c. So thank you, sir, for highlighting, and you were part of many of the researches done over the TIR. So thank you very much once again for highlighting.
Thank you, sir. Thank you, sir, for your much needed, much awaited oration. Now, normally there will be no questions for the oration, but I take this opportunity to be relaxed. And if any questions are there, we are free to discuss. Dr. Banshi Sabu is here. Any questions is there, we can take up.
I can see Dr. Kamlakar Tripathi, sir. Pranam. Partha is also joined.
Yes, sir. Sir, Dr. Kamlakar Tripathi, sir, any questions, sir?
No
question. No question.
He can make comments.
It has been the
cannot be any
wonderful
questions from
presentation.
Kamlakar.
No question. Great presentation. No question. Enjoyed it.
Thank you, sir. Thank you so much for being a part of our conference, and happy to all of us. You bestowed the keynote oration for us. Thank you so much for the time and presentation. Thank you.
Thank you.
Thank you once again, sir. So may I now invite another speaker, also a very legendary speaker, professor of Banaras Hindu University in medicine, a Padma Shri awardee. He has a lot of credential in his pocket. He is MD, DM, DNB, MNMS, FISH, FIAMS, FFR, SSDI, and many others. The Professor Dr. Kamlakar Tripathi, everybody knows he doesn't need introduction to this gathering. So without wasting time, may I invite Professor Dr. Kamlakar Tripathi, sir, to give his oration about the mineralocorticoid receptor antagonist, which we say MRA, in diabetic kidney disease. Over to Dr. Kamlakar Tripathi, sir.
Can you see my slides?
Yes, sir. Sir, before that, on behalf of ADC and ADC International Virtual Diabetes Summit 2020, it gives a great honor in bestowing Dr. Kamlakar Tripathi with the keynote address oration, and it's a prestigious moment for all of us that he got Padma Shri Award this year, and it's a proud moment for all of us. Thank you, sir, being a part of our conference. Over to you, sir, for your
Thank you, Dr. Arvinda, for such a beautiful organizing meeting and getting all of us together. Are you seeing my slide now?
Yes, sir.
Yes, sir.
So I've met Dr. Sinha before, and he's a very good clinician from Patna, and often we talk and meet, and our patients are quite common. They come from the same group.
Thank you, sir.
Nevertheless, we have a subject which is one of the recent molecules which have been introduced for the treatment of diabetic kidney disease. But we have been talking this molecule for a long time, and nephrologists have known it. And why they have known it? Because when you walk in a dialysis unit, when we were the trainee about 40 years before, most of the less than 1/3 patient would be from having kidney. Now we have 50% patient close to having a chronic kidney disease across the population, 37 million. And 6 times higher risk for the cardiovascular death. So looking at the various aspects, now we are looking for the molecule which are the friendly to the kidney, friendly to the heart. These new molecules have come in, and we'll be talking little about the pathogenesis and what is the added advantage. This is the risk of CV event in patient with diabetes increases as albuminuria progresses. This is the only clinical condition, and often asked in the post-operative examination, what are the conditions in chronic kidney disease where the proteinuria increases? Normally what happens when GFR decreases, proteinuria also decreases slowly. And you must have seen end-stage renal failure patient, whether they are dialysis, no dialysis, their albumin excretion is low. Diabetes is the only kidney disease, and of course amyloidosis, where you continue to excrete more albumin and GFR falls. This more excretion of albumin is a strong driver to take the kidney in further deterioration. This is what happens to begin with: the hyperglycemia, the bad milieu, which leads to angiopathy, microangiopathy, the cell dysfunction. Then a lot of vascular neogenesis. That's the reason why in stage 1 of the diabetic kidney disease, you get more surface area. Stage 1 is a hyperfiltration. You get increased eGFR up to 140. Then podocyte damage, basement membrane damage, and proteinuria. Now, it's important here that these drivers are hemodynamic drivers, and we have taken care 40 years back by introducing captopril, the ACE inhibitor drug, and later on we had the lisinopril, we had and ramipril came last, and we had a very famous Morganson trial, HOPE trial, which have shown the hemodynamic alteration can retard the progression of kidney disease. We also have a very wonderful drugs now, metabolic control. We have SGLT2 inhibitors, we have GLP-RA, and many more drugs to be extract in time and range.
What we have not answered so far are the inflammatory cytokines and fibrosis, which takes very strong right. And these patients tend to deteriorate so fast the moment it happens. So there is tubular interstitial damage, sclerosis, mesangial explanation, and glomerular hypertrophy. The bad milieu is related to NF-kappa B, JAK, STAT, neprilysin, and NRF2, Rho kinase, and a lot of pro-inflammatory cytokine ultimately drive to the macrophage infiltration and progression in chronic kidney disease. This is the podocyte, and this is the ultrafiltration diagram on the center of the two diagram, and this is the pore. The pore between the epithelial cell and endothelial cell. Why this diagram is important? Because kidney embryologically develops from two sources. One is allantoids from the ectodermal origin of the gut primordia. Second, from the mesodermal origin, from where we have blood vessels and glomerular tuft. So they have a different transcription factors, legacy, and the memory. Podocyte damage is the first event in hyperglycemia-induced apoptosis, and this is the first lesson I want to convey to you. High glucose increases reactive oxidative species and sequential upregulation of cytochrome 440, and exposure of podocyte to high glucose increases intracellular calcium concentration. One of the philosophy behind using calcium channel blocker, newer calcium channel blocker like Selacar, even amlodipine has a potential to improve on podocyte function and improve on the albuminuria. And this is the hyperactive RAS contribute to the elevated glomerular capillary leak, and the podocyte high glucose also results in angiotensin II level elevation and TGF-beta mediated podocyte apoptosis. The last word, epithelial to mesenchymal transition. This is a new terminology. And there are the two new transcription FOXO4 on extreme my right side. And then we have a calcineurin, which is very, very popular drug, calcium and calcineurin, which is responsible for hyperglycemia-induced apoptosis. This I was talking to you, a new terminology which is called epithelial mesenchymal transition. The moment podocyte permeability is impaired, there is damage to the podocyte much earlier, about 8 to 10 years before you get a clinical albuminuria. There is change of the epithelial cell, which is the podocyte-based cell, into the mesenchymal cell and responsible for the fibrosis and the fibroblast. So we do not have a treatment, I said in the beginning, for the hemodynamic based inhibitor, ARBs, calcium channel blocker, SGLT2 inhibitor. For metabolic, we have equal number of good drugs, GLP-1, metformin, other anti-hyperglycemic agents, SGLT2 inhibitors. But we do not have good drug for inflammation and fibrosis. Now we are going to talk about it. So at bad diabetic milieu, the podocyte injury, hyperfiltration, mesangial cell transformation, mesangiolysis, and tubular interstitial injury would lead to decrease in eGFR ultimately. So I'm now reversing the whole what I talked in the beginning. I'm starting now with the podocyte damage first in the pathogenesis, then proteinuria, then mesenchymal cell transition, then glomerular hypertrophy, then fibrosis, sclerosis, hypertension, and end-stage kidney disease. So this is where we stand today in 2022. Now, in spite of drugs like losartan, we had a renal trial. We have a 16% only risk reduction. When we got little more better drugs, SGLT2 inhibitors like canagliflozin, Credence trial, we have 30% risk reduction. And having DAPA-CKD and other combination of the drugs together, we have only 43% risk reduction. So close to 50% patients are still left who we have not been able to manage, and that's why there's a need of new drug. So these mineralocorticoid receptor regulate gene expression through cofactor, including aldosterone, RAC1, cortisol, and overactivation signals leads to TNF-alpha, interleukin, and IL-6 overactivation, and that's how it deteriorates the structure. Aldosterone is known for ages, and we call it what are the causes of secondary hyperaldosteronism like congestive heart failure,
like patients with cirrhosis of the liver. But aldosterone is a bad driver. It leads to sclerosis, interstitial fibrosis, proteinuria, also to the cardiac fibrosis and cardiac dysfunction and endothelial dysfunction. Now, on my right side, we have a drug which have been known as spironolactone. We have a canarinone. We have a eplerenone, which is now being used for the last 2 to 3 years. On my other side, it is a dihydropyridine, finerenone. And I said in the beginning, it is the calcineurin calcium binder based concept which has given us this molecule of dihydropyridine. If you have a dihydropyridine, non-dihydropyridine calcium channel blocker, so it belongs to that group. And it takes care of MR activation, thereby down-regulating pro-inflammatory cytokine and also trying to reduce glomerular fibrosis. So this antagonist, what they do, they improve on the podocyte, reduce the podocyte damage, smooth muscle cell, oxidative stress is also taken care of, blends phosphorylation of contractile protein. They improve the endothelial cell. They also work on the T cell and also work on the macrophages and the fibroblast, which is most important, and the mesangial cell. Now, this is the isomer, and this is the aldosterone on one side. This is the mineralocorticoid receptor on the other side, and they are the cause of the kidney disease by the mechanism of vasoconstriction, oxidative stress, inflammation, and sclerosis. This is the journey 1938 onward. We had a famous, and this is the same Starling was the physiologist 1938 discovered what is called Doka escape phenomenon. And this is the forerunning of that particular concept. In 1955, MRA was discovered, and today in 2019 we have the molecule. This is the 3 molecule is spironolactone, which is cyclopentane phenanthrene, cyclohydrophenanthrene nucleus, which is a mother molecule for all the steroid. Then we have eplerenone. These are the 2 steroid. We have a now Bayer's non-steroidal finerenone, which has got an advantage on the cardiovascular effect by decreasing the mortality and hospitalization of congestive heart failure, and post-MI decreases BNP, anti-pro-BNP, improves on diastolic dysfunction, improves on fibrosis. Arrhythmia is arrhythmogenic. Aldosterone produces a lot of arrhythmia, oxidative stress, and atherosclerosis progression. The advantage is it doesn't produce hyperkalemia, what we used to get, so it prevents the what the increase in hyperkalemia. It also had the disadvantage of creatine, but it does have a little hyperkalemia. I'll come in a moment that it acts on the same principle, therefore the potassium retained, and we need to keep an eye on it. These are the 2 trials, the Fidelio and Figaro. You will be listening a lot. Dr. Shashank Joshi delivered about a month back. The Fidelio primarily belonged where the mean eGFR was the low, 44.3. But the urinary albumin creatinine ratio was higher, more than 300 milligram per gram in 87.4% patient. So low eGFR, high protein. On other hand, we had a Figaro in which we had a high GFR near normal 67.8, but proteinuria was only 51.2 and 46.0 in the patient of the group of 300 to 300 milligrams. So these are the 2 subsets in which it was done, a double blind crossover study, the Fidelio CKD and Figaro CKD. And this was done, the Fidelio was done on 5,734 patients, randomized double blind placebo control, event driven phase 3 trial. And the other was the Figaro in which it was 7,437 patients, and then they were crossed each other. This is the result. The maximum tolerated ARS therapy. So these patients had already ARB or ACE inhibitor. The finerenone significantly reduced the primary kidney outcome by 18%. Now, mind you that the previous graph, where 47% patient out of that slot, 18% further risk reduction was achieved in those patients who had albuminuria in Fidelio trial. And it was 30%. It was the close to 30% reduction, 31% of urinary albumin creatinine ratio between baseline and 4-month therapy. The secondary endpoint was also reduced up to the 24%. Now looking at the secondary CV endpoint, there was 14% extra advantage of what we call 3-point MACE, 4-point MACE, CV death, non-fatal MI, non-fatal stroke, hospitalization. So that's what on advantages of the 3 to 4 drug which have been conventionally used for the treatment of the diabetes. But it also reduced on the top of the optimized RAS blockade, reduced the risk of the primary CV even by 13%. So this is another advantage. Coming to the combining the two, when you look at the another point, and this is the debatable point, I think you must know this, and that's why I have kept the slide. It did not significantly reduce the clinically accepted more than 40% decrease in eGFR kidney outcome. Meaning by those patients who already had very poor eGFR was not significantly, did not improve. Nevertheless, ESKD occurred in 0.9% to 1.3%. Doesn't look like great one in terms of statistics, but ultimately kidney failure sustained more than 57% decrease in eGFR from baseline. Why I'm saying this? Because invariably, whatever stage of the diabetic kidney patient has, it would continue to deteriorate whatever medicine you give. The only advantage of these drugs would be to retard the progression, to add few more years till patient goes for the dialysis or transplant program. In both Finerenone as well as Figaro trial, both, there was hyperkalemia, I said in the beginning, but clinically it was not very significant, and there was no death due to hyperkalemia, and the incidence of treatment discontinuation or hospitalization due to hyperkalemia were quite low. This I was talking to you in the beginning also, that the ultimate, the square mean change into the after randomization over the period of the eGFR, looking only at the eGFR. In the beginning, there would be transient drop in eGFR, but as the time would pass, slowly it would be restituted. Like exactly what it happens sometimes in SGLT2 inhibitors also, when you give these drugs, then these drugs also in initial phase could have a drop in eGFR, and subsequently they recover over the 3 to 6 months. This is the outcome data in relation to the effect and the side primary composite outcome, and you look all the parameters, whether it is end-stage kidney disease, eGFR less than sustainable to less than 15 ml, sustained decrease in more than 40% eGFR, death from renal causes, death from cardiovascular cause, non-fatal MI, non-fatal stroke, all they favor Finerenone to the extent of 32% to 20%. So it has a significant acceptable range when it comes overall, and that's what we got the composite kidney outcome, CV outcome, time to first occur about the, and this is the fidelity. Fidelity means pulling both data together, the Fidelio, the Figaro, when they were put together, ultimate result was there was improvement in relation to CV death, non-fatal MI, non-fatal stroke, hospitalization, so 4-point MACE, and onset of kidney failure, ESKD initiation, sustainable more than 50% decrease of eGFR from baseline, and renal death. This is the fidelity. The last slide, you look at the bar, you look at the green bar, the CV death, 14% reduction, non-fatal MI, 12% reduction, 9% with non-fatal stroke. Overall, it was 22%. Figaro was 29%. Fidelio was 14%. So this is the composite, ultimately, advantage you get overall by the total CV outcome. This is the fidelity, looking at the 23% advantages over the significant effects of the outcome on the kidney. The fidelity SGLT2 subgroups, this is important. Many people ask this question, what should we do with SGLT2 inhibitors? SGLT2 was at the baseline, and it was added in these. There were about 6.7% patients who were on SGLT2 inhibitor. And even with SGLT2 inhibitor, they had a 32% from the baseline without SGLT2, with SGLT2, 37%. So there is advantage in relation to the proteinuria improvement in these patients. This is the summary slide. Finerenone overall on the 5,674 patients, primary composite 0.8% risk reduction and 13.0% risk reduction in relation to the kidney as well as to the heart. So to summarize, finerenone has shown CV and kidney benefit in patients with CKD and type 2 diabetes patient in 2 different phases of the trial. And as a prospective pooled analysis of the Fidelio DKD and Fidelio trials, it reduces the risk of CV mortality by 14%. This is add-on, and CKD progression by 23%. So it's a nephrologist-friendly molecule. It is I understand it's a costly molecule, next question would be, but it is now being prescribed by nephrologists looking at these results. These are the ADA guideline 2022. It has been kept at the level of evidence A in both recommendation on chronic kidney disease risk management, section 11, patient with CKD who are at increased risk of cardiovascular event of CKD progression is recommended to reduce CKD progression and also to improve cardiovascular outcome and reduce the risk of CKD progression. Thank you very much.
Thank you, sir. It was, as usual, an excellent presentation by a professor. Almost you have covered all the aspects of the CKD and the role of MRA and the newer MRA. And you have covered those areas, I mean, that from podocyte damage to CKD full-blown, there are many steps. And we have many agents like ACRB, cilnidipine, newer SGLT2 inhibitor, but there is a role of the aldosterone inhibitor. Why we are not using? We are afraid of many of the side effects, particularly hyperkalemia. And you have pointed out very clearly that we cannot regress the kidney disease, but we revert the kidney disease, but we can, prolong the survival for more years. So regression, we can say, and you have pointed out the newer the MRA, the finerenone is having its proof that he has emerged molecule of choice so far the MRA is concerned. And one important point more about the finerenone, it causes less of hyperkalemia, which we usually fear about it. So thank you, sir, for your wonderful and excellent presentation. As usual, I have heard many times. Thank you. Thank you. And if the house is open for comment any. So not a question, any comment, anything. Dr. Professor Arvinda.
Thank you, sir. Thank you, sir, for taking your time out and presenting this keynote oration. We at ADC, we are very pleased to have you with us, and it was an honor for us for your keynote address. Thank you so much, sir. Thank you so much.
Right.
We can move on to next.
Next topic. Moving to the next topic, may I invite Dr. Parthakar, and he's going to take us the future of diabetes. And what I know from my little knowledge, that there are bad news because the prevalence and incidence of diabetes is going to up and the complication will up. But there are also good news. So good news is that many of the new things are coming. We have seen the SGLT2 inhibitor has emerged. Many new things. Scientists are working and some new modality to regress diabetes or to revert diabetes. So they are working on many of the agents. The hormone they are working on. They are trying to manipulate genetics. They are trying to put it out the newer agents. So there are many things. So bad and good both. So I invite Dr. Parthakar, and he has been a consultant in diabetes and endocrinology in Portsmouth Hospital since 2008. He has been the clinical director of diabetes. One of the main areas or passion is in helping to design diabetes care to integrate chronic disease management. He is also the co-creator of TAD Talks. He also holds the role Associate National Clinical Director. So he has a lot of credentials. So without wasting time, I invite Dr. Parthakar to start his oration. Thank you, sir.
Thank you. Thank you very much. I hope you can hear me. Okay. Yeah. Can you hear me? Yeah. Okay.
Yeah. So voice is less.
Voice is less. Is that better?
Yeah.
Yeah. Okay. So first of all, Aravinda, wonderful. I mean, this is fantastic. What you've organized, I think you should be really, really proud of this. I mean, to see, while I was hearing two amazing speakers before me, I've heard Banshi speak, and then I heard Professor Tripathi speak, some amazing talks. But then I also took some time to look through all the speakers, and that is amazing. So fantastic work, Aravinda, and all the way from UK, my best wishes, and this is really lovely to see. So well done on that to begin with.
Thank you.
And you know what? And I think that rolls on to a little bit about the talk that I'm about to do, which is what is the future? And I think you are probably showcasing a little bit of the future itself, whereby you can have a lot of the special, your country and where you are in the science doesn't matter. You can have people like you getting people together to discuss. That is part of the future. I mean, 5 years ago, we wouldn't have been thinking like this. But so I think that's what I would start with. So first of all, let me share my screen if it all works. Bear with me. Okay, so hope you can see that, and I will. Right, so hope you can see it now.
Volume can be higher, Partha. I think this is a low volume.
Low volume, yeah, I think the speaker is playing up. So let me try this one. So hope you can hear this. That's a bit better. So this is a peek into the future. So what does the future look like? So first of all, I'm going to show you this slide. We have all grown up remembering watching Captain Kirk in Star Trek. And Star Trek is a very good example of where they always predicted the future. So look at this slide. 1966, they talked about mobiles. Mobiles came out in 1973. In 1987, you had people talking about the iPad. Then it came out in 2010. 1988, they were talking about online and teleconferences. 2008, it actually first came out. And then in 1998, they were talking about Google Glass, which then came out in 2013. So Star Trek has always been a look into the future. And I won't even go into the example of when we first saw those Captain Kirk and Spock walking through doors which just opened, you know, with that noise. And nowadays, it's just part and parcel of what we do. So that was a very good example. So where is the future heading? What is the future? Does the present time give us an idea where the future is going? We all know about this. Banshi made a really fantastic talk about the non-invasive sensors. And where will this head to? So if you can predict looking at the future, along with this, you have all of this, people talking about closed loops, pumps, etc. Where will this go to? So I think this will end up going what we call the Netflix way. Or, for example, what has happened to monitoring of heart rates, etc. I think your sensors will end up being on your smartphones. Most people will have it. They'll be integrated in your watch. And I think it will be smaller, smoother, and more integrated. That is where I think the future is heading. Now, when we talk about artificial pancreas, at the moment, they're not completely artificial because it doesn't have glucagon in it. You still have to input some data in it. All the research tells us that that's where this is going to go. So what we're going to have is sensors integrated into watches. And I think you will have the genuine artificial pancreas being created whereby you don't have to do anything. You will have suspens which stops your glucose from dropping. You'll have glucagon going into the system when it's needed. And if you look at all the research going on, that's where we are at the present moment. That's not very far off from where we need to be. The other thing that will happen very quickly, I think, is the immunology thing. So there's a lot of research going on, and most of it led by JDRF and Colin Dyan in Wales. And it's worthwhile listening to that talk. What are the research they're doing? And what they're saying is that we're going to try and predict which people are most likely to have type 1 diabetes by doing autoantibody screening. So we're talking about doing it in the next 5 years. And if you pick them up, then what you do is make sure you give them immunology treatment to stop them from developing type 1 diabetes. The screening is obviously, this is called the ELSA study. So you might want to look it up. There was a lovely poster at the EASD, which talks about what the ELSA study is trying to do, which is about trying to pick up people who may develop type 1 diabetes, doing autoantibody screening, and then giving them immune therapy to try and treat them so that they don't develop it. So that is exciting in its own right. And finally, people talk about the cure. Now, I have been hearing about the cure of type 1 diabetes since I was in medical school. So every time you hear that every 10 years, it may happen, it may come, okay? And I think what we have right now is things improving and moving in the right direction, where people are talking about that it might happen, it might change, etc. So that is quite important to remember where things are at. So cure at the moment, the thing that I would like you to look at is the one that is happening in Indianapolis, which is talking about stem cells being integrated into the arm. The organization that is doing it is called ViaCyte, which is very exciting, lovely to see, and some really exciting research in this space. So if I look at type 1 diabetes prediction, I think technology will become smaller, integrated into watches, everything like that. You'll have genuine artificial pancreas, you will have screening of people, immunology being used to stop them from developing type 1 diabetes. And finally, I think you will also be looking at the potential of the cure. I've given a question mark on it, simply because it has always been a question mark. But at the present moment, as I said, the work being done by ViaCyte looks very exciting. So it may be worthwhile Googling and finding out what they're doing. At the moment, the problem they're having is not about the cure, but having sustained cure. So what they're getting is that you input the stem cells. How do you stop it from being destroyed by the body's immune system itself? That's the challenge they're having. So then if we go forward, if this works, is what you will find is what we are struggling with at the moment. Oops, it's not moving. There we go. So 3 planks of things that will happen. So I'm trying to see if I can go back. So we moved a few. So what about type 2 diabetes? We've talked a lot about reversal or remission of type 2 diabetes. I think that will come more and more into the fore. The debate about I listened to the talk done about the diet and the intermittent fasting. And I can tell you one big thing will happen as I was being introduced. The big change that will happen is people will still be struggling on what is the best diet. The best diet in the world is the one you can afford. That is the most important thing. And I think what policymakers should focus on is not the best diet just on the science, but what can you buy with the cheapest amount you can do? Because that is where you cannot dissociate politics and science. Because what we do as scientists, we always say, well, I do the science, I do the papers. It is up to the politicians to implement. But all our science is worth nothing if we can't get it into the people's lives. So if we say, for example, we talk about these newer classes of drugs, and we would like people to get SGLT2s and CGMs and GLP-1 analogs, but we know that most people can't afford it. So unless politicians cross that divide, and I think that will happen more and more, because I think the more competition will come, you will have more people developing products which are easier to access because of the price range shifting. And I think India has led the way a lot by doing their own versions of it. And I think that will happen more, which is quite important. Metformin will probably also come off the first line, I think, because if you look at already the European Society of Cardiology, they're talking about metformin being moved off from the first line. So I think that will happen. And EASD talked a lot about precision medicine. So I think that is very important, where you can do tests, find out which drug will fit the person best. So I think drug prices will come down. And already you're having talks about moving away from receptor agonists. You have GLP-1 receptor agonists. We're now talking about dual receptor agonists. I've been at EASD and seen posters on triple receptor agonists. The point is that particular science will continue to evolve. But again, I think the price will be the big thing. And I think that's where people making their own products will be quite important going forwards. So that will be a very, very important part of development as we go forwards. This, however, will continue. And this is, I've said, is type 1 diabetes. The same for type 2 diabetes. This will be a challenge. People know my views on these things about and this is, I think, most people will start to understand that number 3, which is us, we don't have time on our hands. So whatever tools we can develop to help people more with self-management will take the burden off us. And that's what I think the future will hold. Going into the future, you'll find more people being pushed towards doing more self-management. And I think that's where the poverty comes in. That's where your cheaper drugs comes in. That's where your sensors come in, because it helps you a bit more from that point of view. So this doesn't come up, but basically it was a Libra growth that's happening. But I think I'm going to say this bit about the future. This is the most important bit, is that in 2035, there is a very decent chance our gaps in the world will continue to open up. So India, let me take the example of India. It's now one of the big economies in the world, but we still have the big divide, financial divide. Now, then you take the example of UK. It doesn't matter, even if you fund everything, we still have big gaps in deprivation, irrespective. So the question that I think a lot of policymakers will have, the science will evolve, as I said, in technology will evolve, newer drugs will come through, cheaper drugs will come through. But I think we need to have better engagement with our politician friends to make sure these are accessible, because otherwise the divide will continue to widen. And I think the outcomes will continue to be in 2 folds, which will be, if you can afford it, you will have the best diabetes care, some amazing stuff. If you can't afford it, I'm afraid you will have the outcomes of heart attacks and all of that still continue to go up. So that is the worry I would have. So I'll finish there and take some questions. But for me, the vision looking at the future is very mixed. I would say it will be exciting, but it will be exciting only if you can afford it. And I think that's where we as a community also need to work hard to see how can we push industry to do cheaper products. How can we get our political masters to buy into it? Because our job also is to cater to everybody, not just a few. So I'll finish it there and then see if I can come out of it so I can take some questions.
Thank you, Dr. Partha, for your brilliant presentation on this topic. And you have pointed out that the future is not bad, it is exciting, and you have put the role of artificial intelligence in the management of diabetes. The only thing you have pointed out that the cost is important factor, and unless until the regulators and promoters, politicians, they should take interest, and then the thing will be easier to manage the diabetes and its complications. So thank you once again. And
always, Dr. Partha, as you rightly pointed out, the Star Trek and all, I always be telling at home to my kids as well, outside to the youngsters, I always say, think wild, something unimaginable you think that is possible. He said, what you're talking, how can I say? No, something you should think, innovative. Flying cars, yeah, you think of it. It may be a reality, we don't know. Next 10 years in Bangalore, we might be flying, we can grumble with traffic jams and all those things. We can directly fly from here to airport in the car and then go from there. So always think of future. Like by 20 years down the line, we have seen so many changes. Why 20 years? Since 5 years, as you rightly pointed out, we were not imagining whether we are doing a conference like this. We never imagined that we'll do it like this, virtually and all those things. So future is, we can't predict, and what things comes, we never know. And thinking appropriately, and as you said, there are so many factors involved in the innovation, cost, policy makers, all those things are there. Very aptly presented, Dr. Partha. Thank you. Thank you for being here and presenting your views from UK. Thank you so much. Dr. Bansi sir, any points, sir?
To say hi to Partha.
So Dr. Bansi is there means there are so many innovative things will be there always. So the things like we can't imagine, like his vision, if you take 2030, the cure for diabetes. That is one of the things he's thinking of, like 2030 in the sense it is not even 8 years now. So it's a big vision, and it has been acknowledged by the former president of India, Sri Pranab Mukherjee. It's a big challenge. I'm sure.
The meaning is that, Arvinda, those who are born after 2030, they should not see in their lifetime the risk factor for developing diabetes. So the epigenetic factors which someone is having, so those who are born after 2030, the way we should change our lifestyle or society in such a way that they should not see in their lifetime the risk factor for developing diabetes. That was the vision for that. That
is the need of the hour, sir. If you take
so that is what we had planned.
Yeah, because see, nowadays you can see all these mobiles and spoiling the children with less of physical activity, adulteration, junk foods. These things has to be addressed. Your vision is very, very apt, sir. Very, very apt. Thank you, Dr. Partha.
Thank you, Partha. Thank you, boss.
On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit, I wholeheartedly thank our chairperson, Dr. Ajay Kumar Sinha, for taking your valuable time and being a part of our conference. I thank Dr. Bansi Sabu sir, Dr. Tripathi sir, and Dr. Partha Kar for being a part of our conference. Thank you so much for your valuable time. Thank you.
Thank you. Thank you.
We'll move on to next session. We have a food symposium. So to chair this session, we have Dr. Manish Jangam from Satara and Dr. Divya Saxena from Sonepet. Dr. Manish Jangam is a postgraduate course in advanced diabetology from Harvard Medical School, USA, postgraduate course in advanced cardiology at Harvard Medical School from USA. Dr. Divya Saxena is Director and HOD, Department of Diabetes and Critical Care, Saxena Multi-Speciality Hospital, Sonepat, Director, Orange Clinic, New Delhi. We have three interesting talk foot, which should not be neglected. So we have a discussion on that. 3 speakers, Dr. Ajit Kumar, Dr. Pawan, and our dynamic Dr. Suri sir is there. So over to the chairperson for further proceedings, please.
Yeah. Good evening, all. It's a pleasure to introduce Dr. Ajit Kumar. He's MD, MRCP, FRCP, and FRCP, and PG Diploma in Diabetology. He's a Chief Consultant of Department of Hyperbaric Medicine and Diabetic Foot Care, SP Fort Hospital, Trivandrum. He's a Joint Secretary, RSSDI Kerala Chapter. He's a Chairman and CEO of Kerala Diabetic Research and Care Forum. He's a Senate member to Kerala Health University. He has a lot more paper awarded, as well as he has a state-of-art diabetic foot clinic, as well as his areas of interest are HBOT. Is one of the most discussed point in diabetic foot care now. Diabetic foot infections and research in the area of high-risk foot assessment as well as its prevention. He has a lot more publications in national and international journals. Over to you, sir.
Thank you, Chairperson. Can I share my slide?
Yeah, please.
Is it visible?
Yeah.
Am I audible?
Yeah.
Okay, thank you. I think very good evening, all of you. I think first of all, I would like to thank the team ADC led by Dr. Aravinda. He is my close friend. I think I'm happy that from the first national conference, I am attached with him. So now it has become an international conference. So, but my job is today is to stick to our national statistics, especially in the field of diabetic foot in India. I wish him all the success in coming years. I'm happy to be here with all. I think today's topic is a very important, as Dr. Aravinda said. It's a most neglected area in the management of diabetes. We are more bothered about our heart, we are more bothered about our kidney, but we are least bothered about our foot. So in next 15 to 20 minutes, I'll be discussing about the diabetic foot issue, especially in an Indian scenario, the prevalence of it and the significance of the limb saving cancer. That is most important aspect. I will be concentrating the limb saving aspect and how we can manage the diabetic foot in a limited setup. This is a famous article. Most of you know that every 32nd a lower limb is lost somewhere in the world as a consequence of diabetes. Recently, this 32nd has been reduced into 22nd in an Indian study. So thereby, we all know the significance of the problem. And the diabetic foot and the lower limb complications are severe and chronic. I think the chronic ulcers and the amputation needs to result in a significant reduction in the quality of the life, because it is a very dreadful situation. Less than 1/3 of physicians recognize the signs and symptoms of diabetes-related peripheral neuropathy in their day-to-day practice when they see a diabetes patient. This is an Indian statistics study says that it is one of the most devastating chronic complications of diabetes, and it is a leading cause of lower limb amputation. And it says that many amputation is following a small trivial foot infection, either maybe due to the lack of the medical care or the bad healing due to the immunopathy or the vasculopathy associated with the diabetic foot is the reason for the high risk of amputations. A word about diabetic neuropathy, you all know it is a combination of the peripheral neuropathy, maybe a motor neuropathy, central neuropathy, and an autonomic neuropathy. And the peripheral neuropathy, which is the most common form of a diabetic neuropathy, which affects the leg, the feet, the loss of sensation, which makes the individual more prone for getting the ulcers and the complications. The prevalence of diabetes is maybe discussed in the previous the talks. The foot ulceration is one of the most common complications of diabetes because it affects the 15% of diabetic patients during their lifetime. And diabetic foot ulcers were found in 4.5% of patients even in newly diagnosed type 2 diabetes in India. Out of that, 46% was neuropathic, 19% was somewhere around ischemic, and 34.2% was neuroischemic foot ulcers. In the last few years, from the neuropathic, the neuroischemic foot ulcers are increasing. The prevalence is increasing in India, maybe because of the coexistent smoking. This is the burden of diabetic foot care in India. Out of 77 million diabetes in India, 25% develop diabetic foot infection, of which 50% becomes infected, and 20% may need an amputation following either an infection or an ischemia. So, and the small diabetic foot ulcers contribute approximately 80% of the all non-traumatic amputations in India. And patients with prior history of diabetes have foot ulcers have a 40% higher 10-year death rate. So treatment is very costly because once the individual gets a complication like a CKD or another issues, the cardiovascular issues, the total healthcare cost increases by about 20%. Why the burden is in India is the number of diabetic foot patients are increasing both in urban and rural settings, and almost 70% of amputations are performed in neuropathic feet with a secondary infection. So this is what we can potentially prevent if our physicians take a lot of enthusiasm and we advise, proper advice has been given to our patients. These are the leading numbers. In India, approximately about 1 lakh legs are amputated every year, and the numbers are still increasing. And 5% of these amputations can be prevented by doing a proper clinical examination by the available methods. And treating the diabetic foot ulcers is costly, and it accounts for 20% of total health care. So the current practice in India is due to a lot of social, religious, and economic compulsions. Many people walk barefoot, and the poverty and lack of education leads to the problems of not wearing the footwear, and there will be the foot which will be coming to the clinic will be in late presentation. It is estimated that the 90% of diabetic patients in India do not see a specialist in their lifetime. That is where the problem lies, and most of the people may resort to the use of alternative medicine prescribers. Neuropathy, as I said, most important coexisting problem, and the newly diagnosed patients, among the newly diagnosed diabetes patients with DFU, almost half of the ulcers are neuropathic, and out of this, 97% are ischemic. Infection is considered as the major cause of amputation in 80 to 90% of patients, and most of the Indian studies have shown that the people may not follow, about 65% of people will not follow the many foot care procedures, even if they know their foot are at risk. And diabetic foot and related sepsis was found to be the second most common form of infection-related mortality in hospital admitted patients. So there is a close association between the peripheral arterial disease, the PVD, with the DFU. You can see that a few years back the association was a little less, but now it is going up. If we compare with the Western prevalence, our rate is also going up. The prevalence of PVD increases with the advancing age, and which increases with the duration of the diabetes. So about 55% people will have a coexisting PVD if their age is above 80 years. And there are a lot of reasons why we have the lower reported prevalence of foot problem, maybe because of the bias or the poor designs in the study which is done in our country. This is the risk factors for the diabetic foot ulcers. I think the history of foot ulcer, those who have got a peripheral arterial disease, those who are smokers, those who have a deformity of the foot or a previous history of amputation and or an ulcer is a high risk individuals. Why the diabetic patients get a foot problem is the combination of the increased plantar pressure, the neuropathy, the PAD, the trauma, and the limited joint mobility. This is a typical male, the Indian diabetic foot. The males are more commonly affected. The average duration of diabetes is 10 to 12 years. Majority have a higher degree of neuropathy. The common precipitating factors are especially the lack of footwear or irregular foot care. And according to the Wagner's classification, it is grade 2 or grade 3. The mean heal timing was about 44 days. You can see that the recurrence of infection is considered to be about 53%. I think it is a 20-year-old study by Dr. Vijay Vishwanath, but still the recurrence rate is very high in diabetic foot patients. The reason is combination of immunopathy, vasculopathy, and neuropathy. And why still the diabetic foot is a major problem is the studies have shown that less than 20% of diabetic patients are regularly given foot examination by primary care physicians. So we also have to pull up our socks. Any patients comes to our clinic, we should insist for a removal of shoes and socks and see his pay 30 seconds for his foot examination. It put a lot of economic burden on our patients because of long stay at the hospital, and the treatment cost also goes up. This is about 10 years back data. But the treatment cost is going up nowadays. And it is a treatment of simple or even a complex DFU. Complex DFU makes a 5.7 years of average annual income, and most of the diabetic foot ulcers requires a holistic and rigorous approach. And it says that the prevention is the most effective than cure in management of diabetic foot ulcers. If any one of you think that this is the best way of treating diabetic foot or a successful way of treating diabetic foot, then you are not correct, because you have to save the foot in diabetes, because the BK amputation requires a more 40% calorie consumption, and 5-year mortality amputation is 70% in diabetes, and contralateral limb amputation rate is 50% in 5 years after an amputation of patient with diabetes. So are the diabetic foot infections in India is different from West? Yes, definitely, because in India, more often because of the wounds are caused by the persons wearing barefoot or not using the protective footwear, poor hygiene. Most of the wounds will be infested with the maggot, and there will be a coexisting association of CKD, smoking, and peripheral arterial diseases. It makes a lot of problem. But at least if you can do a sharp debridement in the peripheral clinic, preferably in a single setting, should be performed, and appropriate tissue specimen should be collected, and we can still do a better service in the resource constrained settings. An initial empirical antibiotic should be chosen in a primary based on infection severity and based on the local availability of the antibiotic susceptibility. And once you get the culture and sensitivity, you can go for a definite antimicrobial therapy. And the initial antibiotic choice, this is the Government of India data, it says it include an active gram-positive coverage at least, and it should be for minimum 7 to 10 days. Basically, the predominant organism is a gram-negative. In studies have shown that in India it is Pseudomonas and followed by E. coli. But the cost of the therapy is very important factor in our country. So wherever possible, after the initial few days of IV therapy, we have to switch over to the oral therapy. We have to consider the high oral bioavailable drugs like fluoroquinolones, clindamycin, and the linezolid doxycycline is very excellent. But you have to be very careful when using rifampicin and linezolid, because linezolid is a research drug for MRSA and rifampicin is for tuberculosis. Clindamycin is a good bio-oral available drugs, and a lot of resistance are reporting in our country. We have to think about the renal status of the patient, and it needs a significant antibiotic dose modification in that kind of patients based on the bioavailability and pharmacokinetics of the molecule we are using. In our setup, preferably for severe or moderate infections, we can use a parenteral therapy as soon as possible. From the parenteral therapy, once the infection gets stabilized, we should switch over to an oral therapy. And there is a problem that people are using what you call the indigenous method of treatment and home and herbal remedies. So we have to educate the patient for a treatment from a specialist. And because we have an acute shortage of trained personnel, and the studies from India shows that predominantly neuropathic ulcers is more than the neuroischemic ulcers. And it is seen that gram-positive infection accounts for 1/3 of all diabetic foot infections, but they are mild ones. But the MRSA is gaining importance nowadays, because now it is somewhere around 10% of cases are because of MRSA. And these are the 6 main important interventions, starting from the gold standard offloading to the debridement, the modern treatment, the appropriate use of antibiotics, the revascularization, the hyperbaric oxygen therapy, negative wound pressure therapy. A lot of new things are coming. In Indian setup, the application of TCC is difficult because maybe not appropriate for the infected wounds, and it is not always easy that patient will come for a review to us and we can see the wound. But the gold standard is TCC. The limitations are our country, the availability of culture and sensitivity, and the imaging like X-ray, and the local susceptibility of antibiotic sensitivity is also not available. That's what Pseudomonas is consistently shown to be the most common organisms, followed by E. coli, and most of the Pseudomonas are resistant to quinolones. And we have to follow the IDSA guideline. It says that initial antibiotic choice should be an active agent against gram-positive cocaine, and special attention to be given for MRSA in a high-risk patients. So how to overcome the barriers of management in our countries? We need a sensible pair of hands and eyes. This is there in our culture, the feet and footwear in our culture. So we touch the feet of the patient. You look at for a simple ulcers, and you treat at the initial stages and promote the patient to wear footwear, proper footwear. Look for the limited joint mobility at the creto. If there is a limitation of movement, at least palpate the peripheral pulses, dorsalis pedis and anterior tibial, and 30-second foot examination. Look for any previous foot issues, palpable pulses, protective sensation is intact or there or not. Look for any significant foot deformity, and never ignore or never miss this sort of trivial foot lesions, which is very common in our patients. If you get this sort of an ulcer, if possible small ulcer, it is a big problem. Put a probe and see whether it is there is an osteomyelitis. If the patient is affordable, do an MRI. Look for PAD, intermittent claudication, critical limb ischemia signs. Look for that. Charcot. Please never miss. If there is a unilateral limb swelling with redness, you use the thermometer, the non-touch thermometer, the new generation thermometer. You compare the temperature. If the temperature difference is more than 2 to 3 degrees Celsius with the normal limb, never restrict your diagnosis of cellulitis. Always think about a possibility of Charcot joint. It's very difficult situation. This is a classification of IDSA. I'm not going to the details of this. I think the next speaker will see. This is one study which has been conducted in management of clinical setup in Indian patients, and it says that 79.4% doctors are performing comprehensive clinical examination with the 58% utilize the optimal preventive and therapeutic care strategies. This is done by the A.K. Dasar and Sharath Pense. And here this has shown that 20% doctors has reported a clinical cure rate of more than 80% with the minimum available modalities of treatment. And these are the comorbidities which is associated with these patients. Leading the chart is neuropathy followed by PAD. Then now with the renal disease is catching up with the POD. So you have to rule out all these factors whenever you come across diabetic foot patients. And around 76% of doctors have used various tools to screen for the diagnosis of diabetic foot. And most of the doctors were able to provide diabetic foot education. That is the most important aspect in your clinic, followed by pamphlets or videos and patients in the waiting area. And this has done a beautiful outcome in the management of diabetic foot. If you refer, these are the refer criteria: new foot ulceration with infection, suspected Charcot, suspected lower limb osteomyelitis. It is better to refer to a diabetic foot center, which is entirely dedicated for the patients. These are a few patients. I think I'm reaching time. So these are heel pad gangrene. I think you can see the beautiful ulcer has been healed. This is a very difficult case. We had given 30 sessions of life. This has been posted for a big amputation from this. I think it has been beautifully healed, and the patient is for the last 2 years. I think to conclude, appropriate approach to diabetic foot management varies in primary and secondary healthcare. You need a unified approach for the foot care management achieved by the diabetic foot education program, and by the diabetic foot education program will give you the better result, and this may reduce the foot amputation rate and decrease the burden of diabetic foot throughout India. Once again, thanks for the ADC team. Thank you all. Thank you. Have a nice day. Jai Hind. Any questions, I'll be happy to answer. Thank you.
Thank you for very lucid presentation. It was really elaborative. I have one query. India being the phenotype, Indian phenotype is just very prone to diabetes, and we have a lot more pre-diabetic patients. So neuropathic foot is much more present in pre-diabetics as well. So
yes,
shall we start pre-diabetic patients for screening for diabetic foot, or neuropathy in the further diabetic patients?
No, I think you have to even at the first presentation, it is better to evaluate the patient for any changes in the neuropathy, because if you look at, when I have seen in few of my patients, even when I do the urine microalbumin at the first visit, it has been increased. So the microvascular damage may happen earlier. So it is better that especially in the new onset diabetes, I think it is better to assess, even in a pre-diabetic state. I think it is better to assess the complications of neuropathy. And from the day one itself, it is better to make it as a habit that along with HbA1 should do a urine microalbumin. And don't forget that you must do a retinal examination baseline along with the foot examination.
Thank you very much. So moving on,
Thank
next
you, Ajit.
speaker.
Wonderful talk.
Yeah, thanks, Arvind.
Yes.
Over to Dr. Manish. Yeah.
We have a next dynamic speaker who is one of the leading in IPA as well, Indian Podiatry Association, Dr. Pawan Beliali, a good friend of mine. He has been completed MBBS from MS Ramaiah Medical College, Bangalore. He's a DNB orthopedic. He is MCH orthopedics, MNMS, as well as working as ankle foot surgeon at Karnataka Institute of Endocrinology and Research, Bangalore. Presently heading the Department of Podiatry at KIER. Presently holding a post of Treasurer of Indian Podiatry Association Karnataka Chapter. Member Secretary for Independent Ethics Committee, KIER. Past Secretary Research Society of Study of Diabetes in India, Karnataka Chapter, and special interest in diabetic food, deformity corrections, lower limb, pediatric orthopedics, as well as GATE study. So over to you, Dr. Pawan.
Thank you. Thank you, everyone. Can you hear me?
Yeah.
First of all, I would like to congratulate Dr. Arvind sir as well as his team for getting all these busy practitioners in one place on a Sunday. So that itself requires a big motivation. So a big congratulations to your team, Dr. Arvinda, because I know what you have gone through in the last 15 days. So it's a big task, really, and really a task well done. So moving on, I'll be sharing my screen now. I hope everyone can see the screen.
Yeah.
So good evening, everyone. I bring greetings from Karnataka Institute of Endocrinology and Research. I am a diabetic foot surgeon taking care of the Department of Podiatry there. Yes, Dr. Ajit has made my work very easy because he has covered most of the stuff. So it only is appropriate that I stick to the topic that was given to me, the high risk feet. Yes, we have worshipped feet in India for since ages, but still the Indian feet keep suffering. And why is it happening? We will just come to know. So today's agenda, I'll just talk of causes of a high risk foot. What is the required assessment? Okay. Is it moving now?
Make it presentation mode.
Now?
Not that.
Put it in slideshow.
It's in slideshow. It's in slide. I'll stop the share. Okay. So I'll stick to this. I'm sorry for this, some technical glitches. So yes, Dr. Ajit has already touched upon this, but Dr. Ajit was talking about a 10-year-old data and we have the recent data. So now it is very difficult because we have almost one limb being lost every 20 seconds, but that's not the case anymore. We have come down to almost like 16 to 14 seconds that a limb is being lost in India. And it takes almost 1.5 lakh rupees for managing a simple diabetic foot ulcer in India. So that is how bad this burden is for us. And when we see the mortality rates, the ischemic diabetic foot ulcer is just behind pancreatic, lung cancer, and peripheral arterial disease. The 5-year survival rate of is only around 50% after a below knee amputation. So this was already touched upon by Dr. Ajit, so I'll not be going into this. So what is, why are we talking of this risk? Why are we talking of high risk feet? So as we all said, as Dr. Ajit was also very clear that yes, in these feet, the chances of complications, future complications and an amputation are very high. So what are we going to look at when we are trying to detect high risk feet? The history, prior amputation of a foot ulcer, and look for any peripheral arterial disease. And when we are examining, look for the insensitivity, foot deformities, absent pulses. We'll be talking about each of them. Now, this is very interesting. This was in 1999 that one of the articles came about as to what are the causal pathways for foot ulcers, meaning to say that what are the reasons for these foot ulcers which usually take place. So they found out that 78% of the time it is a neuropathy, 79% it is added up by minor trauma. 63% of the times it is deformity, which is already there, but no one checked about the behavioral practices. Now, this is one place where India is lacking, because when it comes to India, the behavioral practices cause most of the problems, most of these diabetic foot ulcers. So again, these factors Dr. Ajit has touched upon, so I'll not be going into them. This is very important. This is based on Bolton's classification, which he gave to us as to how frequently you should screen a diabetic foot. And this is the stratification for ulcer risk. So when you see a diabetic patient, grade 0, that means all normal. He does not have any neuropathy. He or she does not have any neuropathy, no deformities. So even then, that person has at least 1.7% chance of developing a foot ulcer in the next year. And believe it or not, 66% of the time, the patients who are coming to your diabetic clinics will fall under this grade 0. But these are not the people that we are worried about. But yes, this is the place that we have to act. We have to screen them. This is the first time that the patient is available. So whatever screening for the diabetic foot you do, they form the baseline investigations for you. The next being loss of protective sensation. As you see, 17 to 30% of your patients will fall under this. The high risk categories are the grade 2 and the grade 3. The grade 2 are where they already have LOPS, that is loss of protective sensation, with a deformity or absent pedal pulses. They are 10% of your office patients who have a 6.3% risk of developing a diabetic foot ulcer. The last one being the prior amputations. That means patients who have already had an amputation. So these are the ones who will almost end up with 28% chances of diabetic foot ulcers, although they form only 7% of your office patients. But please make sure that they are looked at properly. So what are we looking at? As we talked about, check for neuropathy, peripheral arterial disease, foot pressure mapping. Yes, this is something which many of the institutes have started doing, many of the diabetic foot screening centers, but many clinicians, paramedical staff still lack the knowledge as to how to read this. So this is a very simple technique to go about it. Probably sometime later, Dr. Arvind can give me time to talk to you about this also. Check the footwear. Yes, again, very important. Look for structural abnormalities in all these places. These are the classical deformities that most of the diabetic foot patients will come to you with. The clawing of toes, hallux valgus, pes planus, cavus. Testing for sensation, as we all know, 128 hertz tuning fork with Symes monofilament. But again, we have technology like NeuroTouch, which is one handheld device which helps you screen these patients quickly. So this is what we do at the podiatry lab at KIER. And then this is very important. Now, when the patient is waiting for his diabetic foot evaluation outside, as Dr. Ajit was telling, please make sure that he's educated. You can give him simple pamphlets, put up a television set, put up an animation, tell them what is to be done, what is not to be done, give them a modified neuropathy disability score. That means a simple paramedical staff can do all these things for you. And if the score is more than 6, make sure that this patient is being taken care well and is called more frequently to your place. So this is the eMed platform which we use. I'm sorry, the video will not run in this mode. So this is the stress distribution. It shows us in the different phases. So again, it helps us in not only detecting high risk feet, but also offloading the footwear. So results tabulation, as you can see, this is a simple person who has loss of protective sensations. And as you can make out, he has something called as medial loading. That means the area below the first metatarsophalangeal joint is taking a lot of pressure. And this is the point when the patient still does not have developed any callosities or wounds. You come down and change his footwear so that this extra pressure can be redistributed in that region. So again, results, what we are seeing here, this is for the right foot. Right foot seems mostly normal. And coming to the peripheral arterial index, peripheral arterial disease, you have ankle brachial index and the toe brachial index, which we can use. Anything below 0.9. I know these take some time, but believe me, it is really worth it if you are able to detect one high risk foot and tell them to take care rather than that same patient coming back to you with a wound or a callosity. So prevention of amputation using this stratified risk approach. How can it be done? The cornerstones of prevention still remain: regular inspection and examination of feet and footwear. A simple way is ask the patient to leave their footwear and socks outside your OPD and come in, so that at least you can have a look at their feet. And after you have finished everything, just place your hand on the dorsalis pedis and see whether the dorsalis pedis is felt or not. Identification of high risk foot, education of people and their relatives, appropriate footwear all the time, and rapid treatment of all foot problems. Patient education, very, very important. The patient should take active role in their care. It's not that the doctor is or the paramedical staff is doing everything. Decrease the chances of recurrence by telling them about foot hygiene, daily inspection, proper footwear, and prompt treatment of new lesions, as we'll be seeing. Elective surgery to correct structural deformities before the ulcerations occur. So team care. Why are we talking about team care so much? Because team care really helps in decreasing the amputation rates in diabetic foot. So what is the team? What does it consist of? A podiatrist, a vascular surgeon, nurse, infectious disease specialist, general surgeon, physical therapy. I know getting all these people in one place, especially in a setup like India, is difficult. But yes, at least 4 or 5 of them can form up a team, giving rise to a proper team care approach to a diabetic foot. So role of the nurse, we have to understand that the paramedical staff training is equally important to detect high risk feet, because it is usually the nurse who will tell you that the patient has some issues in the foot. So risk stratified management, as I told you, grade 0 and 1 come under low risk, and high risk will be grade 2 and 3. So basic foot care concepts, foot protective behaviors, basic footwear education, and barriers to foot care remain common to both. So low risk, for low risk patients, grade 0 and 1, do an annual comprehensive foot examination questionnaire, which is completed by the patient. Give them a modified neuropathic symptom score or a DNS score for them to fill up. Examination, self-management and footwear education, brief counseling or a written handout should do. Coming to high risk, annual comprehensive foot examination is a must. But again, if the patient is grade 3 or grade 2, call them more frequently. Inspect feet every office visit, podiatric care as needed, intensive patient education. Believe me, when you tell the patient 10 points, by the time he is going out of your room, he will probably be remembering only 2 or 3. So you have to talk to them more and more often as and when they come to you about this education. Detect and manage the barriers to foot care and therapeutic footwear as needed. So nursing tasks in a high risk foot are equally important. Yes, this is one of the things that we have tried in our patients, where when we place high risk feet stickers on patients who are detected to be high risk for developing diabetic foot ulcers. Always remove patient shoes and socks when the patient comes into your OPD. Determine if patient can reach or see the sole, because invariably we doctors will tell them that you are not taking care, you are not doing this, not understanding that most of these patients are obese. Most of these patients do not have a proper eyesight. So they will definitely require some help. And that is why it is important to ask their relatives to come in, tell them what is to be done. Consider training to perform monofilament examination, provide patient education forms. So podiatric care is again very important. Provide nail and skin cares, assess the footwear needs, and visit frequency is not evidence-based. So this is one thing that we have seen, that when we tell so much about high-risk feet, most of my friends say that we will call them once every 15 days or once every 20 days and make sure that the foot wounds do not happen. The studies have shown that visit frequency will not decrease chances of a diabetic foot ulcer. In fact, it's the education, the proper education that you are giving to the patient, that is going to decrease the chances of a diabetic foot ulcer in the patient. So reinforce frequently, because of the low retention that most of the patients will have. Patient demonstrates self-care. This is one of the best ways of seeing how much the patient has understood. If a patient demonstrates as to how he is able to take care of his diabetic feet, most of the stuff will be done. There is evidence that this may reduce foot ulceration and amputation rates. So daily foot inspection, these are the basic foot care concepts that all diabetic foot patients should be spoken to. Patient able to recognize, report some of the problems, tell them what is to be done. Foot protective behaviors, avoid temperature extremes, no walking barefoot, inspect shoes for foreign bodies, and optimal footwear at all times. So tell them what they can avoid, what they can favor. I have given a list. but you can put a list of your own depending on what your patients, most of your patients are already using. So barriers to foot care remain depression, alcoholism, social isolation. I have seen many patients who have been kicked out of their home because they have developed wounds, smelly wounds, wounds with maggots, which the patient's attenders are not ready to take care of. So this is something which we can overcome only with education of the patient relatives and proper foot care. Financial barriers, yes, this is something which is out of our hands, but yes, we can try to make it available, accessible as easily as possible, making this also a barrier which can be overcome. Footwear goals: protect feet at all time, reduce plantar pressure, shock and shear, accommodate, stabilize, and support deformities. It's not, many of your patients will not actually agree to a surgical offloading, but at least give them proper footwear suitable for occupation, home, and leisures. So this was the stages of ulcer development. As you see, starts with a callus formation, becomes a subcutaneous hemorrhage. It is followed by breakdown of skin, gets to infection with osteomyelitis. So these are all the pre-ulcerative lesions that we are talking about, which can easily be identified and can be referred so that something can be done for them. At least give a proper footwear, talk to the patients, tell them that they might require surgeries, or if they are ready, a prophylactic surgery can be done to correct these deformities and make sure that they don't end up with diabetic foot ulcers. All these callosities, xerosis can be scraped, proper footwear, offloading can be done. As you see, these are the claw toes. Invariably, tips of those claw toes will have callosities. Simple scraping techniques can really take care of these. So I don't know whether I'll be able to show this because this was one patient. Is the slideshow working now? Dr. Manish?
It's not that much working.
It's still not showing?
Not showing.
Okay, I'm sorry about that. But then, yes, this was one patient who had come to us with a very, very small wound. And we waited and we came to know that it was because the second metatarsal was showing some signs of septic arthritis, the second metatarsophalangeal joint. Even though it was a small wound, we opened it up. We removed that piece of the metatarsal head, and patient went back with a completely healed wound. But remember that this is a high-risk foot now. So this high-risk foot will require proper footwear, regular reinforcement about foot care, and calling these patients again to see how these feet are doing. Coming to my conclusion, screening is simple. Screening and team care reduce diabetic foot ulcers and amputations, which has been shown. There is a lot of evidence to say this. The human and financial consequences of diabetic foot are devastating, which can be completely prevented. Action is possible and affordable. Everyone keeps thinking that, oh, we require a EMED platform, we require this. You do not require anything to screen a diabetic foot. Amputations are preventable. Even in low resource settings like Bangladesh, forget India, like Bangladesh, Tanzania, they are doing a world of difference in trying to detect high-risk feet. So being the 5th largest economy now, India has its hands full of diabetic feet cases, and we are looking at a tsunami of these diabetic foot cases in the future. So we have to really pull up our socks, as Dr. Ajit was saying. Even in low resource settings, foot care can substantially reduce ulceration and amputations. And last but not the least, all feet should last a lifetime. Thank you. I'll be more than happy to take questions, if any.
Thank you, Dr. Pawan. It was really excellent presentation as usual. Anybody have any questions? Dr. Raka, I can see you. Yes. Over to Dr. Arvinda, sir.
So Dr. APS Suri is on the way. In between, from Agra to Delhi is coming. He is having network issue. He'll join in 15-20 minutes. So what we can do is we can go to the next session. So whenever he comes in, Dr. Manish will inform me. At that time, we can have his talk. Is that okay?
Yes.
Yes, absolutely.
Yeah. Thanks on behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit. I wholeheartedly thank Dr. Manish Jangam and Dr. Ajit Kumar and Dr. Bele Ali Pawan for excellent presentation and discussion. Thanks for your valuable time and being a part of our conference. Thank you.
Thank you. Thank you, guys. Thank you so much.
Thank
you.
you all.
You are
Thank you.
really Thalaiva. You are really Thalaiva.
We'll follow your order, Thalaiva.
Now both are saying the same word. Rana, you can add some poem. Fantastic.
We'll move on to the next session.
Hi, Ashwin.
We have new last session of the day. Actually, we conclude with this, with the novel approaches in diabetes. To chair this session, we have Dr. Kashinath Dikshit from Bangalore and Dr. Ashwin Mukundan from Kerala. So Kashinath Dikshit is the MD consultant diabetologist at the Krupa Diabetes Center. He is the CEO and diabetologist at Gauri Karanga Diabetes Center, Bangalore. He has 35 years of clinical practice. Dr. Ashwin Mukundan is the gold medalist of renal medicine. He is a PG diploma in diabetes and renal management, PG diploma in advanced diabetes care. We have four sessions we have lined up. Dr. Nisha Nigel from Canada. She will be talking on twin creatine. Dr. Balaji will be talking on once weekly insulin. The Don Raka will be speaking on an update about insulin pumps. And Dr. Deepak Jumani on erectile dysfunction in diabetes. All this with the new novel approaches. Over to the chairperson for the further proceeding, please.
Thank you, Arvind. I think I'm audible.
Yeah.
Should I introduce Dr. Nisha Nagil?
Yeah, please.
Yeah. To go through this entire page, it will take 5 minutes. I don't want to waste time. Dr. Nisha Nigel is endocrinologist. She is associate professor of North Ontario School of Medicine. So without wasting my time, I request Dr. Nisha to go ahead with her lecture. We are very keen to listen to you. Over to Dr. Nisha. Hello? Yeah.
Not able to listen to you, Dr. Nisha.
Please unmute.
Thalaiva, how you have fixed your smile till end of the day?
Hi, Nisha. I can
Hi.
see your chat box message.
Yes, you can go ahead. If you are unmute, we should be able to listen to you, no? Dr. Nisha?
Maybe some network. Dr. Balaji, you are there?
Yeah, I think Balaji's name we are seeing.
Yeah, you can go ahead. Nisha will join.
Oh, yeah. Then I request Dr. Balaji to talk about once a week. Is it insulin or something else?
Insulin.
Dr. Balaji, insulin. Once a week insulin. Yeah. And he has done his biodata is also quite long. But he has got a best clinic, I can say, among the Apollo Sagar, Pan India. Is MD, PG diploma in diabetology, lot of qualifications. So without wasting much time, with lot of thanks to Dr. Arvind, I request Dr. Balaji, Jagan Mohan to talk about this once a week. What is this once a week? Is it an injection? Is it an insulin or whatever it is? Yeah. Go ahead, Balaji. Yeah.
Before that, Nisha, you take your 5-10 minutes, no problem. You can come back. Dr. Balaji will be speaking. You sort out the network issue. Next talk, you will be talking. Is that okay, Nisha? Yeah. Okay, Balaji.
Yeah. So, am I audible clearly?
Yeah, audible.
Okay, my slides are also visible, right?
Yeah.
Okay.
Go for slide projection. Yeah.
PowerPoint.
Yeah.
PowerPoint. Yeah.
Okay, so it's visible in full screen, right?
Not that.
I think this particular pattern, it is not coming up. If the slides are moving, you can present in this pattern only, Balaji.
Okay, my slides are moving. Or the other option is I have sent it to Neelam. So can she share the slides then?
This we can see, no problem. We can present. Go to next slide.
You make it slideshow. It's visible only.
Okay, can you see it now?
Yeah. You can present, no problem.
Go ahead.
Yeah. Okay, so thank you, Dr. Jagdish, Arvind Jagdish, my very good friend. Thank you, Chairpersons, Dr. Kashinath sir, and also the entire team of ADC and RX events. So this is a very unique topic that has been given to me. Although this once weekly insulin is currently not available in India and globally, it's only in the research phase. There are a lot of trials that are being completed, both phase 2 as well as phase 3. But my job here is to show some data about how this once weekly insulin can be very useful. Once it has been launched in the market, it can benefit millions of type 1 and type 2 diabetic patients. So this is the outline of my presentation. So first of all, I'll talk about what is the requirement for this once weekly basal insulin. Then I'll try to present a little bit on the PK/PD data of this once weekly insulin and how we can redefine current diabetes management by administration of this once weekly insulin. And then I'll try to summarize my talk. So there is a need. If you see, there is a demand in the market. What we understand is that despite all the available anti-diabetic treatments, the newer insulins that are there, still only 1/3 of patients are actually adherent to the insulin. Now, if you see, this is a multinational study which shows only 33% of the patients are compliant to the insulin that is prescribed to them. And in another study that was done in UK, here the numbers are much lower. Only 29% of them are compliant or adherent to the insulin that is being prescribed to them. And we all understand the fact that if patients are not compliant to insulin, then automatically that would translate to poor glycemic control, and the healthcare cost and burden would be that much higher. So here it is clearly seen that even in patients who are adherent to insulin, so if they're taking insulin at least for 80% of time, still the A1C target achieved is around 8.1%. And if they're poorly adherent, which means almost less than 80% of the times they're taking insulin, then the HbA1c is slightly higher at around 8.7%. And the direct cost that is associated with non-compliance to insulin is roughly around $17,000. Even in patients who are adherent, the cost of insulin therapy is significantly higher. Now, there has been a paradigm shift as far as the recent innovation is concerned in order to improve compliance for patients. And now that is applicable for the anti-diabetic oral agents as well as injectables. And like I've already mentioned, that poor adherence to the prescribed treatment will not only lead to worsening of glycemic control, but also the development of micro and macrovascular complications. It can increase hospitalization rates for a diabetic ketoacidosis and HHS and even other complications, thereby increasing the healthcare costs. So there have been some strategies to improve the adherence to the treatment that is given. And I will focus on this first bullet point, that is how we can reduce the dosage frequency of the prescribed medication, and that is insulin. But there are also different delivery systems or formulations of insulin, for example, the oral or buccal formulation. You also have the transdermal patches. The intranasal or inhaled insulin Exubra was not very successful, but there are different insulin delivery systems that are also being tried in the research pipeline, and also insulins with better tolerability profiles, so lesser hypoglycemia and weight gain. And overall, the medication that is prescribed should enhance the decision making between the treating physician and the patient. Now, what are the recognized features or attributes to once weekly medications, whether oral or injectable? Now, talking about injectable, it will increase the compliance, the adherence will be better, there is an overall improvement in the quality of life. The patient feels an overall overwhelming sense of treatment satisfaction, and even patients who are elderly, who require medical assistance, it is much easier if there are, regimens that could be better adhered like these once weekly ones. So you can clearly see here on this calendar, you give a shot once a week, every Sunday. So that translates to roughly around 4 injections in a month. Now coming to the PK/PD profile of insulins. Before that, let me just give you a snapshot or a bird's eye view of all the once weekly insulins that are currently in development. Now there is an insulin once weekly from Eli Lilly called the BIF LY 329509590. Now this is currently in phase 3, which means more likely it is going to come into the market, and it has been tried in several trials for both type 1 and type 2 diabetic patients. The structural feature here is the FC fusion protein change that allows a prolonged half-life for this insulin. I will focus on insulin degludec, which is being developed by Novo Nordisk, currently in phase 3. It will get approved for both type 1 and type 2. And the structural change which provides a long half-life is basically an acylation with the icosanoic acid, which is added as a spacer to the B chain. And I will come to that and how it allows for a long half-life. Now, there are other molecules also currently in pipeline. The AP101 by Resolute is not in active development. Insumaram by Phase Bio, it has just completed phase 2A, and it's only for type 2 diabetic patients. Then there are some other molecules, AKS433 by Axton Biosciences. This is currently in preclinical development, and they might try it both in type 1 and type 2. And similar to the Lilly one, the difference is in the FC fusion protein. And also AstraZeneca preclinical stage. And there's another one by Anmi Pharma, currently in phase 1, will be tried for both type 1 and type 2. And the difference is in the FC fusion protein. Now coming to insulin icodec, which very soon will hit the markets. It's also known as Li-287. Now there are 3 amino acid substitutions that have been made in the structure of icodec. And these substitutions will basically give this molecule a stability. It will reduce the enzymatic degradation, and it will also reduce the receptor-mediated clearance, which means once it binds to the insulin receptors at the target tissues, it will stay bound for a longer period of time. Thereby, the clearance would be reduced. Now you can clearly see here 3 substitutions, 1 at the A chain and 2 at the B chain. In fact, at the B chain at the amino acid position 29, there is a removal of threonine and a spacer is added. This is that icosine fatty diacid spacer, which allows for a strong reversible binding to albumin. So this insulin is, mostly albumin bound. More than 90% is albumin bound, and also it stays bound to the receptor. Thereby, the clearance is reduced. And looking at the steady state achievement of insulin icodec. So after 4 to 6 injections, that means after 6 weeks, you can clearly see here that the steady state concentrations of insulin icodec are achieved. So you need at least 4 to 6 injections for more than 90% of patients to achieve at least 76 to 92% of steady state concentration. Now looking at the pharmacokinetic profile, it appears that there are 3 doses that can be given that were tried at least in research. So although the higher dose gives you a higher plasma concentration, but the biological half-life or the terminal half-life for all these 3 formulations appears to be the same. It's roughly around 196 hours, which is around 8 days. So the only difference is the higher plasma concentration that is achieved with the higher dose. Now, also it is seen that once steady state concentrations are achieved, that is, once you have given insulin icodec for a period of at least 6 weeks, then thereafter, for each dosing, it is seen that at day 1, the area under the curve for glucose lowering effect is slightly lower, but anywhere between day 2 to day 5 is where you get the maximal glucose lowering effect of insulin icodec, and then it starts to slightly wean off from day 5 onwards until day 7. So then that indicates that the next dose has to be given. Now talking about the pharmacodynamic action of insulin icodec, once the first injection is given, so this formulation is basically a 700 IU formulation, which means that each ml has got 700 units. And once it is injected into the subcutaneous space, the hexamers will then slowly dissociate as monomers and it will enter into the systemic circulation. Now, once it's into the systemic circulation, it is extensively bound to albumin. More than 90% is bound to albumin, and there is a depot that is formed in the systemic circulation with this albumin binding. So it's basically icodec albumin depot, which is very different from all the other insulins which form a subcutaneous depot. So from here, it will then slowly release the icodec, which will then go and bind to its receptors on target tissues, so the skeletal muscle, adipocyte, and liver. And there again, there is a reduced clearance. So there will be a strong binding here, and it will facilitate glucose uptake for a longer period of time. So this is with the first injection. Now with subsequent injections, so as you give 2 to 3 injections, and as icodec is going to reach steady state concentration, you can clearly see here that there is this strong depot that is formed between albumin and icodec in the systemic circulation. So from here again, it will be slowly released. And once it is released, the icodec that binds to the receptor as well will have a reduced clearance. So the depot, which has a strong binding, which gives it the long duration of action, and also the reduced clearance at the level of the receptor. So both of these combined together after 2 to 3 injections would translate into a longer duration of action. Now, steady state concentrations are achieved after 3 to 4 injections. Now, icodec is at its full effect. So you have the icodec albumin bound depot in the systemic circulation. So there's a slow and continuous release, which will help you to achieve an effective glucose lowering throughout the entire week. And also the reduced clearance at the target site, so at the receptor level, that will give you immediate glucose lowering and also for a longer period of time. So these are the key attributes as far as the mechanism of action is concerned. Now coming to some of the studies that have been completed with insulin icodec. Now this is a study that had compared once weekly icodec with insulin glargine U100, and you can clearly see here that after 6 months of therapy, the HbA1c reduction from a baseline of 8 to roughly around 6.6 with icodec and 6.87, so slightly better, although statistically not significant. But if you see the proportion of patients who achieved the A1C target, 72% less than 7% for icodec versus 68% with glargine, so slightly better with the once weekly insulin. And also the percentage of patients getting A1C less than 6.5, slightly higher with icodec as compared to glargine U100. Now this is another study. This is a phase 2 study where patients were already taking other basal insulins like NPH or Detinib, and they were randomized to receive either glargine U100 or insulin icodec in 2 strengths. So the first strength, they've given icodec as a loading dose. So they're giving 2 doses at one time. So that becomes a loading dose. And then there is another formulation that is given as the normal injection once weekly. So you can clearly see here in the results here that for the loading dose, the time and range is slightly better as compared to the no loading dose or even the insulin glargine U100 that was given. And also the time above range and below range was significantly lesser with the icodec loading dose as compared to the non-loading dose and the glargine U100. On the right-hand corner, you can see the HbA1c reduction again. For both the icodec formulations, it's slightly better as compared to glargine U100, not only for A1C, but also for the fasting blood sugars. So they've concluded here that when you're switching to another basal insulin, whether it is glargine U100 or icodec, both of them provide good efficacious control, but the loading dose icodec is slightly better, giving you a higher time and range as compared to the non-loading dose or the glargine U100. There is another study, and this was done in type 2 diabetic patients who were previously on OHAs and they had failed to achieve the desired glycemic targets. So they were again started with either glargine U100 or basal insulin icodec once weekly. The graph is not very clear here, but they're showing that as far as the efficacy is concerned, the proportion of patients achieving the HbA1c target, and also the 7-point SNBG profile, is similar between glargine U100 and insulin icodec. But if you see the entire dose requirement, it was slightly higher for glargine as compared to insulin icodec for a period of at least 6 months. Coming to the safety profile, hypoglycemia level 2 and 3 with insulin icodec in all insulin naive patients, type 2 diabetic patients, you can see that compared to glargine U100, the level 2 and 3 of hypoglycemia is exactly the same, identical and non-inferior compared to glargine U100. The last few slides. Now, this is newer data that is released in ADA, mainly with icodec. So they've compared different formulations of icodec, and they've also tried to study the hypoglycemic response with multiple dosing of icodec given in type 2 diabetic patients, and they've seen that there is no risk of hypoglycemia. There are other once weekly insulins, and they also have been presented at ADA 2022 recently, and they have also been tried comparing to insulin degludec or in Asian patients like Japanese patients. So this is my last slide. I'd like to summarize that if we have these once weekly injections, okay, then the adherence will be better. There will be more number of patients achieving the glycemic goals. And insulin icodec is a novel basal insulin analog that will address these issues of non-compliance. So the data of efficacy and safety definitely looks reassuring. Thank you for a patient hearing. Over to you, Chairperson.
Yeah. Thank you, Dr. Balaji, for this excellent insight. Most of us, we don't know there will be once a week insulin. Once a week means we think of, what is that? GLP-1. Once a week means immediately it comes to our mind once a week. It's an excellent this deck is an excellent molecule. We are all eagerly waiting for that. And dosage, is it something like 200, 300 units per week? That we don't know. We have to wait and see. But what I want to say is, once a week, we prescribe vitamin D. Most of the patients, about 99% of the patients, they take that. They won't. Unlike once a day, the statins and all they avoid. But once a week is an excellent criteria. Hope it will come to the market so early. Thank you. If there are any questions from the audience or Dr. Arvind or
so just one point I wanted to make, sir. Since you asked about the dosing, so if they're already on another basal insulin, let's say they're taking 10 units per day, then we have to add the dose for the entire week. So that comes to 70 units. 70 units will be given as one shot for that entire 1 week. That is the dosing of insulin icodec.
Insulin. Is it used through pen-like device or multiple weeks they can take? I don't know.
We don't
because
know.
It's a new, no? Yeah. Okay, thank you. Arvind, what should we do next?
Yeah, thank you, Balaji. That was an excellent talk. Thank you so much. And Dr. Nisha is ready now. We can go to her.
Yeah. Madam, you are ready?
One second, voice problem is there, Dr. Nisha? No, we can't hear you. Any network issue or the connectivity issues?
If you have attached earphones, please remove earphones.
Yeah, that might be the case. Earphone or the sound audio system.
That volume button will be there. That should be increased if it is at lower volume.
Yeah. See the volume button.
Can you hear me now?
Yeah, exactly.
Yeah. That's good. So I'm using another browser. Okay, so I'll start. Sorry about that.
Madam, about 20 minutes back, I have introduced you already. You can go ahead. You can go ahead. Yeah. Okay.
Thank you very much for the opportunity. I'll try and share my screen. Are you able to see my slides?
Yeah,
Yes,
PowerPoint mode.
Yes, madam.
Okay, excellent. So I'm going to, these are my disclosures, and I'm going to be speaking about tirzepatide, the latest GLP-GIP agonist. I do have some data slides, but I'll just touch up on the basic important aspects. Okay, so this is a multifunctional peptide, 39 amino acid linear peptide, and has a mean half-life of 5 days, so that we are using it as once a week, similar to dulaglutide and semaglutide, which are popular options for diabetes management. Compared to the GLP-1, there are some extra mechanisms that more profound improvement in insulin sensitivity and change in lipid accumulation. These are the other, so I'm not going to the details. So there are direct and indirect actions, and by now we are all familiar with the GLP-1 action, and this is the GIP receptor agonism. So again, appetite is suppressed, increased insulin, and suppression of glucose. And in phase 3 trials, we are seeing substantial reduction in HbA1c and also body weight. With insulin, you see that patients gain weight, same with sulfonylurea, and causing hypoglycemia. Here, no hypoglycemia and reduction in A1c and body weight. So that's possibly leading to potential remission of diabetes as well. And these are the various clinical trials in this series, SURPASS 1 to 5. SURPASS 1 was against placebo monotherapy, 2 with comparative with semaglutide, which is Ozempic, then against degludec and glargine basal insulins, and again, other titration modes. So most of the trial endpoints were studied at week 40 and 52. And and proportionately, we are seeing more patients achieving A1C reduction up to 90%, 80 to 90% of patients achieving A1C reduction, which is very remarkable. And we are seeing that the results are independent of the duration of diabetes. Most of the trial patients had duration for up to 8 to 9 years. So we are seeing that in even long-standing diabetes, you see some kind of remission or A1C lowering and weight loss, which is encouraging. And again, there is good correlation between body weight and HbA1c improvement. So this is what we are seeing in the trials. And again, benefits are seen even with 5 milligram dose. The maximum dose they have studied is 15 milligram as of now. And then the benefits are regardless of background diabetic medications as well. So we can down titrate a lot of these medications. And a mean body weight, even in week 26, you are seeing good amount of weight loss early on. This is compared to dulaglutide, which is Trulicity. So you are seeing almost double weight loss, even with a smaller dose of the medication, and of course 2.4% reduction at A1C reduction, and up to 20-pound weight loss. Again, compared to Trulicity, double weight loss, even with the smallest possible dose. This is 1 milligram, and so that's quite remarkable. And of course, as expected, the GI side effects are more with this group of medication. Even though the GI side effects are more, and we are not seeing a lot of people discontinuing, of course, with the highest dose, we are seeing 20% discontinuation, but smaller doses up to 9% due to side effects. And again, one remarkable aspect, what you're seeing is that you are seeing A1C lowering within 4 weeks of starting the medication. So this is quite remarkable. So immediate HbA1C lowering. So if their patient is on insulin, they have to down titrate the dose pretty rapidly. So that's otherwise there is risk of hypoglycemia. So you're seeing early on and then continued benefits all the way up to 40 weeks, and there's sustainability of weight loss benefits. There's no tachyphylaxis sort of effect. And again, even A1C reduction is early on. And we've also seen data looking at pre-lunch, pre-meal, post-meal readings, and they are also better compared to placebo, all even fasting blood glucose, and also pre and post-meal readings are better compared to placebo. Similarly, continued benefits at 40 weeks. You're seeing continuous benefit, prolonged benefit. And as I said, percentage change in body weight starts at 4 weeks. And obviously, when the dose is higher, patients tend to lose more weight, as seen here. BMI is also declining as early as 4 to 8 weeks. You're seeing a downward trend coming down from, let's say, 33 to 28. So significant BMI reduction, improvement in waist circumference from baseline to 96 centimeter, which is also very encouraging. And again, fasting insulin resistance parameters, there is significant improvement, and also lipid parameters improvement in HDL and lowering of LDL, which is excellent, and significant triglyceride lowering up to 20% and 12% LDL lowering. And these are the common adverse effects similar to GLP-1 molecules: nausea, diarrhea, appetite suppression, etc. No serious adverse effects noted, and hypoglycemia very negligible, and no severe hypoglycemia. Interestingly, no increased risk of pancreatitis or pancreatic cancer, but mind you, patients with prior pancreatitis were excluded from these trials. And no cholelithiasis significantly reported, no hypersensitivity, no significant reactions. And we are also concerned about medullary thyroid carcinoma as a risk. So again, no increased risk of medullary thyroid carcinoma or no worsening of emergent diabetic retinopathy noted. And there was improvement in liver enzymes and also no antibody mediated reactions or no anti-drug antibody related effects noted. So these are all encouraging, and no relevant change in mean calcitonin concentration. Again, the nausea is also self-limiting. The nausea should improve by 6 months or so, like gradually it comes down. So proportionately less patients stop the medication if they continue beyond. And there was some concern about palpitation, etc. So we are not seeing that as a problem, as a significant issue. So there is improvement in blood pressure as well as expected, partly related to weight loss. And there is improvement in liver enzymes. So we are seeing reduction in A1C, fasting glucose, body weight across all doses, and up to 90% of patients are achieving A1C below 7, and up to 30 to 50% of patients are undergoing diabetes remission. This is going to be a remarkable benefit that we are going to see in our patients, and no hypoglycemia, significant weight loss compared to even bariatric surgery. GI tolerability is established already, with good glycemic control, reduction in body weight, and tolerable GI effects compared to other GLP-1. And recently, the study was published recently looking at renal outcomes. So SURPASS-4 trial, they did a post-hoc analysis showing that significant reduction in renal outcomes similar to SGLT2 inhibitors, I think, and this is in comparison to patients on insulin. So this is of interest right now, or even the GLP-1 molecule has some renal protection, so this is being addressed. Possibly some direct arterial benefits are also being proposed, and along with improvement in A1C. So this is of interest in our patients with renal disease. And as I mentioned, median time to reach A1C compared to other drugs here, you're seeing at 4 to 8 weeks, we are seeing an absolute improvement in HbA1c within 2 months in most patients, and compared to 12 weeks in semaglutide and 12 weeks with basal insulin. So, and the glycemic control is irrespective of baseline A1C, above or below 8.5, irrespective of the duration of diabetes, and significant reduction in energy intake and fat mass. And this is of use when people have fatty liver and non-alcoholic steatohepatitis, improvement in insulin sensitivity, and improvement across multiple aspects of beta cell secretory functions, which is very encouraging. This has been studied as a monotherapy as well. We are seeing similar benefits. And again, no interaction with antibodies, etc. And this is also now being trialed as a medication for obesity, even when the patients do not have diabetes. So this is a once-a-week treatment, a trial published in July in New England Journal. Again, 72-week trial, 5, 10, and 15 milligram once weekly dosing. We saw significant reduction in body weight and percentage reduction up to 20% with the 15 milligram dose, minimum of 15% weight loss with the 5 milligram dose. And I think at this dose, there is better tolerability as well. So significant improvement in weight loss. Potentially future prospect as an anti-obesity medication. And 90% of patients are losing at least 5% of their body weight, which is quite significant. So this is in comparison against the bariatric surgery. So again, very similar benefits compared to bariatric surgery. This is quite remarkable based on improvement in calorie intake, insulin secretion, glucagon balance, and increase insulin sensitivity. So interestingly, the medication is covering 7 out of 10 mechanisms covered by bariatric surgery. So this is possibly a strong intervention, especially in patients who cannot afford to undergo surgery, and possibly we can avoid the complications of bariatric surgery. And we are also seeing some benefit in liver fat content. This is patients with non-alcoholic steatohepatitis. So there is significant hepatic fat resolution at 52 weeks. So that's another proposed mechanism. Possibly this will be a medication for NASH as well. And there was a recent editorial about tirzepatide versus semaglutide, and we just saw all the comparative benefits. So being known as a complex disease with impaired insulin secretion, increased glucagon insulin resistance, etc., we do know that type 2 diabetes interventions have to be multifactorial or multi-prone. So combining drugs with complementary models of action is common. So we are using a dual agonist now, which is very, very encouraging. We are seeing benefits in insulin response, insulin secretory benefits as well, without hypoglycemia and profound weight loss. Possibly we're getting FDA approvals for NASH and also heart failure with preferred ejection fraction and also dementia maybe. And we are still trying to understand the full risk-benefit profile. I'm happy to...
Yeah. Thank you, Dr. Nisha, for an excellent presentation about this. It looks like some wonder molecule. Just 2-3 small questions I'll ask you. Diabetes remission, you told about this from this molecule. Then correlation between weight loss and HbA1c. And any idea when it will be available commercially?
So in the US, it's already available. I'm in Canada. So
Yeah.
Yeah, in the US, it's already available. And in Canada, we might start using it in the next 2-3 months. And the feedback I'm getting from my American friends is really excellent. Whatever benefits we are seeing in the trial is being translated to real world. So we're, even patients taking 100 units of insulin have been able to stop their insulin.
Yeah, that's good.
What about the side effects, Dr. Nisha?
Side effects are the same. I mean, there's no similar to semaglutide, nausea, vomiting, diarrhea, similar. They do tolerate. We have to start slow, and sometimes, I mean, I have literally like hundreds of patients on semaglutide. Sometimes the exaggerated GI side effects are due to underlying. I send them for endoscopy. There's H. pylori, hiatus hernia, a lot of other things, and it's that we simply attribute this to the drug. It kind of gets exaggerated when they're on the medication. So we have picked up things like that, and there is like some proportion of patients do stop, so that we can't.
Dr. Nisha?
Just like oral semaglutide, you had to increase by stepwise, by starting with a low dose, wait for 4 weeks, and then increase it subsequently.
Exactly. Yeah.
Dr. Raka, you want to?
Any off-label use in type 1 obese diabetics?
Yes, so the GLP-1 molecule is being used. It is a well-known treatment now. We are all using it now, and I mean more so in the in the US, and I am also using it off-label because a lot of these patients that we know are obese. So, and if they've had pancreatitis or severe issues before, maybe hesitate, but otherwise, you have to have that honest conversation with the patient. And we've seen at least 100 clinical trials with GLP molecules, thousands of patients, and there is no real concern about pancreatitis. And even if somebody has had pancreatitis before, let's say due to hypertriglyceridemia, gallstone, if that has been corrected, careful use of GLP-1 is recommended. And of course, as you asked, type 1 diabetes for sure.
Cost in US?
US is different. Here it's around, like if you translate to Indian, it's 10,000. So Ozempic is 10,000 rupees per 10,000 to 11,000 per month. And they haven't told us about the cost of tirzepatide yet. I think it'll be comparable to Ozempic.
Yeah.
Because they're competing, right? So.
Few words about reversal of diabetes with this molecule. Reversal of diabetes with this molecule.
Yeah, trial. I mean, this is one thing that is being touted as a potential benefit of this drug, right? And we possibly will see a lot of, even with semaglutide, we have seen patients, and they're also trying to use this medication in people with pre-diabetes to prevent progression to diabetes. So that's a little bit of extrapolation, but that's also being discussed as, yeah, and we're going to definitely see reversal. I mean, again, the question is whether do we stop the medication, then, there will be rebound weight gain. That's going to be an issue similar to pediatric surgery or any intervention, right? How long do we continue the treatment? So that's something we need to know. Is it going to be a lifelong thing? A 50-year-old patient starting these medications, you stop after 5 years, then you see again rebound weight gain and stuff like that. That part is interesting.
Thank you, Dr. Nisha. That was an excellent presentation about the new molecule. And thanks for taking your time out from Canada and speaking to us today and being a part of our conference. I'm sure last month you were in India, I believe, in Kerala.
Yes.
I saw you receiving a lot of awards from your school and colleges.
Thank you. Yeah.
Congratulations. Yeah.
Thalaiva's eyes are ever omnipresent.
Over to Dr. Ashwin. Yeah.
Thank you, sir. It's an honor for me to be a chairperson on this final session. Thank you, Aravinda sir, for giving me this wonderful opportunity. Without wasting much time, let me introduce the again omnipresent speaker everywhere in national and international conferences, well known to everyone, Dr. Rakesh Yohare sir. He doesn't need an introduction, to be very honest. Still, as a part of my job, I would like to introduce him. He's an MBBS MD Medicine, Director, Lifeline, Madhumit.
Ashwin, skip.
Okay, sir.
We are the only
I know everyone know you very well. Still, I thought I'll read a line or two. Yes, you can start your session, sir. Thank you.
Yeah. Can I have the sharing rights, please? My slides are visible?
Yeah,
no. Yeah. Okay. Yeah.
Yes. Yes.
You can start, sir.
I am not getting that slideshow. My slides are visible, na?
Yeah, it's
moving. Walking a tightrope. Yeah, it's visible. Yeah.
Yes, it's moving.
So, at the outset, I am thankful to dear Aravinda Thalaiva for giving me such a topic. Although I am not an insulin pump expert, but I need to talk because it's an order. It's an order from the boss, so I need to talk. So, advances and update in insulin pump. I'll try to brush up as early as possible. We are at the end of the session and Thalaiva is almost exhausted. So we'll do the justice to the topic, and being not an expert, I'll try to give the best and the best possible methodologies. We are really in bad old days of diabetes when we were having HbA1c of 11 and 12 in our type 1 diabetic patients. But with the advent of all kind of technologies, and it's very difficult, it's like walking in a tightrope with hyper and hypos coming in and coming down, and we have to balance. The ultimate goal is full normalization of glycemia, and we all know that the ultimate aim is to keep our patient happy. And that's the way we are going ahead. So friends, this is the evolution of diabetes management technologies. And since 1776, when we were doing just urine testing, now we are in the era when we are able to achieve artificial pancreas. And here is the evolution data from 1920 to 2022. We are just celebrating insulin centenary as well as so many advances. And there were a green period and great period of historic approaches when the people had shown great thoughts in converting into technologies and coming up with the help of so much amalgamation of scientific knowledge that there we are getting towards closing the loop. It was first insulin pump introduced in 1960 by Los Angeles physician named Arnold Kadish. How cumbersome was the pump? He has applied on himself and tried, And first successful study of pumps in type 1 diabetes were shown that there is reduction of normal plasma glucose in juvenile diabetes by using such kind of fancy things. And it was just surprise to that time. In so much advances coming on, we are just going ahead by ahead. And the type 1 diabetes exchange clinical registry has shown that pump lowers A1C, pump tackles diabetic ketoacidosis and prevents patients to come to the hospital admission. Pumps lower the severity of hypoglycemia. So it's beyond doubt. It's our job that we should counsel every of our type 1 diabetic patients and make our India such type 1 diabetic free, complication free world. Because of these advent and there is a lot of gap between the conversion of these patients. We know that very well. So journey to the closing of loop since from 2006, where the Medtronic has the past of first Minimed paradigm pump, and now we are in 780G, where we have added addition of meal detection algorithm, and which has a clear-cut picture to detect to accurately, and even they can alter bolus, and they can manage bolus, they can manage basal in automated manner. So CGM, that is continuous glucose monitoring system, is the backbone, which has lays the groundwork of automation of pump insulin delivery. And it's like behaving as a artificial intelligence working and driving your car. Because whenever the pump automatically detect that there is insulin going towards, that sugar is going dip, that is automatic suspension of the machine. When the driver sees that there is a chance of accident, there is a brake, auto brake, and that's it. It works like that. So it's a pre-crash safety alert system which has been drawn and which has given a boon to this kind of system technologies. And that's why our chances of getting more and more better insulin pumps. So that's why we say that necessity is the mother of invention, and novel thoughts and scientific knowledge is the father of invention. And the tuning and retuning and refining is the kids of invention. So that's why we need to refine and give the personal choice, and as much as possible, we can create a bionic pancreas. That's why we are coming with newer systems and newer system and newer system. The SmartGuard suspend before low suspend insulin delivery module, which has been applied in 640G Minimed system, has changed the total paradigm. And there is SmartGuard suspension insulin when sensor glucose is approaching towards a preset low. There is a preset low automatically devised in the machine, and when it senses the graph of sugar coming down, it just suspends that machine, and there is delivery of insulin is stopped. So now Minimed 750G, 640G system with SmartGuard technology has shown that there is maximum patients, 75% of the patients are now reaching towards the time in range. With the backup of CGM, we can calculate that. So the journey of closing loop, we are going ahead slowly with this technological advancement. And now we are coming towards the hybrid closed loop system, which is looking similar to sensor augmented pump. Here we have a glucose sensor, transmitter, infusion site, insulin pump, and they all are giving sensors to each other, and there is a closed loop, and this closed loop is the ultimate goal towards bionic pancreas, because they have to work in toto and together with an harmony so that they can detect the sugar and they can act on it. So it's automatic brain acting in with that machine. Here, how it works: auto basal did adjust as per the sugar level, and fall of sugar level and rise of sugar level. They suspend the machine and they check the CGM profile of the patient. They sense that how much time they will go in hypo, and they just automatically on off that machine. So this is the best way, because if you are giving a smooth rhythm in any kind of body organ, whether it's pancreas, whether it's cardiac, these are the arrhythmias. If sugar arrhythmias occurs, then you have a crash of system. That's why you are just giving a best non-arrhythmic cycle in sugar pulsations. So this is the way, and this pivotal trial publications in type 1 diabetes published in 15 September 2016 have shown that the glucose outcomes with in-home use of hybrid closed system insulin delivery system is shown better outcomes. And these trials in 10 sites in 9 and 1 site in Israel, they have given inputs that these pumps will change the life of type 1 diabetic patients. So the journey of closing the loop continues, and now Medtronic has given a 780G, which is addition of meal detection algorithm. And what it has done, it adjusts, it corrects glucose level every 5 minutes as needed, and it lowered default target of 100 milligram per deciliter. So if sugar goes 120 above 130, then there is auto correction. So auto correction of bolus and auto correction of basal insulin have been particularly designed, and it has been kept as comparable to the carb counting, and everything is intelligently created in this system. That's why basal insulin auto basal determination in individual insulin needs and automatically adjust insulin delivery every 5 minutes. And these correction bolus don't give the patient such kind of needing manual correction, rather than it can correct automatically. So these are like brain acting. A patient is behaving like a robot, the machine is behaving like a robot, and patient is comfortably free from any kind of complications. So 780 adjusts and corrects glucose level automatically 24/7. And how see the automatic bolus within blue graphs. These are the green graphs showing the sugar rise. Then there are 2 automatic bolus. Once the sugar rises to 120, there is automatic bolus in the machine. And see the graph, CGM graph. So most of the patients in these trials of these pumps has shown that 70% of the time HbA1c is reduced, then 7%, and time in range has improved to more than 75%. What a type 1 diabetes person can need from a machine. This is the best way that 47% of the subjects are able to achieve that time in range, and 79% of the subjects are able to achieve that in that study period, according to that kind of machine applications and sugar fluctuations. So less work in managing highs. 22% of boluses are auto-corrected, means patient doesn't know, and there is automatic bolus corrections. Patient satisfaction, it's almost less effort in managing highs and glucose, and 72% patients remain calm. So there is automatic rise in happiness quotient and belief in the therapy. And belief in the therapy as well as the harmony of the patient is the best thing which we can give to a patient of type 1 diabetes. So smartphone connectivity for greater convenience and peace of mind for the patients. It has developed Minimed mobile application where they can go and display pump and CGM information on a smartphone. Then patient can easily review the time in range data. For the patient's caring group, healthcare professional, the data connectivity, where from CareLink Connect app, they can allow their care partners to view the real-time pump and CGM and can tackle and see the patients who are having brittle diabetes or who need care from and connections from their healthcare care professionals. Remote follow-ups can be done, and automatic uploads of the patient data. Virtual visit to the clinic can be done through that machine and connectivity with gadgets. So these glucose management indicators have phenomenally changed the paradigm of care of type 1 diabetes. So there is just a good amalgamation of technology, best way of taking care with the use of artificial intelligence, and that's the journey of closing the loop goes on, so that we can land up and may be able to create bionic pancreas. Bionic pancreas is just a few years to the friends that we will be going to see this. The basic challenges in bionic pancreas is that how we'll imply this bihormonal secretion, because a pancreas, if it has to be changed, should be having an insulin and glucagon. And that's why integrated continuous glucose monitoring, fully automated methods, controlled algorithms, when insulin will release, when glucagon will release, insulin bolus priming changes, breakfast, lunch, and dinner, size of the meal, more than usual, what is less than usual, what are the bites, and these all things has to be taken in consideration. And that's that's why these studies on this bionic pancreas with dual hormone artificial pancreas has shown that effect of bionic pancreas on glycemic control is very nice. And they have shown that in adults and adolescents, that time is spent with less than 70% of the time is in time in range with bionic pancreas. And conventional pump therapy compared with single hormonal artificial pancreas means having only insulin. With dual hormonal artificial pancreas means having both glucagon and insulin. And they have shown that results are quite enhancing and encouraging. So technological effect on time in range, we can see here in this colored graph, the technological effect on time in range, how they have changed from SMBG to bionic pancreas. But you can very well see that smart guard suspend before low 6 and that bionic pancreas has almost equivalent results. So there is so much hurdles. There are future questions that how we'll be using bihormonal pancreas, because something needs to be answered in future. And these are the practical challenges in future questions. Whether it is justifiable to add glucagon to the artificial pancreas is a challenging question, and answers are needed in further research. And single hormone and the dual hormone systems are yet to be compared in large and longer studies with important endpoints such as evidence of severe hypoglycemia and HbA1c concentrations. So the dual hormone system will likely to reduce hypoglycemia, can counter hypoglycemia by releasing glucagon, potentially improving quality of life, but it also necessitates an additional catheter, an additional drug manipulation, an additional algorithm, and an additional artificial intelligence. So thank you, sir, for patient hearing. We have insulin. Now we need its best toolkit. Insulin pumps are the best toolkits. We have the ray of hope beyond any scope. So that's why this is the ray of hope. We need to justify, we need to give our patients, and we need to make it profitable to our patients as early, as bad, as easily to possible to every of our type 1 needy patients. Thanks, Talaiva. Thanks, Arvinda, for giving me this opportunity to talk on this technological advancement. Although I am not a technology expert, but he has made me today that expert.
Thank you, sir, for the wonderful session. I see that you've taken over Jyotidev, sir, talking about insulin pumps. Maybe in future, you will become our technology expert number 2.
Yes.
And it was a wonderful session, enlightening session. I don't see any questions in the chat box. I think sir can take over from here.
Yeah. So there was an stimulating session by Dr. Raka. I was stimulating you to become a tech person in future. So that was a nice discussion. So by this, from ADC as well as Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2020, I wholeheartedly thank Dr. Kashinath Dikshit, Dr. Ashwin Mukundan, Dr. Nisha Nagil, and Dr. Balaji Jaganmohan, and Dr. Raka for your valuable time and being a part of our conference. Thank you so much.
Thank you.
Before that brings to the end of the session and the end of the conference in Hall A. So that is, thank you so much for all your active participation. Neelam, can we have that thanking video, please?
I think Dr. Jumani lecture is
everybody. Jumani is in flight.
Yeah, outset, I thank wholeheartedly all the faculty members, delegates, pharma peoples for being a part of our conference. So we had an excellent 2 days conference, a virtual conference, which was well attended across India as well as across the globe. I'm happy to share that we had nearly 2012 registration across the globe. It was an excellent scientific extravaganza, which was appreciated by one and all. I personally thank our orators and keynote speakers, Professor V. Mohan, Professor Shashank Joshi, Professor Anup Mishra, Professor Kamlakar Tripathi, and Dr. Banshi Sabu for their wonderful deliberation and oration and discussion, which was much appreciated by the faculty members and the delegates. And I thank all the faculties for their wonderful participation and wonderful presentation and the discussion, which was well appreciated by all the delegates. Any conference will not be successful without the delegates. So I wholeheartedly thank all the delegates who participated actively across India and took active part in the discussion as well. Without pharma people, no conference will be successful. Their support means a lot. I thank wholeheartedly all the pharma people, especially USV, Micro, Novo Nordisk, Sanofi, Abbott, Biocon, Sun Pharma, Eris, Intas, Pocard, Torrent, Serdia, and Mankind for their active participation in our conference. I thank Mr. Banu, who actively supported me in this conference for in the preparation. I thank Dr. Shweta, who participated in coordination of our conference. Not but not least, Dr. Hardik and the RX events team for their successfully managed program through their event page. Dr. Neela, who is the wife of Dr. Hardik, Dr. Nirav, Mr. Neela, for their involvement in the success of the conference through the event managed. I wholeheartedly thank one and all. Thank you for your wishes and blessing. Hope to see you all in person in next year ADC International Diabetes Summit 2023 physically. Thank you so much.
So thank you everybody for being a part of our conference. It was a pleasure and a very nice 2 days of scientific discussion with with loads of fun. That was important. It was not only the scientific things. We had a good interpersonal relationship exchanges. That was the most important thing. All of us were in a jovial mood with the scientific background. So that was the most important thing. I wholeheartedly thanks all of you for being part of our conference. Next year, hopefully, if everything settles, we should meet definitely. Neelaman team is the main thing.
Yeah, I know.
And excellent time management. That's the key to success of any program.
Yeah, that's
excellent time management.